There will be 3 people. Emergency loan. It's maybe a
Check 1, 2, 3. Hello? 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 Check 1. Sir.
Lighting change किया कलर
I went. I'm sure.
Recording in progress.
Good.
Hello. Hello. Audio check. Hello.
Hello, hello.
A very good morning, everyone. Yeah, I think everybody is settled. We're expecting more people to come, but this being a Sunday, we can expect some delays. Very, very good morning, and I thank all of you for attending this CME early in the morning on a Sunday. The brainchild of lung Instagram has come from the Department of Pulmonology, Yashoda Hospitals, Malakpet, in order to integrate clinical approach with pulmonology and radiology, so that our practice enhances. And that is because we have learned a lot through our practice by our mistakes, and we wanted to share it with everybody. That is the main theme and motto behind this conference. I am Dr. Vamsi Krishna, Organizing Secretary of this Lung Instagram, a consultant pulmonologist at Yashoda Hospitals, Malakpet, and along with me are my team, Dr. Yugandhar Bhattu sir, HOD of Pulmonary Medicine, Yashoda Malakpet, and Dr. Satish Reddy, pulmonologist at Yashoda Malakpet. All three of us have ventured into this CME only to share knowledge and to show as to how we see at cases, how we approach at cases, what we have learned over our course of journey, whatever experience we are having in handling with cases, we just wanted to share it with our medical colleagues, be it any branch, because radiology is important for every specialty in medicine, starting from MBBS practitioners to the super specialty practitioners. Radiology is an integral part, and radiology is not something which is confined only to the radiologists. Every specialty should have an idea about the radiology of their system. For example, pulmonology, chest radiology should be there. There are oncologists here. Oncologists should be having the radiology knowledge of almost every system of the body, because they deal with patients of various types of cancer. And so radiology is an integral part of clinical practice, and inculcating the right radiological skills will give us more confidence in clinical practice, and more importantly than that, will help the patient to the maximum possible extent, and will change the course of treatment in some special cases and might save some lives. So with that introduction, I would like to start the Lung Instagram CME now. So we have 3 DNBs with us, and we believe teaching is also very important, and we are responsible as teachers to make our DNBs as future speakers. And so we have inculcated one of our DNB resident, Dr. Megha Varghese, to give the first talk on the basics of lung imaging modalities. So we'll start the CME with Dr. Megha Varghese, who will be presenting on the various lung imaging modalities. Welcome, Dr. Megha.
A very good morning to all the faculty, dignitaries, and all the delegates. For the first session, I would like to introduce the chairpersons to take over the seats to chair the session. First session would be every image has its own story. I now introduce Dr. Yugavir Gaud sir to chair this session. Sir is a consultant pulmonologist at Kim Sunshine Hospital. And I now introduce Dr. Lakshman Babu sir to chair the session. Sir is a consultant interventional pulmonologist at Kim Sunshine Hospital. And Dr. Krishnamurthy sir. Sir is a professor and head of the Department of Gandhi Medical College, Secunderabad. Welcome you, sir. I now hand over the mic to Dr. Megha for the first topic.
A very good morning to all. So all the respected delegates, faculties, my teachers and residents and all who have gathered here. As sir told, I'm very much blessed to be here to get an opportunity. This is such a big opportunity to have a talk in front of all these great speakers. So as this is a case-based pulmonoradiology masterclass, I'll be dealing my topic, that is lung imaging modalities, in a case-wise manner. So to start with, I'll be starting with the very basic radiological modality we routinely use, that is chest X-ray. So chest X-ray is the most frequently performed radiological investigation. Indications are to rule out respiratory diseases, infections, pneumonia, TB, pneumothorax, cardiac diseases, evaluation of symptoms related to abdominal pelvic pathology, etc. So it has mainly three projections: chest X-ray, posterior anterior view, anterior posterior view, and lateral view. Just let me tell you a basic difference between PA view and AP view. PA view is usually taken, it is taken in erect posture, standing position, scapula not overlapping lung fields. There is no cardiac magnification, fundic air bubble seen. In AP view taken in supine position, there will be scapula overlapping lung fields, cardiac magnifications will be there, and fundic air bubble not seen. So to compare the two images, that is left one is showing chest X-ray PA view and the second one is chest X-ray AP view. These both are normal chest X-rays. So to start with, let me start the first case. This is a case of a patient who presented with shortness of breath. Chest X-ray showed, chest X-ray was taken and as you can see there is a mild shift of trachea to the left side. Also noted there is an opacity in the midline which could be the cause of tracheal deviation. On careful history taking, we came to know that the patient had a history of left hemithyroidectomy for goiter done in the past. So followed by the X-ray, we have taken a CT chest with neck. CT chest neck showing an enlarged thyroid compressing the trachea, causing the tracheal narrowing, which was the cause of shortness of breath in this case. So next case, as you all know that X-ray we are using to diagnose the diseases. X-ray we can use as a modality to assess treatment response also. As in this case, this patient presented with loss of weight and chronic cough. Chest X-ray showed bilateral millet seed-sized nodules. So diagnosed as a miliary tuberculosis, sputum was positive for tubercle bacilli and ATT was started. So second picture is this. It's a follow-up chest X-ray after 3 months of ATT. You can see an improvement in lung fields with clearing up of nodular opacities. So X-rays can also be used as a modality to assess treatment response. So till now I was telling about chest X-rays only. So there are other radiological modalities we can also use in our practice to diagnose diseases like. This is an X-ray PNS view. This is of a patient who presented with cough for 2 weeks. Chest X-ray was normal. So we suspected a pathology elsewhere. So we did X-ray PNS. Here we can see an air fluid level in the right maxilla suggestive of right maxillary sinusitis. So it suggests that a patient coming with a chronic cough need not have a lower respiratory tract infection. We also need to rule out an upper respiratory tract cause. So it is very much advisable to advise in our daily practice to advise chest X-ray PNS view, or PNS also in patients who are having chronic cough. So next is another, so far we have seen some plain radiographs. Additional modification can be done on a plain radiograph by using contrast medium like barium sulfate also. So next I will be talking about a barium study. You may be thinking that why barium study is important in a pulmonology practice. So it can be used as a modality to rule out the same scenario with a patient coming with a chronic cough, to rule out GERD causes hiatus hernia or a tracheoesophageal fistula. So let me tell some basic about the barium study. So barium study is, as I told before, it's a contrast-based study. The contrast barium sulfate is ingested and radiograph taken. Indications are it helps to identify pathologies involving pharynx, esophagus, stomach, small intestine and large intestine. There are four types of barium study: barium swallow, barium meal, barium follow-through and barium enema. So this is a normal barium meal study. This we done to rule out a patient who had a chronic cough to rule out GERD. So indications of Bare meal study in our practice is GERD, hiatus hernia, and tracheoesophageal fistula. So up to this time, I was talking about X-rays only. Let me step one more up to an next advanced imaging modality that is nothing other than computer tomography, that is CT. So CT it is a mainstay of diagnosing, imaging, evaluation of thoracic disorders. However, there are a number of CT protocols ranging from a simple non-contrast CT at one end of the spectrum, and CT perfusion as a complex protocol available only on high-end scanners. With the growing diversity, there is a pressing need for radiologists and clinicians to have a basic understanding of the recommended CT examinations for individual indications. So this topic I'll be dealing with different kinds of CT, different views, different sections, prone view, supine view, on a case-wise manner. And further, I will also be dealing with contrast-enhanced CTs also. So as I told, regarding non-contrast CT, there are, based on radiation dose, we can classify a non-contrast CT into standard dose CT, low dose, and ultra dose CT. The indication for all these CTs are indication for all this of the CTs are nearly same only. The radiation dose differs. In standard dose CT, radiation dose being 3 to 8 millisievert units, low dose CT 1 to 3 millisievert units, and ultra low dose CT is less than 1 millisievert unit. Low dose CT, as I have written, the indications of low dose CT are ILD evaluation in lung cancer screening, follow-up imaging of ABPA, cystic fibrosis, and bronchiectasis. Ultra low dose CT indications are lung cancer screening lung as a part of coronary CTs. So what you're seeing here are two CT images of chest. The first one of your left is a normal CT, that is a plain CT, and the second one is an HRCT. As you can see, the HRCT image provides a better details about the lung parenchyma, and definitely it is superior to the left image, that is a plain CT. Coming to HRCT chest proper, it obtains images with exquisite lung detail, which are ideal for assessment of diffuse ILD. The technique used is, they use thin size chest images, which are post-processed in a high spatial frequency reconstruction algorithm. Thin sections defined as less than 1.5 mm with an interval of 1 to 2 cm between two sets of images. The collimation here is 1.5 to 3 mm. Patient position is supine or prone. Usually it is done in a full inspiration phase. So this is an HRCT chest. Indications of HRCT chest in a routine pulmonary practice is ILDs, bronchiectasis, cystic lung diseases, smaller airway disease, and pulmonary micronodules. So let me explain HRCT chest with another case. So this is a case of a patient who presented with cough and shortness of breath. On auscultation, velcro crackles were there over the basal lung fields. HRCT was suggestive of bilateral honeycombing. So in this way, the HRCT chest was able to identify honeycombing and thus interstitial lung disease, which is the classical feature of interstitial lung disease. So up to now I was talking about CTs in an inspiratory phase, but there are circumstances we need to do CTs in an expiratory phase, where and all. In patients who are cases of airway obstruction, so we need to we need to visualize, or we need to detect the air trapping, which is more evident in an expiratory phase. So expiratory scans, these scans are mainly acquired in cases of suspected air trapping, small airway disease, or tracheobronchomalacia. Whenever there is appearance of ground glass opacities, mosaic pattern on routine non-contrast CT, or suspicion of an airway dominant disease, it is necessary to acquire an expiratory CT. So the first A image is an inspiratory phase CT, and the B image is an expiratory phase CT. So expiratory CT performed in low dose shows multiple areas of air trapping shown by the black arrow. So compared to the left side image, the mosaic attenuation is minimal, but it is more evident in the right side expiratory phase. So expiratory phase CT can also be used in another case scenario where here this is a patient, elderly female with 2 months history of shortness of breath, saturation was low, on auscultation bilateral velcro crackles were there. We proceeded with CT chest suspecting an ILD. So the left side image is showing HRCT chest in an inspiratory phase, and B is showing an expiratory phase CT. So you can see that the air trapping and mosaic attenuation is more evident in the second CT, that is expiratory phase. Thus, we are able to identify the 3 density pattern or head cheese sign, that is hypo-attenuated areas, air trapping area, the hyper-attenuated areas, ground glass opacities, and the normal lung pattern. So, in a patient whom we are suspecting of an airway trapping, airway obstruction, or a patient suspecting of a fibrotic hypersensitive pneumonitis, it is advisable to go for an expiratory phase CT also. So up to this now I was talking about, I am showing in CTs with axial cut only. Let me explain about the sagittal and the coronal view with another case scenario. This is a patient, male patient, obese patient, came with presenting complaints of shortness of breath on exertion for more than 6 months. So 2D, we suspected pulmonary hypertension, but 2D echo was normal. So the pathology was elsewhere. So CT chest was followed. CT axial cut was inconclusive, and CT chest sagittal section showed tracheal narrowing. Next is the coronal view of the same patient, that also showing significant tracheal stenosis. So on careful history taking, we identified that this was a patient with a previous history of intubation 2 years back. He had been intubated for 10 days followed by tracheostomy. He had been tracheostomized for 20 days followed by decannulation. So this is a patient of a post-tracheostomy tracheal stenosis presented with SOB on exertion. So in this way, sagittal section and coronal view were able to diagnose the tracheal stenosis. So I am explaining coronal view with another case scenario. This is a non-case of ILD. CT chest showed coronal view showed honeycombing. The advantage of coronal view in a ILD case is that the disease distribution is very much important in classifying ILD. Here the disease distribution pattern is better identified with coronal view. Whether it is upper lobe predominant, diffuse honeycomb, diffuse pattern, or it is lower lobe predominant. So likewise we are able to classify ILDs with the coronal view. So this is chest CT done in supine and prone position. As you can see in the left side image, which is a supine position image, we can see ground glass opacities in the posterior basal segments, but we are not sure whether it is, the pathology is actually there or not. So to rule out that, we have done the CT in a prone position. We can see that there is clearing of ground glass opacities in the prone position, which indicates that this was not actually a pathological ground glass opacity, it was just because of a dependent density. So next, this is an interesting case. The patient is a non-case of asthma with a worsening cough. So his asthma symptoms were not controlled with regular medication, so suspected ABPA. CT chest done showed a patchy opacity on the right side. You can see it is a mediastinal window. Here we try to compare with the attenuation. So the attenuation of the opacity is compared with the attenuation that of skeletal muscle. It is seen that it is almost similar, 38 and 39 is almost similar, which indicates that the opacity contains a high attenuated mucus, which is pathognomic feature of ABPA. Thus, just by comparing an attenuation in a mediastinal window, we were able to radiologically diagnose ABPA. So up to now I was talking about non-contrast CT also, or non-contrast CT only. So let me step one more step up, that is contrast enhanced CT. So here we used various contrast media which are available for use in contrast enhanced CTs. For routine contrast enhanced CT, iodine concentration of 300 to 350 milligram iodine per ml suffices, whereas in CT angiography protocols a higher concentration is needed. The dose of contrast to be administered depends on the weight of the image. Indication for a contrast CT are to assess for vascular and nodal pathologies. Let me explain contrast CT with another case scenario. This is about a patient who presented with SOB on exertion. You can see the ratio of pulmonary artery to ascending aorta is more than 1, which indicates that there is a high pulmonary artery pressure suggestive of pulmonary artery hypertension. So the cause of SOB on exertion for this patient was pulmonary artery hypertension, which can be easily radiologically detected by contrast enhanced CT. This is another contrast enhanced CT angiography. It is used mainly for it's a primary. The focus is on systemic circulation, that is aorta and its branches. CT angiography of thorax is essentially performed in 3 scenarios. First one is evaluation of hemoptysis, which also includes pre-procedural imaging for bronchial artery embolization. The concept is that for bronchial artery embolization procedure to be successful, there should be a bronchial artery collateral for the pathology site, and if the multiple collaterals are there, the bronchial artery embolization procedure won't be a successful one, because hemoptysis can recur from the other collaterals also. Another indication is suspected aortic dissection or aneurysm. Third indication is demonstration of anomalous artery in congenital lung malformations, example sequestration.
2 more minutes.
So next is, so I am explaining the case CT angiography, CT aortography with another case. It is a non-case of pulmonary TB present with massive hemoptysis. CT chest showed left upper lobe cavitatory lesions. Bronchial artery embolization was planned. So as you can see, that CT aortogram showed multiple calcific collaterals, so which indicates that this bronchial artery embolization won't be successful in this patient, and this patient was actually then managed conservatively only. Next case is another case. It's an interesting case. A 15-year-old male presented with recurrent respiratory tract infections. Chest X-ray showed left lower lobe consolidation, followed by CT chest, which showed a mass-like lesion in the left lower zone. CT angiography was done. You can see the mass-like lesion getting its blood supply from thoracic aorta. So this was a case of lung sequestration having its anomalous blood supply from systemic arteries. So next is CTPA, CT pulmonary angiography. Based on the detection, it is based on detection of filling defects in the pulmonary arterial vasculature. Indications are suspected pulmonary embolism. Contraindications are as this is a general contraindication for all contrast enhanced CTs: allergy to iodinated contrast and renal failure. So the left image is a normal CTPA with no thrombi. The right side image showing a saddle thrombus sitting over the right and left main pulmonary artery. So in such scenarios, a patient would present with acute SOB, chest pain, hemoptysis and tachycardia. So it is advisable to do CTPA at earliest and as the very first imaging. No need to go for first CT chest and then CTPA. So as I am talking about pulmonary thromboembolism, I think it is also necessary to include some description about a V/Q scan. This is a ventilation perfusion scan. Indication is This is done in pulmonary hypertension cases to evaluate for the cause of pulmonary hypertension, that is chronic thromboembolic pulmonary hypertension. Here we do ventilation as well as the perfusion scan. There are ventilation perfusion match scenarios and ventilation perfusion mismatch scenarios. In a patient who is a patient with an airway obstruction, there will be regional vasoconstriction. So there will be ventilation defect as well as perfusion defect in the same site. So it is a matched V/Q scan. In patients suspected of thromboembolism, there will be mismatch in the ventilation perfusion scan. Ventilation will be normal, but perfusion will be mismatched. This is an image of a patient who is a non-case of pulmonary hypertension. We evaluated to rule out CTF, but the perfusion scan was normal. So I was talking about pulmonary thromboembolism. Let me also talk a few words about the necessity of a bilateral venous Doppler. It is very advisable in a routine practice to advise bilateral venous Doppler in patients suspected of pulmonary thromboembolism, especially in patients who are bedridden for a long time, ICU patients, sepsis patients, or patients who are in hypercoagulable states like malignancy. So this is
Sorry to interrupt. We are running out of time.
Okay, sir. This is the last, sir. This is a whole body PET CT scan. So here, a standard uptake value is calculated at the end. SUV more than 2.5 is considered abnormal. Let me explain this with a case scenario. This is a 16-year-old male who presented with fracture femur following trivial trauma. So we suspected a pathological fracture. A chest X-ray was showing an irregular nodule in the left upper lobe. PET CT was done, which showed FDG avid metabolically active lesion in the left upper lobe. So the fracture site biopsy showed adenocarcinoma. So thus this patient was a case of primary lung malignancy adenocarcinoma with the bone mets, which was the cause of pathological fracture. So let me conclude my talk with a note. Radiological investigations are cornerstone in the diagnosis of pulmonary diseases. Hence, having a basic understanding to the techniques and principles of various scans would help us clinicians to choose wisely from a plethora of radiological investigations. Thank you.
It is difficult to include all the things in more than 15 minutes, I know. This one. So shall we take questions after that or after the session? Yeah. Right.
Thank you. Next speaker is Dr. Other than Dr. The organizing chairman itself, Dr. Vamshi Krishna Mutnuri. Right now he's the consultant interventional pulmonologist at Yashoda Malakpet. He did his MBBS from Ashram Medical College, then completed his MD from Andhra Medical College. He had his European diploma in respiratory medicine and MRCP in respiratory medicine. His special interest is in sleep medicine and ILD. Now he'll be talking about OPD decision making, the right choice, right diagnosis.
Good morning, everyone, once again. I think my introduction slide has gone. So let me start straight away with the case. So OPD decision making, the right choice, the right diagnosis. I have chosen this topic and designed this topic only to pass the information that whenever a patient comes to us in the OPD, Most of the times the patient might be seen seeing many doctors, physicians at different levels, primary, secondary, tertiary care levels, and they might also be coming for the first time, but they might be having previous investigations, they might be having a lot to tell to you. But your focus has to be on as to what is the proper history, what best we can do for them in the least possible investigations. That is what is the theme of this title. So this is a case of middle-aged male presented with hematemesis to the gastroenterologist from 5 days, and their upper GI endoscopy was done by the gastroenterologist. There are no complaints otherwise, absolutely. The endoscopy was insignificant except for blood near the vocal cords, for which he was referred to me to rule out if the hemoptysis is from the lungs. So what I asked is a basic chest x-ray, because I asked him to get a chest x-ray and done when they called me, so that I will have an idea as to what might be the problem. So this chest x-ray shows a slight lower lobe haziness. Don't work, huh? I think it's not working on the screen.
On screen not working.
Yeah. Yes, sir. So you can even the cursor is not working. That's okay. The thing is that you can see a slight haziness in the right lower lobe. And the first question which I asked him after seeing the X-ray is, are you sitting for a long time these days? And the patient said that he is constructing his house and is sitting for 7 to 8 hours a day continuously. And he used to be a cab driver and used to drive for 8 to 10 hours a day. And the next thing I did was I asked him to stand up and just, examine his calf muscles. I could see that his calf muscle, one of the calf muscle is swollen and it is taut. And when I tried to palpate the calf, he removed a cloth from his popliteal fossa. And then I asked him, why did you tie a cloth? He said, I have some pain in the calf. And then I asked him, do you have any pain in the chest? Yeah, there is a nagging pain on the right chest side. So these are the deep probing history points which are important for us, because the X-ray is, there can be anything possible, like more history will help. Clinical examination, the patient was almost insignificant, the chest was clear. Whether it is hematemesis or hemoptysis, we don't know. The patient was saying that he attended a dawat recently and he was having gastritis, and because of that he's having blood, and he ignores whatever questions I'm asking, and he complains that his pain has been long standing in the calf and doesn't matter at all. In spite of all that, we have to be focused, and this can be a community-acquired pneumonia as well. Pneumonias can present with hemoptysis. It can be COX. The history might be short, but COX can present in any way, and it can be an aspiration pneumonia. Maybe he had a dawat and aspirated. So there is all possibilities. So what tests will you ask for? Will you ask for a CT chest plain in this case? So with the kind of history in mind, with the kind of slight lower zone haziness, with the calf muscle swollen, the first thing which should strike to our mind is possibly the patient might be having a pulmonary thromboembolism, possibly the patient might be having a DVT, and the opacity what we are seeing is possibly or probably an infarct. So CT chest plain wouldn't help. Contrast CT chest will only give us details about the arteries and would not tell us about any thrombi, and it would be a waste of time and radiation and money to the patient. Sputum test, it is of no value because the patient doesn't have expectoration. Even if he has a minimal expectoration, a sputum test would be inconclusive. And what best test can, give us a straightaway diagnosis is what I felt was a CTPA would give a straightaway diagnosis and a venous Doppler of the lower limbs. This patient did not come back to me. So he went away because he denied that he doesn't require those investigations. He went outside, got a venous Doppler done, there was DVT, and then he came back to me for CTPA and admission. On admission, we did CTPA. If you can see the CT findings here, unfortunately the marker is not working, but if you can see, there was a little bit of any other way of marker. White marker. So what if you can see on the right side in the mid sections on the 1, 2, 3, 4th section, you can see a peripheral pleural based consolidation, and if you can see that there is a bubble pattern in that consolidation. This bubble consolidation is nothing but an infarct. The infarcts usually present with bubble consolidations and they are confused with pneumonias. So here it is evident more nicely. You can see on the lung window and the mediastinal window that there's a pleural based thing, and if you see closely you can see some bubbles inside this, and all patches are not pneumonias. And so a CTPA was done for this patient. There is a thrombus in the right main pulmonary artery. You can see the thrombus in the coronal view also. You can see the RVSP was above 50. It was in range of 54 to 64, and it is possibly a chronic acute and chronic pulmonary thromboembolism. So coming to case 2, the presentation to OPD was with shortness of breath, fatigue, anxiety, a middle-aged female. The chest was clear in auscultation, outside chest X-ray was normal, and routine investigations were done which were normal. So what do I have in hand? I have auscultated her, the chest is clear, there is no wheeze, she does not have history of allergy, she does not have history of asthma, but she has this anxiety since many years, she has this SOB since many years. So the first thing I do whenever a patient seems anxious to me is I will fill up the Nijmegen questionnaire, which will give us a clue about anxiety hyperventilation. And in this patient the score was 39, and any score of more than 23 is suggestive of anxiety hyperventilation. But anxiety hyperventilation very often coexists with bronchial asthma. So we cannot ignore asthma in these patients, and sometimes if in patients with anxiety hyperventilation you are asking for a PFT, the patient might land up in an anxiety and panic attack immediately after doing PFT, and she might have hyperventilation and a fallen PCO2. Some patients also collapse. So it is always not advisable to order a PFT if you are suspecting anxiety hyperventilation in a case of who present with SOB or any history suggestive of asthma, because if there is nothing else and if the patient is complaining of SOB, the most common practice is to consider it as a case of asthma, because PFT or whatever it is not diagnostic of asthma. So here, somehow I was not satisfied, she was not satisfied. So she was continuously complaining of, unable to work due to fatigue, has problem climbing even 1 flight of stairs, has problem combing her hair, demanding job, and suffering from more than a year with many untruthful consultations. In fact, I was the one who asked her if she is having a problem with combing, if she is having a problem in the proximal muscles when she is climbing the stairs and all, because her fatigue seemed to be so bad and she doesn't seem to be malingering at all, and she was very genuine, and she has flown from Odisha to Hyderabad only for a consultation. And that is what made me ask more and more questions out of the box. And so I went for precision testing. I didn't order chest X-ray or a CT scan because I was not sure the pathology was not in the lung. And I asked for anticholinesterase antibodies, which are negative. I asked for ANA profile and myositis profile. ANA profile was negative. Myositis profile showed PMSCL 75 positive. So the thing is that in this case, it is not a radiology based case, but what I wanted to show in this case is that, radiology is not the answer for every SOB, radiology is not the answer for every cough or anxiety or anything. There can be other things also. People complain fatigue as SOB, people complain weakness as SOB, some people complain pain also as SOB in Hyderabad. So here, finally we got a diagnosis. The PMSL 75 is positive and OJ is 1+ positive. OJ 1+ positive need not be taken very seriously. These patients might develop interstitial pneumonias later in life, but 2+ positive of PMSL 100 has to be taken, PMSL 75 has to be taken seriously, because PMSL 100 is usually done in ANA profile, but not in myositis profile. PMSL 75 is not done in ANA profile, which is actually more specific and sensitive for polymyositis and scleroderma overlap. So this patient possibly might be having a polymyositis, and maybe there are no features of scleroderma. I referred her to a rheumatologist. I gave her an option here in Hyderabad and in Vizag because it's near to her. She met the rheumatologist. She's very happy now. Before presenting this case, I pinged her up, asked her how she's doing, and she's doing absolutely fine with rheumatologist prescription and much better now. She is a DSP in the police department and a very dynamic lady. The thing is that only anxiety made me anxious, and sometimes we feel that this is an over investigation, but PMSL 75 is not like ANA, which might be normally positive in some 5% of the population. PML-SCL75 is a very specific antibody, and it is a more recent antibody used by the rheumatologists to rule out a pulmonary polymyositis and scleroderma overlap. So what role does radiology have here? This case is to highlight the fact that all cases that present with SOB are not necessarily SOB. CT test or further radiological testing are not a rule. History and more history and more history and out-of-the-box history are needed in some cases before functional causes are considered or planned for extensive evaluation. Of course, I considered anxiety and functional cause in this, and the Nijmegen questionnaire is positive. She has anxiety hyperventilation, but her anxiety hyperventilation might have possibly developed because of her inherent problem which was not diagnosed since a long time. Coming to case 3, this is a middle-aged overweight male who presented to OPD with SOB and cough since 6 months, and he hasn't shown to anybody since 6 months. Though he was having cough and SOB, he was thinking over it, whether to show or not, whether it is significant or not, whether it because of his overweight, because he gained weight apparently in the recent past. On examination, his chest was clear. The SpO2 on room air was 98. There was no allergic history or history of obstructive airway disease. There is tachycardia on the pulse oximeter, and the lower limbs examination showed varicose veins, but there was no significant swelling, or there is no tautness, or there is no pain on palpation. So what next? We have to evaluate in the lines of obstructive airway disease, we have to evaluate in the lines of cardiac disease, evaluate in the lines of pulmonary disease, or prescribe an inhaler and ask for follow-up. Because this patient has SOB and cough for literally 6 months, and he does not have one positive finding on auscultation. I didn't want to go for a PFT, which would give me nothing in this case, because I was not suspecting OAD. He does not have absolutely any history suggestive of OAD, and he is around 45 years old. His varicose veins were what caught my attention, though there was no significant swelling. So the first thing I did was the road that is usually taken, I asked for a 2D echo and a CT chest plane, so that I can see if there is anything in the heart and in the lung side. It will give me a clue. The 2D echo showed an RVSP of 88 millimeters of mercury. There was moderate TR, severe pulmonary hypertension, RV dysfunction, and the CT reported was air trapping. Basically, it was reported as air trapping, and which usually we think it is probably some COPD or bronchial asthma or some this thing. But the CT chest clues which we have picked up is that, if you can see here in these 3 sections, if you see in the low, on the right side, there is paucity of vasculature, there is hyperattenuation, and in the upper lobes also, and here in the mid zone at the level of Kirana, you can see that there is hyperattenuation, there is paucity of vasculature. And if you closely see along that vessel, you can see a border between the hyperattenuation and the hypoattenuation. Even in that section, you can see that border more clearly. That's a zoomed out view. So hyperattenuation with paucity of vasculature in a patient with varicose veins, I was not satisfied, especially with severe pulmonary hypertension. I was suspecting pulmonary thromboembolism, and so I went ahead with CTPA. Though the patient did not agree with it, and Doppler, I told him that this might be DE and it might be life-threatening. You have to undergo this, and DVT, there is DVT in both the lower limbs, and CTPA was suggestive of pulmonary thromboembolism. This patient had 2 big thrombi in both the right main and pulmonary arteries, and if you see on the left side, if you see the arteries, unfortunately the marker is not working, but if you see this thing here, there is lobulations along the pulmonary artery. There are lobulations of thrombi. This is very much suggestive of a chronic thrombi, which are evolving over a period of time. They are forming in the calf, and they are coming into the chest, and they are passing through the pulmonary vasculature. And this fellow is fortunate enough to live for 6 months, and he has got used to it. And the heart has endured so much, and he had developed pulmonary hypertension, but not having developed a life-threatening event. So the thing is that this is an acute and chronic pulmonary hypertension case again. So the clue is the morphology of vasculature and the echo findings. As you can see here, the vasculature is not at all uniform. You can see that it is very much uneven in distribution, and this should again also give us a clue about acute and chronic thromboembolic pulmonary hypertension. So this is most probably a case of CTF, but he didn't agree for further investigations. I could not do a VQ scan, but we did admit him and treated under a cardiologist. Coming to case 4, this patient is elderly female with SOB on minimal exertion, wheezing and cough with loss of appetite and loss of weight in 6 months. There were 4 hospitalizations in the last 6 months and 3 CT scans were done, which are absolutely of very poor quality. They were only showing opacities on the chest X-ray, no more details than that. And this patient was started on ATT, and she was on ATT for 1 month when she came to me, and she was also being treated in lines of asthma, and that sputum was never positive. The only thing I got doubt is that this consolidation is not TB. It probably might not be TB. It is a perihilar consolidation. The attenuation was also kind of different. I can see the bronchi in between the consolidation. There is pleural effusion in this case. There is a pericardial effusion. I could appreciate a raised JVP. There are septal. Unfortunately do not have the other sections, but in this patient in the lung window there are septal thickenings, which I felt was lymphangitis carcinomatosa, and there was orthopnea because of the pericardial effusion, and the patient was not lying down since the past 3 to 4 months and only sitting and sleeping. So the first thing I did is asked her to get admitted because she already had enough hospitalizations. I did not want to prolong the investigations. I didn't want to go for again all the investigations. On day 1, I went for a PET CT and it showed an FDJ-vid lesion with an SU of 9, FDJ-vid mediastinal nodes with an SU of 4.9, and there were brain and liver metastasis. This is a case of metastatic cancer and is being treated in lines of TB and bronchial asthma since the past 4 to 6 months. The point I wanted to make here is that all opacities on chest X on CT scans are not pneumonias, are not COX, and the first investigation of choice would give a diagnosis when properly evaluated. There lies the importance of radiology. Only the radiological findings made me suspect that it might be lymphangitis, and that is the cause for her SOB on minimal exertion. Her baseline saturation was also low. It was around 90-92%, and she was around 55-60 year old. And there was bronchi also, and that can be attributed to probably to lymphangitis and the peribronchivascular coughing. SUV uptake, I want to make a word. In tuberculosis and in malignancy, the SUV uptake is usually seen so that, in TB it is usually around 4.5. In malignancies, it is usually more. We can see up to 18, 20, 22 also, the standard uptake value. Depending on that, also we can take a call sometimes. Here it's a straightaway case. We went ahead with a radiolibus and it turned out to be a poorly differentiated carcinoma. We did IHC, it turned out to be adenocarcinoma. But unfortunately, in this patient, the EGFR is positive, but it was exon 20 insertion positive, which obviates her from the use of any newer drugs like geftinib or osimertinib or anything, and we cannot use any TKIs in her except very posidotinib and all, which are very, very costly and she can't afford. Even though she is a non-smoker female, EGFR positive, the bad thing is that we cannot offer her targeted therapy, but we were at least happy that we were able to come to a diagnosis on day 2 itself, because our imprint, thanks to our pathologists, our imprint showed atypical cells in the first instant, but were poorly differentiated, and within 1 day we came to know that it is poorly differentiated adenocarcinoma. The last case is a 30-year-old obese female presented to OPD with whole body swelling. This was her only complaint. Gained 10 kgs in the last 6 months. There was SOB in exertion 6 months. Evaluated for Cushing syndrome before, which wasn't there actually. Last child was nearly 18 months old, following which the symptoms started slowly, that is SOB in exertion and weight gain. There was pedal edema. The calves were so hard, you can't even just pit on the calves. There was left lower limb cellulitis. She was wearing a very tight thing, and I made her pull it out, and it has become an obsession nowadays to palpate the calves and examine the calves, because there were so many cases of pulmonary thromboembolism we are seeing. And the calves were rock hard, and there was bilateral diminished air entry. So what next? I asked for a 2D echo, a bilateral lower limb venous Doppler and CTPA, because I felt that all those features are due to right heart failure. It was due to RV dysfunction that she is gaining weight. It is actually cor pulmonale, which is actually the presentation, and she is having fluid all over the body. And as you can see, this is the case which Megha presented earlier. If you can see here, the ratio between the pulmonary artery and the aorta. The pulmonary artery is way bigger than the aorta, and it was very surprising. And you can also see the vessels here in the section. They are tortuous. They were like, they are holding on thrombi since a long time. Maybe this patient was having an ongoing episodes of DVT again and again. If you see, her pulmonary artery size is around 4.1 centimeters and diameter is around 1.7 or 8. And there was DVT in the left lower limb where she was having cellulitis. There is pulmonary thromboembolism. There is severe pulmonary hypertension or 2 deco, and possibility is a case of CTF, but we didn't evaluate. They were not ready for the investigations. It is acute and chronic PTE for sure, because you can see as in the volume rendered image, thanks to our radiologists who are very cooperative, the tortuosity of the vessels can be seen. The vessels are abruptly stopping and they are not having the typical morphology, which is again suggestive of an acute and chronic pulmonary thromboembolism. Thank you.
Thank you, Dr. Vamshi, for your excellent presentation, as well as you have selected a good cases for presentation. And you have tried to tell the important aspect, especially the requirement of clinical correlation, the clinical evaluation before selecting the investigation. All investigations should be selected at any particular point of time with a good clinical assessment, and follow-up is also very important. Most of these cases, they will be coming from different doctors, multiple consultations. So there will be some advantage for the later person who has, because he can rule out many other diseases. So that happens. But for the first time, if he comes to us, then it will be a little bit difficult. But so you have presented a good cases.
Thank you, sir. Except 1 out of these 5 patients are under follow-up, sir. This lady lost 23 kgs in 1 month after putting her an anticoagulant and treatment for right heart failure. And she is now very happy. Her SOB decreased, but she is still having cellulitis. Her venous Doppler repeat still shows DVT, and maybe that will take time to resolve.
Thank you.
Yes, sir. Thank you.
Vamshi,
Sir.
Still surprised why you didn't go for a CT scan in that lady with myositis profile.
Sir, because
basic X-ray also was not there.
No, X-ray was already done very recently outside, and it was absolutely normal. The chest was clear. I wanted to go for a CT scan, but again, somehow my gut feeling was the pathology is not in the lungs. That is the only reason I didn't go for a CT scan. Even she asked me, sir, I came from so far, you could do me all the investigations. But I was very precise. I was obsessed with those investigations. Sir, present symptom is very bad fatigue and SOB. Her persistent complaint was fatigue, and she repeated this word nearly 30 times in the 10-15 minutes.
Thank you.
Thank you, sir.
Next, I invite Dr. Yashoda Hospitals, sir, Professor of Respiratory Medicine, Deccan Medical College, Chief Editor of Journal of Medical and Allied Sciences. He was a former editorial board member of Just India. Presented more than 70 papers and 400 citations. Best Teacher Awards for 2 times. And he has published 2 books which are by Springer London and translated into several European countries. We know all of them as one of the best teachers in pulmonology. Welcome, sir. The stage is yours.
Yeah, actually, yeah. So thank you very much, Lakshman, and it's my pleasure to be here. I was delighted when I got the invite from Yugender, but I was somewhat alarmed when I found that I'd lost most of my recent images which I had stored. So this is going to be without any images. Actually, I'm joking. I'm just joking. So it's perfect. So tuberculosis has been described as a protean illness, and Proteus is the god of water. Water changes its shape all the time. So it doesn't maintain any particular form, and that's why tuberculosis has been described as this. And some of these classical radiological features you will see. Of course, radiology strictly speaking, is to do with the chest X-ray. When imagiology has to do with everything else. But of course, that's a very technical, semantic thing. So we'll start off with our first case related to Proteus. And this is of a 65-year-old man with fever and lung infiltrates. And this man hailed from Kerala, where there's a practice of instilling oil in the nostrils. And we caught on to that after 2 days of admission. He had fever for about 4 days, and this was his infiltrates. Okay? And if you look air bronchogram, that means to say the problem is in the alveoli. And if you look closely, you can see a variegated appearance within the so-called consolidation, and that kind of alerted us to the problem. And the lavage, of course, showed this, which is basically the presence of fat within alveolar macrophages. This is our old friend, the Mycobacterium. And surprisingly, this is a weakly acid-fast organism, which everyone can identify as PGs, juniors, as nocardia, closer view. So this is, actually these were the treatment options, but it's always, now you have, the Mycobacterium also was identified as Mycobacterium fortuitium, not as Mycobacterium tuberculosis. So we had some treatment options, but for either of these organisms, it is always better to treat according to the culture and sensitivity profile. So you had the following culture sensitivity profile of fortuitium, you had the following, and of course, if you looked at the treatment that we have actually commenced, some of these were effective against nocardia also, and so we commenced the treatment, and at the end of 19 months, there was complete clinical and radiological recovery, and the patient was well until he last saw us. So this is actually, it raises a very curious question, because this has to do with the evolution of the mycobacteria and nocardia also, because both of these organisms evolved pari passu in environments that were very close to aquatic bodies, and they evolved in the soil. And because of that, these are the mycobacteria, and the atypical mycobacteria, they were equipped with waxy cell walls. And these cell walls, we'll come to that a little later. Because of that, they became known as the ducks of the aquatic world. Sooner or later, they evolved, and today, the Mycobacterium tuberculosis is a specialized human pathogen. But what's so special about the Mycobacterium tuberculosis? If you want the short answer, absolutely nothing. It lacks classical virulence factors, no capsule, no pili, no adhesions, no flagella, no enzymes, no toxins, relatively low infectivity, very slow growth rate. But it has one attribute. It has the most complex cell wall in all of nature, period. And this lipid cell wall seems to enhance the growth of these organisms, including the Mycobacterium cheilionii and fortitium, etc., and impede their phagocytosis by the host macrophages. And it's possible that the cell wall has much to do with it. So the cell wall has unusual complexity, unusual components, and can play an unusual role. And this is another role that it can play. 18-year-old college student presented with acute symptoms: fever, high-grade fever, intermittent, evening rise of temperature to some extent, but the fever was high. Dry cough, 10 days, dyspnea of fairly sudden onset, rapidly progressive since 1 day. The father was diagnosed and treated with tuberculosis 6 months ago, now asymptomatic, and she presented with the following, derangement in her vital data and hypoxemia. You can see the last line. And this was a chest X-ray. And by the time she was in ER and we saw her, she already had the endotracheal tube, the first arrow, the central line, second arrow, the NGT tube, third arrow. And you can see that there's a lot of consolidation abutting the fissure, the minor fissure. So the ball showed Mycobacterium tuberculosis, some gram-negative bacteria, and of course, we gave her the treatment that covered both these, and she made an uneventful recovery. And with Dr. Satish from Warangal, we pulled in these cases, and we reported some of these cases who had an acute presentation of tuberculosis. But again, if you look at the cell wall, it is the LAM, the lipoarabinomannan, which is the unique component of this particular cell wall that can lead to a syndrome that is very akin to endotoxic shock. Now, the mycobacterium has no intention of killing anybody. It's a very pleasant organism to have. The problem is that, and in fact, this is documented by an organism called the Dassy rat, which lives in Africa, and they live in huge underground caverns, and they have a very equanimous relationship with the mycobacterium. The mycobacterium makes itself milder, the rat allows it to live in itself, and they both live happily ever after. But any illness that initially comes with an acute virulent phase, and you know the arcana of tuberculosis, this is in all your textbooks, and later on it becomes mild. So tuberculosis is on the way. It is still not, pleasant illness to have. Unfortunately, the mycobacterium sometimes infects immunocompromised people, which it has no intention of doing, because if it does, then the individual dies and the mycobacterium also dies with it. So the mycobacterium doesn't want to get into that area, but sometimes it does. And of course, we have already seen miliary tuberculosis. This photograph was already shown by Dr. Meghna. But look at this, 43-year-old male, chronic renal failure, and as we all know, chronic renal failure itself is a 16 to 60 times risk of lung infections. The presentation was of renal pulmonary edema, not very convinced about it, hypoxemic respiratory failure, but we would normally have not done a CT scan, except for the peculiar right middle lobe infiltrate configuration. But when we did the CT scan, we found something little unexpected. And this is a lesson in itself, because if the individual is immunocompromised, then this individual is at high priority for going a little deeper into the imagiology. So chest X-ray can significantly underestimate the extent of the problem compared to the CT, and a low threshold must be acquired for doing a CT in especially people who are higher priority patients. That means to say immunocompromised. So this was what we saw, a lot of infiltrates and a cavity. So in essence, we expected the mycobacterium to come on ball, and it did. But what we didn't expect was this. These are not the exact images of the patient. They've been downloaded from the net because I lost some of the images there. But this, as you can see, is Aspergillus. So eventually we treated him, very, very satisfactory resolution, both with antifungal and antituberculous therapy, and you can see minor scarring is left. Lymphadenopathy is a very, very common condition in endemic areas such as ours, and there are lots of reasons for that. And if you had caseation with a variegated appearance, in our days we used to feel that it was sufficient evidence for tuberculosis, and without any further investigation we used to embark on ATT. And in the vast majority of cases we were right. But today it's a different scenario, because you have the tools, we should use the tools, and we should probably get a diagnosis in case things can go wrong, because the variegated appearance is by no means extremely specific of tuberculosis, although to a large extent it is. So lymphadenopathy, in fact, responds, however big it might be, it responds very well to antitubercular therapy, and as you can see, the resolution can be pretty satisfactory. But sometimes the resolution isn't so great, at least initially. So this is a 33-year-old male, 1 month of the following symptoms: cough, feverishness, loss of appetite, left hilar mass. The CT scan of the chest shows a minimally enhancing soft tissue mass in the anterior mediastinum, small volume lymph nodes, etc. Biopsy was done, histopathology was suggestive, microbiology was also suggestive, diagnostic, and culture was diagnostic of tuberculosis. But the patient hadn't improved initially. And this once, there was a, can you see the marker? Oh yeah, great. So after a couple of weeks, the high-grade fever had continued. Extended fever profile was normal, and the histopathology had to be reviewed, and in fact it was repeated. And this time it was reported that there was paracortical necrosis, histiocytes with crescent-shaped nuclei, etc., etc. And of course, the markers of tuberculosis were also there in the histopathology. Now, today, this condition is also called as the Kikuchi Fujimoto disease, which was first described obviously in Japan. And this is a condition that normally affects the cervical lymph nodes. So the involvement of intrathoracic lymph nodes is rather rare. It is usually described in young women, and these are, by the way, these are the original images of this particular patient. It's rare, normally benign, usually self-limiting, and there are, broad etiological agents, either, infectious or autoimmune. The infectious is comprised of a large number of viruses and some bacteria. Unfortunately, no viral particle has ever been directly incriminated or rather seen, and cultures and infective workup in Kikuchi disease are typically negative, except for, in this particular case. So by the time the second round of histopathological results were in, the patient had actually begun to settle and eventually recovered uneventfully without the addition of ancillary treatment such as steroid. But sometimes the lymphadenopathy can throw up some other questions. This, of course, anybody can see. What is your first thing that comes to your mind in this particular case is obviously something like sarcoidosis. But beware, it may not be sarcoidosis in most instances, although the recommendation, the guidelines say that if you see such a kind of thing in conjunction with, let's say, uveitis or parotitis or whatever, you are justified in treating without any histopathological access. So only thing is, normally if you have a lymphadenopathy of this nature and it is also sarcoidosis, you don't normally treat. But if the patient is PPD positive, then you have to assume that there is some active tuberculosis which is there, and then you have to start treating with antitubercular therapy. But certainly, when there is a problem nearby, a steroid is definitely going to be handy. So there are two problems that you can see. One is the patient has developed some arrhythmia and the patient is already on a pacing device. And second thing is you can see a subtle flattening of the inspiratory and the expiratory curve, which means to say some compression of the airway has already begun. So this patient is already meriting a steroid in case the patient had sarcoidosis. But what we found is, this is a paper that was predominantly driven by Dr. Narasimhan, and I was fortunate to be part of. Mediastinal adenopathy with a mid-myocardial scar and or focal myocardial inflammation there's an association. So if you have a paratracheal lymphadenopathy and you have an arrhythmia going on, that means to say there is a very strong likelihood of myocardial tuberculosis going on in this particular patient. And there we have published about 3 papers on this particular thing. So tuberculous lymphadenopathy has got a very significant association with myocardial tuberculosis, and especially if there is a supraventricular tachycardia present, then definitely this association is all the stronger. Now, a peripheral lung mass actually may turn out to be tuberculosis, as you can see. This is the case, and the response to treatment has actually been extremely satisfactory. So fortunately, it turns out, excuse me, sometimes that lymph node, the lung masses are not malignant, but tuberculosis. But it's still a good idea when you see a lung mass to think about a neoplasm first, obviously. This is a 33-year-old man with cough on and off since the last 10 years. He had asthma, but it became worse lately. So there was a change in his pattern which merited some kind of an investigation. There was discovery of radiological abnormality during evaluation, and this was a problem, and you can see some speculations at the end. A bronchoalveolar lavage was done, and a TBLB was also done, and eventually there was the usual stuff, but a few AFB were also seen here. And in BACTEC AFB were detected. Cultures showed Mycobacterium abscessus. So this was an unusual case on several grounds, because the patient had not lost weight, the patient was not immunocompromised, but in any case, Mycobacterium abscessus among the rapid growers and the MTB is one of the least likely to affect immunocompromised individuals. It is the most important human pathogen among rapid growers because of the disease that it can cause. It is the most pathogenic of all the rapid growers, and a mass lesion, as in this patient, is distinctly unusual manifestations of Mycobacterium abscessus infection. Now, the caveat here is that if there is a mass lesion, and that is unusual in Mycobacterium avium abscessus, and Mycobacterium abscessus is also associated with malignancy, then can the mass not be a malignancy and Mycobacterium abscessus a colonial there? So this could have been possible, but in this case it was not. The lesion, the primary lesion itself, turned out to be tuberculosis. not tuberculosis, the atypical tuberculosis caused by this. Now the problem here is that the treatment of Mycobacterium abscessus is extremely difficult because isolates are usually susceptible in vitro only, and despite aggressive medical therapy, cure is unusual. And one of the main arms of therapy, which are macrolides, there is an acquired resistance to macrolides, which is dictated by the ERM gene, which is very, very common in this. Unfortunately, this patient's culture sensitivity profile was very adverse, and as you can see here, Mycobacterium abscessus has been termed as a new antibiotic nightmare, and most of these drugs here were resistant, and this patient unfortunately was also lost to follow-up. But new treatments are now being born of desperation, and such as phage therapy and of course nitric oxide therapy as well. Sometimes the lung mass will be more complex, and as you can see, there is a kind of an obstruction of the left upper lobe. That means to say there's a proximal obstruction going on here. The obstruction is further reinforced. That impression is further reinforced because of the fact there's a complete lack of air bronchogram within the on the CT, and this is what we saw endobronchially, and this is the biopsy, and eventually you can see the mycobacteria towards the center of the slide and the resolution there. So this is one of the manifestations of endobronchial TB as well. Similarly with this kind of patient, this other patient, and she had something that looked, at least to some extent, like a carcinoid, although the vasculature was not very prominent here. And you can see, in fact, there is a spot of caseation that's also happening here. Again, her images, and again, the very, very satisfactory resolution with anti-tubercular therapy. Now, endobronchial TB and sarcoid can sometimes present very, very similar cobblestone appearances, and we can be kind of, foxed by that. And this is one of the studies that we presented with Dr. Swami at Care Hospital, and we thought it was sarcoidosis, we thought it was tuberculosis, but when we biopsied the nodules, they were rock hard, and eventually the diagnosis came to be tracheopathia osteoplastica, and this is basically a sidelight. Now, if you have intermittent symptoms, so this is a patient who was known to have intermittent asthma since childhood, but now again there was a change in the profile. The patient had been known to suffer from tuberculosis in the past, and you can see the old image on the left, and you can see the new image on the right. This is reminiscent of some of the images shown by Dr. Meghna a little earlier, and you can see a clear constriction of the right mainstem bronchus. But what brought this to light, what made us do the CT scan, of course, was this particular image, which shows what is called as the inverted mirror image flow volume loop, which is typical of any mainstem obstruction. So this led to this led to this, and that led to the diagnosis of endobronchial, or rather bronchostenosis. And this is a very, very, it's not specific actually for tuberculosis, because this can happen with even a foreign body, as we have shown in this particular case. So, of course, a chest X-ray can hide a lot. A CT scan can show a lot, and if you see such a very, thick-walled cavity with an intramural nodule, the first thing you should be thinking of is a squamous cell, cavitating squamous cell lung cancer. But in this case, it turned out to be tuberculosis. And of course, like I said, you have to be extremely careful if there is a suspicion of other disease hiding there, because these are the two chest X-rays which showed virtually, normal lung fields. But if you looked at these two X-rays, they showed, mycetoma in both of them. So the value of CT is obvious. It can detect a lot of things that are not visible on a normal chest X-ray, and it can show things that are underestimated, like a big consolidation. And the mycobacterium has a lot of tricks up its sleeve. So I have been very, very fast with this presentation because I didn't know how long. I really didn't time myself. I'm time. Thank you very much. So I'm done. So I'm just trying to, last couple of slides, reaffirm we have been committed ourselves to the eradication of TB in the country. And we have a journal on which we have written repeated editorials about tuberculosis. So even in this day and age, whether it's tuberculosis or non-tuberculosis is the question. We don't have, the old staining methods are actually dying a slow death. And we need live stains and new ways to, identify our organisms. We don't have a vaccine that is effective, and the future of tuberculosis in this country is more or less, uncertain. So with this, I would like to say that the Surgeon General of America in 1966 published an article, and he gave a quotation in Time magazine. He said, the book of infectious diseases is closed because your antibiotics have they have taken the day. They've actually won the day. It's time to close the book of infectious diseases and declare the war against pestilence won. Unfortunately, what we feel is that in respect of infectious diseases, there is much work to be done. Countries will need to come together. But the book of infectious disease continues not only to be open, it continues to grow thicker by the day. So thank you very much for your patience. And this is a set of paintings done by my colleague, Dr. Swami, with whom I collaborated on a couple of the papers that I already showed you. And with that, I will leave you. Thank you so much. If the chair, Shailaja, thank you very much. If the chair allows, you're very welcome.
Yeah. Thank you. Thanks, sir.
When you have the histopathology,
yep.
So how would you decide if it is disease or
Okay. Thank you for that wonderful question. See, the thing is, that's the pathologist domain predominantly, but Kikuchi's has been termed as apoptotic lymphadenopathy, in which you see the stigmata of apoptosis. So at least in the paracortical areas, there is a lot of apoptosis and cell destruction going on. So that is the first clue. Then you have that debris and all those kind of things interspersed within the structure of the lymph node. But today, there is a genetic marker. The second thing is, if you have access to electron microscopy, which obviously none of us have, then the process of the pycnotic and the karyotic debris can be picked up with much greater felicity than the X-rays.
Thank you.
Thank you very much.
Sir, you showed one case, mediastinal lymphadenopathy, ventricular tachycardia.
Yep.
Why not sarcoidosis, sir?
No, actually, see, it's not a case. It's a case series. It's a case series. So here, initially, what we were trying to do is we were just correlating with granulomatous lymphadenopathy. So that made no difference between sarcoidosis and tuberculosis. Then we realized that many of these patients were tuberculin positive. So in sarcoidosis, because of the peripheral energy, you don't expect tuberculin positivity there. So once the tuberculin positivity we started noticing, we shifted our stance and we kind of said it was tuberculosis and rather than sarcoidosis. Thank you.
Thank you, sir, for your wonderful presentation and the nice cases, thought-provoking cases. Thank you very much.
One comment for closing the session. I think we should not forget the good old lateral views and lateral decubitus views, though you have a gamut of all advanced things, especially bedside. Thank you.
Thank you, sir. I now request Dr. Ashfaq Hassan, sir, to please come and take a memento. I request Dr. Krishnamurthy, sir, to come and present a memento to Ashfaq Hassan, sir. Thank you, sir. I request Dr. Yugabir Gaud, sir, to present a memento to Dr. Vamshi Krishna, sir. Dr. Megha. It's not here. I now request Dr. Subhakar sir to present a memento to Dr. Krishnamurthy sir, to our chairperson. I now request Dr. Pramod Kumar sir to present a memento to Dr. Lakshman Babu sir. I now request Dr. Pradyut Vagre sir to present a memento to Dr. Yugavir Gaud sir.
Now we will move further toward our second session, the human brain, the mother of the artificial intelligence. For the chairpersons, I would like to invite the Dr. Subhakar Kandi sir. He is a professor and head department of the pulmonary medicine at the Kamineni Academy of Medical Science, and he is a fellow of the Royal College of Physicians London, and also the fellow of the American College of Physicians and the Indian Chest Society. He piloted national airborne infection control guidelines for the India, and he received an international award for the best paper on the diagnosis of TB pleural effusion presented in the Chest 2008 Philadelphia, and he received the KSR Murthy Memorial Gold Medal from the TB Association of Andhra Pradesh for the best scientific paper. Please come on the desk, sir. Now I second chairperson, Dr. Pradyut Vagre sir. He is a professor and HOD of the pulmonary medicine at SVS Medical College. He is a chairman and managing director of the Kunal Institute of the Medical Society. He is a senior consultant pulmonologist at the Apollo Hospital, Jubilee in Hyderabad. And I would like to invite our third chairperson, Dr. Narendra sir. He is a professor and the HOD of the respiratory medicine department at the Osmania Medical College. And our fourth chairperson, Dr. Pramod Kumar sir. He is associate professor in the Gandhi Medical College and currently working as a professor at the Osmania Medical College.
Yeah. Good morning. At the outset, I congratulate Vamsi, Yugandhar, and the Satish, the team from Yashoda Malakpad, for bringing out an important program today, the lung Instagram. I think they were saying that the picture speaks 1,000 words, but every picture has a long story behind it. The story is known to a pulmonologist. So I think that the interpretation of the imaging as far as chest is concerned, we are the persons to interpret. Don't go by the reports, read the reports and take decisions. I think you have seen the first session, wonderful presentations, and we are going to the next, the human brain, the mother of AI. Actually, I thought Dr. Ashfaq will speak about some of the AI, I think he has given a gloomy picture about tuberculosis. I think, because of lack of time, I could not comment on that. The AI in the interpretation of TB is coming a big way. And the moment you show your app is there, the report will come to your WhatsApp. That is the development that has happened in the tuberculosis. So we have first talk, the pattern paraphrasing the is not there? Okay. I think because the first speaker has not come over, just slightly slide. The CTD and ILD, hen or the egg. I think the Bhaskar is my good friend. He has worked with us in Chest Hospital. Now in Nizams, he is doing a wonderful work. So he will tell us which is the hen, which is the egg. Let us hear from. Over to, yeah, please. So he's an additional professor in the Department of Pulmonary Medicine, Nizam's Institute of Medical Sciences. He did European Diploma in Adult Respiratory Medicine. He's an undergraduate from Andhra Medical College, Visakhapatnam, and he has 35 national and international publications. In main areas of interest are allergy and asthma, but today he is speaking on ILD.
Thank you, sir. Thank you for the kind introduction. And at the outset, I'm thankful to the organizers for inviting me, and they are given a nice title also. So, which the hen or egg, but I will try to sort out what are the possibilities anyhow. And I tried to bring out some cases which came to our attention. The thing is, a lot of work has been done on this case. I'll show the brief history only. But a lot of workup has been done, and I filtered all the data so that it will be very useful as a final process. This is the final diagnosis. A lot of work has been done, but I wanted to impart that what is the importance of these things. Here is a 49-year-old female who is a known case of SLE overlap under the follow-up of a rheumatologist, and she has been getting all the medication immunosuppression, and the help of the serology she was diagnosed. Now she presented with the complaints of cough and breathlessness of 3 months duration. Although initial, as per documentation, initial imaging wise, there were no suggestive lung disease. Later she started having haziness. Now she became symptomatic, and this was the picture showing bilateral lower zone and even left lingual also. Ground glass haziness, reticulation, subpleural zone, predominantly at right lower lobe and left upper lobe also. So this is a patient, known established CTD, connective tissue disorder, later developing the chest symptoms, presenting with breathlessness and cough, diagnosed to have an NSIP pattern. This is one more patient who is a 38-year-old female. She is also known case of MCTD 2 years on immunosuppression, and she presented with almost 6 months of history. Again, now you can see subtle changes in the bilateral lower zones with nice ground glassing, a little bit subpleural sparing in the right lower zone also. On examination, crackles, she developed crackles, symptoms, imaging. All these three concluded that this is the interstitial lung disease which she has developed after the onset of the connective tissue. She has an established connective tissue disorder, and now she developed a lung involvement. So here, these two cases are lung disease, CTD preceding the interstitial lung disease. This is another subset of patient where a 51-year-old female. She has been getting treatment as LD and SIP since 5 years. She got all the medication somewhere, inhalers, somewhere steroids, all these things. And they have done initially CTD profile also, which was negative. And now she presented with breathlessness, and clinically also there were arthralgias. Actually, that's not mentioned here. And later, her IMRF was positive to me. With the help of the clinical imaging, everything, she was diagnosed to have a rheumatoid arthritis with ILD. So these are the images. You can see nicely the ground glassing in the right lower and left lower joints also. So this is one subset. Next, this is one case. And next, one more thing is a male 55-year-old, almost 2 months of history, rapidly progressive. And on the workup, he was found to have PL7 positive, and later he was diagnosed as anti-synthetase syndrome. So this is the imaging picture. You can see nicely left lower joint. You can see bilateral lower joints, ground glassing. There is a nice subpleural sparing. So these two cases are in known case of ILD. Patient has been getting treatment as an ILD, either in the form of NSIBO or whatever it is, now presenting with later developing the connective tissue. So the thing is, both can happen. A CTD can happen. CTD patient can develop a respiratory manifestation. Starting to be the ILD can develop the connective tissue phenomena later. So to have a brief idea, this is the ILD. So we know that ILD are a group of disorders, almost as per textbook, more than 200 entities. So previously there were several classifications. Now this is the recent classification by 2018 ATS classification. There are several changes. You can see that previously all were grouped in the single group. Now it's a etiology known and unknown. In the known group, different exposures, smoking, drugs, connective tissue disorders. If you see the 4 groups, exposures, inorganic and organic, smoking, and drugs, 4 things. You ask the question, they'll give you the history. So 4 things, you got it done. Connective tissue disorder related to ILD. This, you see the case, you will get the diagnosis. So you ask the questions, you can get the diagnosis. You see the patient, you can get the how it's going to be, we'll see. Whereas at the other extreme, we have certain problems. Like you see the IIPs, idiopathic interstitial pneumonias. It's broadly classified into 2 types, IPF and non-IPF, whereas non-IPF will consist of NSIP, COP, LIP, that's lymphocytic interstitial pneumonia, and AIP, which is acute interstitial pneumonia. So 2 extremes, and we are going to balance between this CTD and all other things, because the aim of this presentation is CTD. So this is the generalized idea of how the cases of ILD in our country and the Western setup in the next slide. There are 2 studies which were published. The first study was the Indian National Registry, which showed that hypersensitivity pneumonitis was the dominant type of ILD which has been present, which is present in the Indian setup. Whereas when it comes to the CTD ILDs, rheumatoid arthritis, next is scleroderma, MCTD, Sjogren's, and CSL. These are all the CTDs among the connective tissue disorders with ILDs. So one more study from the PGH Chandigarh, which is a multicentric study, which has shown that sarcoidosis is the dominant CTD in that center, because probably there could be some referral bias because it's a tertiary care center. So this is the estimated relative distribution of the specific interstitial lung disease in the United States data, of course. There you can see almost all equal distribution. IPF was 20%, CTD is 20%. Same thing has happened with HSP and sarcoidosis also, almost equal distribution. So these are the various distribution. Now, when it comes to the picking up the disease, how do you see? Now, the primary aim of this is to identify whether any connective tissue disorders, because connective tissue disorders or immunology is a rapidly expanding branch, and we are not the correct person to speak it also, but let us have a basic knowledge. It's a very rapidly dynamic changing branch, and immunology, as you know, somewhere I read that daily 2 or 3 cytokines are being detected. So really it's going to be very difficult to catch up the entire knowledge. So, but basic knowledge is essential, we will go through that. So when it comes to the, now the dilemma, we have certain patient groups. First thing is, what about the general population? Are there any features of connective tissue disorders, either in the form of clinical, serology or anything? Or at one extreme you have connective tissue disorders which are established. The other end you have IPF, which is supposed to be the restricted to the lung alone without any systemic manifestation. So here you have systemic and there are no systemic. In between you have certain areas by constant evolving knowledge we have observed this thing. And one more thing is there are certain occupational lung disorders which can later develop, connective tissue disorder features. So what is the prevalence of prevalence or presence of the markers of the autoimmunity? Those are AN and RF in the general population. And we have definitive criteria for CTD-ILD. Once you are aware that, we can confidently diagnose. So that awareness is very, very, very important. Number two. And the other end, do IPF patients will have any autoantibodies? If at all they are there, what is the importance? In between these two things, again, IPF is one entity, interstitial pneumonia with autoimmune features. This is a working diagnosis. This is still evolving entity. Other end, I said ILD, occupational lung disorders with autoimmune features like silicosis, like rheumatoid, known as Kaplan, or Erasmus syndrome. So these are the extremes of the presentations. So there is one interesting study which was published recently. What is the prevalence of the autoantibodies in the general population study? It has shown that ANA of 9% and rheumatoid factor of 6.6%. So there are antibodies which are markers of serological autoimmune markers, but people do not have any clinical manifestations. And there are some interesting points in the study which I will be telling later. And what about aging? Aging is a phenomenon where patient immune status will gradually, in fact, all of our immune status will be changing constantly. Daily we'll be exposing a lot of external environment agents, infection, all those things. So there is one interesting thing which I came through was there is age-related autoimmunity. In fact, one nice study has shown that in 256 patients of 100 years old, all of them, the prevalence of the antibodies was about 80%. 80% of the 100-year-old of 256 patients had at least one antibody, either ANA, rheumatoid factor, or something, antithyroid, whatever it is. So as the age goes up, there is constantly autoantibodies are being developed, but they do not manifest in clinical wise. So what are the reasons? So this picture depicted nicely. So there are certain subset of the cells known as Treg cells, which are anti-inflammatory. They do suppress that because you need to control the immune system once it gets activated. So Tregs are the cells. They secrete IL-10, TGF-beta, which are almost try to suppress. So these Treg cells will have enhanced production at the age goes up, which will suppress the CD4 and CD8 cells, which will lead to the cancer and sepsis. That's why you see more and more cancer and sepsis patients incidents in the elderly, whereas you see autoimmune antibodies, but they do not manifest clinically. So this one diagram depicts two extremes, as I said. At one end, you have well-defined CTD-ILD, and other end, IIPs, where there are no features of autoimmunity. In between, there is a IPAF, which is interstitial pneumonia with autoimmune features. So what CTDs we commonly encounter, we are not worried about all the other things. Vasculitis also, it's not being discussed here. These are the common things: RA, rheumatoid arthritis, SLE, scleroderma, Sjogren's syndrome, MCTD, idiopathic interstitial, myopathies. SLE has relatively less involvement of the lung, but pleurisy, pleuritis, lupus nephritis, all these things are, but interstitial component is a little bit less. As I said, some are evolving. So these are the various criteria which are well defined. I think by practicing, we can all practice and we can see daily. For rheumatoid arthritis, there is a criteria. For Sjogren's syndrome, for systemic sclerosis, and in fact, there is a diagnostic criteria for SLE also. But for the IIMs, myopathies, the criteria is there, but there is no part for the lung in that criteria. So IIMs, we should be aware. But as Vamsi said nicely, that high clinical suspiciousness is very, very important, which is we often missing now. So how is the prevalence of ILDs in CTDs? You can see here in Sjogren's syndrome, 25%, rheumatoid arthritis around 7 to 10%, systemic sclerosis. And one interesting thing is, some studies have shown the MCTD up to 50%. So prevalence will be more and more in case of MCTD, scleroderma, and polymyositis, you can see 43%. So anti-synthetic syndrome, almost by definition itself, it has a criteria. The criteria consists of ILD also. So this is how this goes on. So there are, what are the common disorders? 3, RALD, scleroderma, IEM. IAM is the recently evolving entity. One has to remember all the time, is it a possibility, is it a possibility. So these are the features where RAILD is commonly, the pattern is UIP, scleroderma it's NSIP, IAM ILD is the NSIP with OP, and it has prognostic significance also. The common findings, as we know, I don't want to go, but risk factors are important. See here in the RAILD, you see smoker, age, male with high CCP antibodies. High CCP antibodies is important. I'll tell you in the next slides why it's important. It comes to the SSC-ILD, risk factors are anti-topoisomerase, black race. Because why these risk factors are important? Because once the patient with rheumatoid arthritis comes to male or female, smoker or non-smoker, how is the age? So if all these things are there, yeah, this patient is a high possibility of getting an ILD or already has an ILD. So this is the importance. And how it affects prognosis. RAILD is one of the leading cause of death in rheumatoid arthritis patient. In fact, lung involvement itself is a bad prognostic marker in cases. But one good thing is, if you compare with IPF, yeah, these patients have better prognosis. So both the things are there. So 5-year survival in UAP is hardly 36%, and it's NSIP 94% survival is there. That's the beauty. So when it comes to the Sjogren syndrome, 75% of the disease is subclinical, and always remember that there could be airway disease also in case of Sjogren's, because that's a sicca. Dryness will be there in the entire trachea. So this can manifest as a cough, and you are treating the lung disease interstitium, it's not getting resolved. There could be a possibility of the airways also. SLA, as I said, polycirrhosis is common, ILD is less common. MCTD, as I said, it's very common. So why it's important to have this discussion? Because therapeutic response will change, and also assess the extrapulmonary involvement prognostication. Now, I'll take as rheumatoid arthritis as a prototype. How the patient develops the disease, this connective tissue disorder will develop the ILD, so that we can understand there is a strong HLA association. That is, there is genetic predisposition, which is a HLA association. Second thing is, there are some interesting findings in rheumatoid arthritis which do go in line with IPF, which is the other extreme. That is MUC5B polymorphism, you must be knowing. There is a polymorphism variant known as RS3570 5950. It's a promoter variant which is more prevalent in the Western setup, and you can remember that the same variant is also highly prevalent in the IPF patients. So there is some common link between the so-called IPF and this connective tissue disorder entities. There is one more interesting thing, is only one was study shown that RPA3 UMAD, this gene polymorphism, is highly prevalent in the Japanese population, which is associated with ILD. And interestingly, this region represents the telomerase. And you remember that telomerase is consistent. Patients with the telomerase defects will have pulmonary fibrosis as their manifestation. You can see in familial cases. So any familial incidence is there, definitely you need to think about the STS, that is short telomerase syndrome. This is one important entity which is it should be kept in mind. So, and also all these things will be correlating with the UIP pattern in CT, and there is a role for epigenetics, as I'll discuss later. So this is the thing.
Bhaskar, how many slides you have? Because
Almost few only. So environmental factors like smoking is important, infections are important. So all these will lead to the autoimmunity and inflammatory parameters leading to the ILD features. Smoking induces the PADI enzyme, which is peptidyl aminodeaminase, which causes citrination of the peptides recognized by the immune system, leading to the immune tolerance. Already immune tolerance break in the immune tolerance is the prerequisite, which will lead to the recognition of these citrinated peptides, leading to the autoimmune phenomena. Environmental factors, periodontitis, GRD, particulate matter exposure, and these are the risk factors which are already discussed. Pathogenesis, one interesting thing is RAILD airways will have aggregated lymphoid follicles, which will have T cells, B cells, follicular dendritic cells. Interesting thing is B cells are activated, leading to the CCP antibodies. These CCP antibodies will stimulate neutrophils. Neutrophils will release a netosis, that is extracellular traps. These will stimulate the fibroblast, thereby leading to the interstitial lung disease. This is the scleroderma, again showing that genetic susceptibility, environmental factors, and epigenetic regulation. So ultimately the thing is, all the three factors are important. So simple presence of the one factor will not sufficient. Similarly, Sjogren syndrome also. Endogenous, exogenous, and genetic background is also important. These are the various myositis antibodies which I would like to skip, and these are the various antibodies here again. Yeah. Next comes to the clinical examination. So once you see a patient, of any patient, any ILD patient, so it doesn't take much time or money to examine for all these things. In fact, one strategy known as VEDA strategy, that is very early diagnosis of the systemic sclerosis, is already being published. You can check it. So it starts with the identification of the Raynaud's phenomena. Ask the patient for typical. It doesn't require, even PFT will cost about 500, 600. Examination of the hands doesn't take much time. So Raynaud's phenomena, puffy fingers. So puffy finger is a preceding feature of all other features. So see for the puffy fingers, Raynaud's phenomena, antibodies. See all these three things. High possibility, go for the next alternative known as nail fold capillaroscopy. So I think in future we should be using nail fold capillaroscopy to identify the early changes in the capillaries, so that a high guess of any CTD related disorder can be sort of. So these are the various manifestations. You see the Gordon's papules are the other extreme, telangiectasia. These are the mechanic hands. And there are certain radiological findings which are important. You must be knowing anterior upper lobe sign. You can see anteriorly a lot of lesions are there. Exuberant honeycombing. The straight edge sign is the third image, and last edge is the one more thing, interesting thing is four corner signs, regions of the thorax. All these things are indicative of CTD ILDs. And one interesting thing I came across is in SLE, along with, you can see that image, you can see islands of, island areas of small vascular, hyper intense areas there. These islands of lesions are seen in SLE fibrosis. So newer approaches, artificial intelligence, ultra-low dose CT, ultrasound. IPAF is there, which has given criteria. 10 to 20% of the IPAF can progress.
I'm afraid I can't extend any more time. Can you conclude?
So one interesting thing is IPF patients can have who are followed for 9 years, but did not. They have developed 41% of them developed autoantibodies, but they did not show any pulmonary function deterioration. So this is the important. So you have now at the conclusion, you need to have all the three factors. Environmental factors are important, genetic factors important, and stimuli. All these things are important to develop the CTD. So if you ask me hen or egg, which is prior, if human beings are hens, definitely hen will be the first thing, right? With this I conclude. Thank you.
Thank you, Dr. Bhaskar. You have presented a vast topic. Of course, I can understand this is a vast topic. To be covered in 20 minutes is a difficult challenge here. So you have nicely projected. Sometimes CTD is egg and sometimes ILD is the egg. They change the scenario, and you have nicely pointed out the clinical examination is the important thing for approaching a case of CTD ILD. And you have projected anti-synthesis syndrome here. I want to share our experience. We got 3 cases of anti-synthesis syndrome of late. We are publishing this is in the next IJCD journal. One anti-synthesis syndrome presented as a bilateral pleural effusion with organization. So sometimes unusual presentations may be there, so a detailed approach will help. Thank you for your. So I will hand over the mic.
Thank you, Dr. Bhaskar, for excellent presentation. A few points which what he has highlighted here is if you get a classical case of rheumatoid arthritis or any other CTD earlier, and then do your CT, you know it's a typical NSIP picture except rheumatoid arthritis, when you get a UIP picture as well. But the question comes, if you see the CT scan first and you don't get a diagnosis, then you are perplexed why he is having this NSIP picture. So I think he has shown excellently that always look for extra pulmonary signs. You may get an answer there. Take a very detailed history. Is it drug induced? Is it bird exposure? Or is it any other exposures or exposure to organic or inorganic dust? So most of the times we get an answer here. If you're still not getting anything, you don't know why it has come, just repeat the test after 3 months or 4 months. Maybe it will show some positivity as he has shown in one of the case. Thank you so much, Dr. Bhaskar, for the excellent presentation. Thank you. Now we have Dr. B.V. Murli Mohan. I think he is going to do an online presentation. Introducing Dr. Murli Mohan is like showing light to the sun, but I have to do my job. Murli I know since a long time. He has done his MD MRCP. He is a senior consultant physician and pulmonologist in Narayan Hridayalaya, Bangalore. He is a consultant physician and pulmonologist in Parichma Medical Center, Bangalore, at Nightingale's Home Medical Services, Bangalore, and he was in Trinity Hospital and Heart Center, Bangalore as well. He is a professor in the Department of Medicine, Dr. B.R. Ambedkar Medical College from 1994 to 2005. He worked as a registrar in the Newcastle General Hospital, Newcastle upon Tyne, UK. He was a clinical fellow in respiratory medicine unit in the famous King's Cross Hospital in Dundee, and he has authored several research publications and projects. Dr. Murli Mohan, the stage is yours. Dr. Murli, are you online already?
Can you see me now?
Yeah, hi, welcome. Yeah.
Fine. Hello. Can I start speaking? Because I can't see anybody or anything, so. Okay. I can start. All right. Great. Thanks. Thank you. Thank you. Sorry, I'm trying a bit blind here because I can't see what's going on at the other end. But it gives me great pleasure to be here talking on imaging in pulmonary hypertension. I bring you greetings from Narayan Hridayalaya, Bangalore, and of course a very grateful thanks to Dr. Vamsi Krishna and the entire Department of Pulmonology at Yashoda Hospitals in Malakpet for inviting me to give this talk and to do the brilliant work they're doing. It's said that the pulmonary circulation lies in the territory between the cardiologist and the pulmonologist, but is understood by neither. This statement was made quite some time ago, but we've learned a lot since then, a lot of it thanks to imaging that happens. I'm going to start with the new definitions of pulmonary hypertension. This was what came out with the 6th World Symposium on Pulmonary Hypertension and has been repeated, revised in the ESC-ERS guidelines that came out last year. So basically, we're talking about pulmonary hypertension being defined by a mean pulmonary artery pressure at rest of greater than 20 millimeters of mercury. And we recognize different types: pre-capillary, post-capillary, and a combined pre- and post-capillary. So in a pre-capillary, the mean pulmonary artery pressure is 20, as in all the others. But the pre-capillary variety, the pulmonary artery wedge pressure is less than or equal to 15, suggesting that the problem is all in the pulmonary arterioles before the capillaries.
and the pulmonary vascular resistance must be greater than 2 Wood units in all. In isolated post-capillary pulmonary hypertension, the pulmonary artery wedge pressure is more than 15 millimeters of mercury, suggesting that the problem is after the capillary, hence post-capillary pulmonary hypertension. And in combined, you have both. You have a raised mean pulmonary artery pressure, you have a pulmonary artery wedge pressure that's more than 15, suggesting post-capillary. But unlike isolated post-capillary pulmonary hypertension, where the pulmonary vascular resistance is low, less than 2 Wood units, here the pulmonary vascular resistance is also high. So there's both pre-capillary and post-capillary pulmonary hypertension. And we recognize 5 different groups. This is a complicated, detailed classification, but I'll sum it up. Group 1 is pulmonary arterial hypertension. Group 2 is that associated with left heart disease. Group 3 is associated with hypoxia or lung disease. And I assume practically everyone here is a pulmonologist, so this is the group we see most often. Group 4 is due to pulmonary artery obstructions. The commonest cause of these obstructions being clots. So that is chronic thromboembolic pulmonary hypertension. That's a long 5-word title, so we usually abbreviate it to CTEPH. And group 5 is where you have miscellaneous causes or multiple mechanisms. And in the rest of my talk, I'm going to try and show you some images associated with each of these groups. It's also very important to remember, and why imaging is so important, is that a correct early diagnosis of pulmonary hypertension is crucial. Here you can see that in the early phase, after the diagnosis was made, the mortality gradually increases and is highest in those with pulmonary hypertension. That's the green and the blue lines, whereas those without pulmonary hypertension tend to have better outcomes, irrespective of the disease. This includes all causes of pulmonary hypertension. When you have pulmonary hypertension with a normal RV, that also gives you a better prognosis. That means you've caught it early enough before RV dysfunction occurs and the person therefore has better outcome. So early diagnosis, very, very important. And you can see this other slide, pulmonary hypertension, irrespective of the cause, worsens outcomes. Always look for pulmonary hypertension in lung disease. You can see the survival difference between those who don't have PH and those who have PH when they have lung disease. A specific example, COPD, where people with milder pulmonary hypertension have better outcomes than people with more severe pulmonary hypertension. So having PH worsens the prognosis, having more severe PH worsens the prognosis even more. But it's very important to look for the etiology. For example, pulmonary hypertension associated left heart disease, what we call group 2 pulmonary hypertension, probably has the best outcomes of all. CTEPH also, thanks to the fact that surgery is available, it's one of the few treatable causes of pulmonary hypertension, as is pulmonary arterial hypertension. Lung disease has no treatment, and that has the worst outcomes of all. And even within group 1 pulmonary hypertension, all these are causes of group 1, also known as pulmonary arterial hypertension. All the others should not really be called pulmonary arterial hypertension. The ones with the worst prognosis are those with pulmonary veno-occlusive disease and portopulmonary hypertension, whereas idiopathic pulmonary hypertension has actually got a much better prognosis now, thanks to the availability of multiple drugs. And always try and make an early diagnosis of PH. Here, after starting treatment, you see how patients have done well compared to those who are not treated for whatever reason. Untreated patients caught early when they're still in class 2 have a much better outcome. You catch them very late when they're in class 3 and 4. They have as bad outcomes or worse outcomes than those with untreated pulmonary hypertension. So you have to diagnose it early and you have to the better functional class very clearly do better than those in the worst functional class. And how do we make an early, accurate diagnosis? Of course, you must do a good clinical examination after taking a good detailed history, a structured history as my professor used to call it. But also, imaging plays this important part once you made a diagnosis of pulmonary hypertension in getting to the accurate diagnosis. What are the varieties of imaging we use? We use obviously chest X-ray, PA views, and lateral views. And somebody like Dr. Baburao Gadipati and Dr. Paramjyoti are probably experts at this. They're masters in the chest X-rays. In the old days, we also used to use fluoroscopy and barium swallow, and rarely we still do. But our go-to imaging investigation is the CT, including the HRCT. And when we suspect pulmonary hypertension, a patient always gets, and gets it very early, a CT pulmonary angiogram. This may sometimes be combined with the CT aortogram when we are suspecting shunts and other left to right lesions. And when we are suspecting group 2 pulmonary hypertension, the person also has a CT coronary angiogram. They can also have an angiogram, a coronary angiogram, a conventional coronary angiogram, as well as left and right heart catheterization before a final decision on treatment is made. But the entry point is often an echocardiogram, and sometimes when patients are not suitable for the CTPA, or when we want to look at myocardial disease, as for example in sarcoidosis of the heart, we use a cardiac MRI. And another very useful modality for sarcoid, cardiac amyloid, and other infiltrative myocardial diseases is PET-CT, including myocardial perfusion imaging. I'll start with this lady, Mrs. NB, a 48-year-old. She was diagnosed to have pulmonary hypertension 3 years ago, and then strangely nothing was done. And I think it's largely because COVID intervened, and she never saw a doctor, and the doctors had not advised any further follow-up. This was her CT pulmonary angiogram done recently at one of our major cardiac hospitals, and they still decided only to start her on a single drug. And what you're seeing here is a hugely dilated pulmonary artery. You can see how it compares with the aorta. And what makes you suspicious in this patient that you're probably dealing with idiopathic pulmonary hypertension is this huge, almost aneurysmal pulmonary artery. You do not normally see such huge pulmonary arteries in patients with other causes of PH. So this itself makes us very suspicious that you're dealing with idiopathic pulmonary hypertension. Another point which I'll come to later is the absence of collaterals. This is a late image. You're seeing images in the pulmonary artery still die, but you're also seeing contrast in the aorta, down to the descending aorta. This means two things. One, that we're seeing a fairly late image, and I will show you, how a classic CTPA should be done. But equally, it also shows us that the RV is probably failing. I have not put in images for lack of time, but therefore the emptying of the right ventricle is also poor, so it's still having contrast in it fairly late. So we did a workup after this patient was diagnosed to have probable group 1 pulmonary hypertension, because you have to rule out what is called associated PAH. A CTD workup was negative, as was the other findings that we looked for, including for for pulmonary veno-occlusive disease. We ruled out liver disease to rule out portopulmonary hypertension. We ruled out HIV. 3 of the important causes of associated PAH, which is also a part of group 1. We actually called it group 1 prime or prime prime. We did a CTPA. This did not show any obstructive lesions, no collaterals, and no shunts. You'd seen that earlier. And to be on the safe side, we did a bubble contrast echo. Sorry, that should not be bubble contact echo. It's contrast echo. Thank autocorrect for that. And that was also negative. So our final impression, this is group 1 idiopathic pulmonary hypertension. We started her on 2 medications. We will be reassessing her in 3 months with a reveal 2 light score or one of the other scores, and decide on escalating the treatment. Our second patient, Mr. HB, a 50-year-old, came to us with a history of recurrent lower respiratory tract infections, being treated for many years as asthma. His echo done outside showed RA-RV dilatation and pulmonary hypertension, with the pulmonary artery systolic pressure of about 56, which works out roughly to a mean pulmonary artery pressure of about 34 or 35. Examination was normal, but this is where we got the clue. He had an ejection systolic murmur in the pulmonary area and a fixed, widely split S2. Makes us suspicious of, for clinical reasons, an ASD, and that's what the echo showed. In fact, it showed a sinus venosus ASD, and you see his CT pulmonary angiogram, which always has to be done also. You see a hugely dilated RA and RV, and you're seeing no very clear-cut ventricular septum. You're seeing a good intact atrial septum, but you're seeing a partially absent ventricular septum, and you're seeing dye contrast, which despite an early scan has already gone into the left side of the heart. And this is the pulmonary artery, slightly dilated compared to the aorta, and you can see this in contrast with my previous patient, Mrs. NB, who had a hugely dilated pulmonary artery. Another patient of ours, Mrs. MR, a 37-year-old homemaker, and jumping actually to an acute problem, came to us with acute onset breathlessness and syncope, with no apparent earlier history except for abortions twice in the past. But she never had any respiratory or cardiac symptoms. We did a CT pulmonary angiogram because she fit into a very high simplified Geneva score and Wells score for high risk of pulmonary embolism. We didn't waste time doing a D-dimer because she was quite unstable. We straight away went to a CT pulmonary angiogram, and you can see multiple filling defects, none in the main pulmonary artery, but you're starting to see it in the beginning of the left pulmonary artery and in the origin of the right intermediate pulmonary artery. And as you go down, you're seeing clots in branches, lobar branches of these arteries, and going down into the beginnings of the segmental branches that you're seeing there, all the way down. And here we were a little suspicious that she's already got a dilated pulmonary artery. She's starting to show evidence of right ventricular hypertrophy, and you're seeing these vessels applied, the clot applied to the side of the vessel rather than the absolute center. And at this point, you start worrying a little about, is there a chronic component to this pulmonary embolic disease? You can see it classically here, rather than being in the center, it's attached to the wall of the pulmonary artery. So this may be a patient with an acute on chronic pulmonary artery disease, pulmonary thromboembolic disease, and here you're seeing this intermediate pulmonary artery is slightly expanded. That's a sign of an acute clot. When the clot becomes old and fibrous, it tends to contract, and the vessel becomes actually a little narrower. So here we have some evidence of acute clot with acute on chronic disease underlying it. So a very, very important thing here was this lady was Appler syndrome positive. So what we did was, because there's a significant acute component, we planned to put her on anticoagulants with coumarins, because that's what you need in Appler syndrome. Please remember that when there is Appler syndrome, there is no evidence for the direct oral anticoagulants or the novel oral anticoagulants. You need to use coumarins. That is the only evidence we have. We plan to reassess her in 3 months. We want to maintain a PTINR of 2.5 to 3. And we would like to maintain lifelong anticoagulation for her, given the fact that she had an unprovoked clot and that she is Appler positive. Another patient of ours, I'm coming back to Mr. HB actually, I don't know why those slides came in between. This was his RA and RV, and you can see his vessels showing, sinus venosus defect there. Leading to the diagnosis of an ASD, sinus venosus type. This was another gentleman. I'm now moving to this group pulmonary hypertension. The disease, a patient with group hypertension. Pulmonary hypertension, I'll remind you, this is a group 3 pulmonary hypertension is somebody with lung disease and hypoxia, which poses to pulmonary hypertension. So, and grade 3 MMRC breathlessness. He had hyperinflated lungs and an auscultation, vesicular breathing with prolonged expiration. There were no features of right heart failure. His heart sounds were normal, there were no murmurs. And he'd been stable. I've been seeing him for about 3 years on single inhaler triple therapy more recently, given as 2 separate inhalers in the past. And he was on regular vaccines and doing well. We did his CT because his echocardiogram, we always follow them up for cardiac disease also. As you know, there's a huge overlap, especially in a smoker, in risk factors, and therefore the coexistence of coronary artery disease and COPD. And in fact, you remember that in the TORCH study, almost 27% of patients who died of cardiac problems rather than respiratory problems. So his echo was quite normal, but his CT pulmonary angiogram, CT done at that time, this was a plain CT, HRCT, showed evidence of a hugely dilated pulmonary artery, and the ratio of the MPA, the main pulmonary artery, to the aorta is more than 1. That's very specific for pulmonary hypertension. And as you can see, I hope this projects well, the HRCT shows a good evidence of COPD, and he has fairly advanced COPD, hyperinflated looking lungs, increased AP to transverse diameter, and a lot of emphysematous disease, centrilobular, as well as paraseptal, and what looks like bullous disease. His echo findings, strangely, were normal. And while the cardiologist said there was a poor echo window, he was still fairly confident that the echo was completely normal. And I got it done twice, including by our expert chief of echocardiography. He's one of the leading cardiologists, non-interventional cardiologists. And so very important to remember that echo may be misleading, because I think this gentleman, given his RARV dilatation and the large pulmonary artery, has definitely got pulmonary hypertension. This is another gentleman who came to us recently. He's still in our ICU on a ventilator. Initially was prone and is slowly improving. Came to us with a short history of cough and breathlessness since 2 weeks, and he was being treated as asthma. Strangely, at 44, he had a previous history about 3 years ago of a cerebrovascular accident, but no details were available. He's a never smoker and has been complaining of joint pains and backache on and off, put down to the fact that he's in the shop all day and stands all the time. There was no arthritis, but he had arthralgia. And these complaints surfaced on and off. So this was his X-ray, and you can see between 10-7 and 19-7, there's been a rapid progression of these linear opacities and reticular opacities that doesn't project very well, but take it from me that this was what it showed. I was not able to play the CTs for this gentleman, and I took images, and you can see that the CT shows a definite increase reticular and linear opacities, increasing as you go from the apex to the base. And there's a combination of what looks like peripheral consolidations as well as these linear opacities. So when you see this combination of fibrotic changes and you're seeing what looks like organizing pneumonia changes, always start suspecting the possibility of an inflammatory myositis associated with an idiopathic, with an interstitial pneumonia. So this is IIM, idiopathic pneumonitis. I don't know why it's called that, because it's not idiopathic, and with inflammatory myositis. And you can see the same thing there, a combination of consolidatory changes and reticular opacities. We did his rheumatoid factor and anti-CCP, both were negative. His ESR was 55. His echo PASP was quite high at 66 millimeters of mercury, and his RARV were dilated. We sent off his ANA profile, and it showed the ANA immunofluorescence, fine granular 3+ nuclear staining, and condensed chromosome in his mitotic apparatus. ANA was positive at 3+, but he also had a Q of positive at 1+. But because we suspected the possibility of myositis, and these days we routinely send it for all patients where we suspect a UIP pattern or a CTD-related ILD, we sent a myositis profile, and lo and behold, he had an MDA5 which was 2+ positive. This is an amyopathic dermatomyositis where you don't see much of myositis in terms of inflammation of the muscle, but the MDA5 is positive. It has a terrible prognosis. This gentleman has already received pulse steroids. He has been on treatment for CMV, and he has received rituximab already. So we need to be very aggressive very early. The mean survival reported is between 3 and 6 months after a diagnosis is made. and most often patients have died within the first 1 or 2 months. Coming on to group 4, Dr. Vamsi, please tell me when I'm exceeding time, or whoever is online.
Dr. Murli,
This is a 13-year-old student, Miss CS from Goa. Long history short, she had features to suggest acute pulmonary embolism in 2002, went on to 2004, a repeat episode, and finally was found to have chronic thromboembolic pulmonary hypertension. CT done. Hi, Dr. Kaivan, tell me. Yeah? How much more time do I have? 2 minutes? Yeah, I'll wrap up in minutes. Okay, thank you so much. Sorry to disturb you all, but basically she has evidence of lots of clots and RARV which is dilated. You can see small webs in the peripheral vessels which suggest that she has got chronic pulmonary thromboembolic disease. And normally in patients with acute pulmonary embolia, you do not get a dilated pulmonary artery. She has moderate to severe tricuspid regurgitation, and you can see a lot of collaterals which tell you that there is chronic disease. And you can also see clot in the right pulmonary artery, which tells you again that this is chronic. So there's evidence of chronic pulmonary hypertension, and see the difference from acute pulmonary embolism, where you have predominantly central filling defects. Okay? And this is again an example of a central filling defect that you see in patients with acute pulmonary embolism. These are the clots that we take out in chronic pulmonary thromboembolic disease, and you'll agree they're nothing like the red to black acute clot that you see in acute PE. But what is very typical is bronchopulmonary collaterals, which tell you that you're dealing A, with chronic thromboembolic pulmonary hypertension, and B, you'll never see this in idiopathic pulmonary hypertension, something that you can see very classically in this way. Huge number of collaterals running between the aorta or bronchial arteries to the lung. And this came in very useful for this patient who was diagnosed to have idiopathic pulmonary hypertension, but some clinical features made me suspicious of CTEP. And when we did her CT pulmonary angiogram, we saw those collaterals, discussed it with our radiologist, because these collaterals suggested CTEP. We went on to do a VQ scan, and this showed evidence of mismatched perfusion defects in both lungs, suggestive of pulmonary thromboembolic disease, and she was advised pulmonary endarterectomy and has been doing well. The last patient, and I'm going to just fast forward, show you one video, and this is a patient who has come with what is called group 5 pulmonary hypertension. And I will quickly run through this. She has evidence of a lot of ground glassing. She had bilateral pleural effusions, larger on the right than the left. Look at her HRCT. You can see very clearly that there are a anterior upper lobe sign. And as you go down, you're seeing exuberant honeycombing. You're seeing a dilated esophagus. You saw that there was a pleural effusion earlier. And all of these pointed us to a diagnosis of CTD-ILD. And you can also see that she's got a dilated pulmonary artery, suggesting pulmonary hypertension. So she has both pulmonary arterial hypertension, part of group 1, and she's got CTD-associated ILD and hypoxia. So she's got a mixture of CTD-ILD, group 3 PH, and group 1 PH. I'll stop at this point and thank you all for your very patient hearing. Remember that imaging is extremely important in making a diagnosis of PH, in clarifying the diagnosis of PH. The diagnosis is made by a combination of echocardiogram and CT pulmonary angiogram, and goes on to sorry, I seem to be logged out. So goes on to get a good diagnosis, start your treatment early, and ensure better outcomes for your patient. Thank you.
Thank you so much, Dr. Murli, for that very lucid presentation. I don't think there are any questions from the audience. So I think, thank you so much once again for spending your time.
I don't seem to be hearing anybody, so I'll log out and thank you all for your patient hearing.
I think you are taking a small break as per the organizing committee. So because the next speaker is, so.
Welcome, Dr. Pawan sir. Now we will go for the lamp lighting session. Please come forward.
Yeah, I now request Dr. Pawan sir to come onto the stage and accept our this thing. I request Niranjana to come and give the book. I request Pawan sir to come onto the stage. Yeah. Thank you, sir. I welcome Dr. Pejit Chagre sir that promotes Dr. Lohia sir, and Dr. Shankar sir, Dr. Yugandhar Bhattu, Dr. Satish Reddy, our whole pulmonology team, Dr. Kirti, Megha, Niranjana, all of you to come onto the dais, and Dr. Vijendra, please come onto the dais for the inauguration ceremony. Lamp lighting, yes, sir. Dr. Srinivas sir, please come onto the dais.
Shubham Kurutvam Kalyanam.
Shailaja madam, please come on.
Shubham Kurutvam Kalyanam. Shubham Kurutvam Kalyanam. Arogyam Dhanasampadah. Shatrubuddhi Vinashaya. Deepajyote Namostute. Deepajyote Namostute. Deepajyote Parabrahma. Deepajyote Janardhana. Deepajyote Parabrahma. Deepajyote Janardhana. Deepo haratu me papam. Sandhyadeepa namostute. Shubham kurutvam kalyanam. Arogyam dhanasampadah. Shubham kurutvam kalyanam. Arogyam dhanasampadah. Shubham kurutvam kalyanam. Arogyam dhanasampadah.
I now request Pawan sir to come and speak a few words about the lung Instagram, and his words are always very precious and valuable to us. He is the visionary of all the pulmonology in the whole of India as well as in Hyderabad. We thank you, sir, a lot.
Thanks, Vamshi. So I don't think I deserve those kind of things. And nowadays, I'm not doing any bronchoscopies or anything. So we are lucky to have a top-class pulmonary department in our hospital. But even more than that, we have a top-class pulmonary team in Hyderabad. I think rest of the country definitely looks at us for all the things. So, including coming to that, we welcome Dr. Shubhakar Kanya and all for his leading efforts to do the NAPCON. The Silver Jubilee NAPCON is coming up in Hyderabad in a big way, and special congratulations for all of your efforts. I'm sure this will be a crowning jewel in the pulmonary department. Pulmonary itself is leading other specialties, and we are leading in pulmonary specialty throughout the country. So I think it will be special. So thank you, sir, and thanks for all your support. And it feels good to see all the leading luminaries. Pulmonary department for some reason is like really, really leading among all the specialties. I've been to so many other things. People sometimes are saying that I'm favoring pulmonary, but the academic sessions in pulmonary is in a different level. Like everybody is in touch with everybody, not only in city but throughout the country. And that's good though. So we may have a little bit of friendly rivalry and all outside, but inside we are all pulmonologists, and it's good to have discussions about everything. So, but especially thanks Vamshi and the team in Malakpet here to take special efforts about this lung Instagram. So, among all the glamour and hype about this intervention pulmonary and maybe transplant pulmonology, I think the bread and butter is depends on good imaging, and more importantly to recognize what exactly X-rays and CT scans and what exactly it is showing us. So we may not sometimes in future we may be forgiven for not having a stethoscope. Already many doctors are not having a stethoscope, I think, but X-rays and CTs, there is no alternative. I think we have to go through them, and but analyzing what exactly it is showing is a totally different art. And thanks all of our radiology colleagues and multi-specialty colleagues from other departments also who have come up here to have a great session. So pulmonary is not only intervention pulmonary, transplant pulmonary, sleep medicine and all, but we have multiple other things in pulmonary. So I think it's still, this is Silver Jubilee NAPCON. So maybe by Golden Jubilee NAPCON also we'll have further things in pulmonary to keep us all in work. And that's great to see so many people on a Sunday morning for different kind of sessions. So these kind of topics are really useful, and we thank all the delegates from all over the country who have participated in this, and all specialists, and most importantly all you delegates for attending these conferences despite getting the half day off. In India, doctors are like really busy. So in US and all, I can say that nobody works this kind of hours, like maybe 1 week on, 1 week off kind, or at the very least you get 2 days weekends off kind of thing. So despite that, you have taken your efforts to come here. So I'm sure you'll go much more enriched. And a little unusual, other thing unusual about pulmonary, the top people in pulmonary is everybody is very, very responsive to any kind of questions. So like if you do have any questions, please feel free to speak up, because these physical conferences, the advantage is you can ask the questions about some things which is not there in YouTube and all. What is your personal experience? How patient took care of this, and these kind of things are also there. So please feel free to interact with our delegates and make use of this opportunity even more. Thank you all.
Sir, I request you to stay on stage for a while. I request Dr. Gandhar Bhattu, Dr. Satish Reddy and Dr. Lohiya sir to come onto the stage. We have a small gift from the Department of Pulmonology, Malakpet, to our most precious and sweet director, Dr. Pawan.
You will not get a special increment for this.
We are not expecting, sir. We are not expecting at all.
So Vamshi is saying this is done through artificial intelligence and digital. So next time you have to do a hand-painted one.
This is painted on iPad, sir, actually, with hand and then digitally printed.
Wow, that's great. So nice.
Thank you, sir. Sir, I now request Dr. Subhakar, sir, and all the dignitaries in the conference hall for the NAPCON, prestigious NAPCON we are holding in Hyderabad this year for the Silver Jubilee NAPLON. I request Dr. Subhakar Kandi, sir, to come onto the stage. Dr. Pedri Wagre, sir, Dr. Pramod Kumar, sir, Dr. Bhaskar, sir, Dr. Pawan, sir.
With the permission of Vamsi, 1 minute, in fact, I am coming your way. I think for the first time in Hyderabad is hosting NAPCON, that is Silver Jubilee Conference. In the most difficult, challenging situations, I think everybody knows. But in spite of that, we have done a pre-NAPCON survey by the industry. Can I tell the result of the pre-NAPCON survey? 88% are favoring Hyderabad NAPCON. So it is going to be a wonderful event. 12 international societies, American College of Chest Physicians, Cleveland Clinic, Nepal Thoracic Society, Sri Lanka Thoracic Society, Bangladesh Society, Emirates Society, Egypt Society, you name Saudi Arabians. So almost 12 international societies are partnering with us, and they are coming on their own to Hyderabad without our travel expenses. The only thing is local hospitality. So for the first time, we are having a Cleveland Clinic symposium with 9 doctors coming from the Cleveland Clinic, Abu Dhabi, and Cleveland Clinic, Ohio. So this is going to be a wonderful experience, and all this is possible with the effort of the Yashoda Hospitals, because 2 faculty are instrumental of the Yashoda. One, Nagarjuna, is driving the seat of the scientific, coordinating with it, and Harikrishna is doing the interventions. So marking Silver Jubilee, we have come out with an idea of 25 workshops, and it is going to be wonderful. I request Pawan also to launch this poster in front of him. Salja. See my friend. I think you are breaking for a tea and join the remaining session after 5 minutes only a small tea break.
One of my friends he off this. Narzima, live ఆగిందా? కాదు ఇప్పుడు క్రమంలో ఉంచాలా తీసేయాలి అది తీసేసి చెప్పేసి వాళ్ళు ఫెస్టివల్ ఉన్నా ఏం చెప్తున్నాం ఓం ప్రకాష్ సార్ లైవ్ ఆగింది కదా నేను కెమెరా ఆఫ్ చేసేసాను ఫుల్ స్క్రీన్ చేసి
हमारा कागनी जाएगा अच्छा भाई बस चकाचक दोस्त चलो प्रिपरेशन प्रैक्टिकल મારી તો બીજી ઓક્ટોબર હા સોરી 12 ઓક્ટોબર 12 થી 15 ભાઈ બસ બેઠા છે શાંતિથી એવો વાંચો છો ત્યારે ભાઈના ફેબ્રુઆરીનો લગ છે વાંચો તો ખરો ભાઈ ત્યાં કંઈ વાંચતો નહીં એટલો ટાઈમ મળે એટલે વાંચતો હોય બહુ વોટ્સઅપ થઈ ગયું જુનિયર ના 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 હજી હવે આવશે ને ઓગસ્ટમાં આવશે કદાચ ચાલ
हाँ डाउनलोड किया ये
I request all the delegates to gather back for the next session.
I request all of you to come inside because we will be breaking down after one session into lunch again, and so that we will have a lot of time for lunch. I request everybody to come inside. Kirti.
I request all the people who are taking tea, they can come with their glass inside. So, Pramod,
that's okay, sir. I'll come down. What's sir? Pramod sir, sir.
Yeah, Pramod. I think Paramjyoti could not attend the meeting, and Vamsi is speaking on his behalf just.
Yes, already done, sir. So no, nothing like that, sir. In the first session, it is over anyways.
Introduce. Okay. The topic is when drugs become the disease.
Pattern paraphrasing the must in ILD. Yes, sir. Dr. Paramjyoti sir had an emergency and he could not come. Since we do not want to cancel the title. So I cooked it up right now from morning. So pardon me if there are any glitches in the technical slide making and anything. But I just wanted this topic to be discussed precisely because interstitial lung disease is all about pattern.
Okay. The stage is yours. Start.
Okay, sir. Thank you. రావట్లేదు ఇక్కడ చూడండి. Okay, thank you. So pattern paraphrasing the must in ILD. In interstitial lung disease, we have gone into the stages of doing biopsies as a routine nowadays. In some ILDs, which is recommended, and in some ILDs it is not recommended, but we have gone for transbronchial lung biopsy, transbronchial cryobiopsy. We have gone to advancements in pulmonology where we can get a diagnosis precisely as to what type of ILD it is, so that we can treat it according to the pattern and the natural course of the disease and which pattern it belongs to, because every pattern has its own prognosis, just like Dr. Bhaskar sir was saying. And interstitial lung disease in many occasions is associated with connective tissue disease, which was the topic earlier, and CTD ILDs form a major chunk of ILDs, and the most of the ILDs we see, we need to evaluate for any underlying CTD, because not every time the patients might have symptoms of connective tissue disease, and this entity in which there are predominant features in the lung in the form of ILD, but there are no clinical features of connective tissue disease in the patient, was initially called as unclassified connective tissue disease, and then was called as lung dominant connective tissue disease, LDCTD, and then called as AIF-ILD, that is autoimmune featured ILD, and now it is being called as IPAF, that is idiopathic pneumonia with autoimmune features. So ILDs are a major chunk of pulmonary practice, and there is a lot of scope in ILDs, and ILDs going to be a subspecialty clinic. Already there are subspecialty clinics of ILD started by Dr. Nagarjuna and others in Hyderabad, and they are doing really good. And ILDs, there will be pulmonologists who will be practicing exclusively ILD down the lane 5 to 10 years. So with that introduction, I just wanted to put a few theory slides before going into the cases, because many of us will always have a hazy vision of what exactly the interstitium is, what are interlobular septal thickenings, what are intralobular thickenings, what are the nodules, what are the random nodules, what are the ground glass nodules, what are the central lobular nodules, and there will be so much confusion. I'm not going into the theory part of everything, because ILD in itself is a one-day CME, and I just want to touch base on basic points. As you can see here, there is the intralobular interstitium in the lobule. There is an intralobular interstitium in the lobule, and we have the peribronchovascular interstitium, we have the secondary pulmonary lobule, which is the basic thing. These things we need to identify on the CT. The more and more you sit along with the CTs for hours together, you will be able to identify each and every line in the CT, which is important. Every line in the CT matters when it comes to ILD. And then we need to see the association with the pleura, subpleural interstitium. We need to see the interlobular septa. We need to see the intralobular interstitium, because every ILD has its own predominant features and basically patterns. There is a lot of overlap between patterns, but every pattern has its own specific characteristic and unique feature. So the normal secondary lobular anatomy is what is most important, and if this lobule anatomy we know and we have in our mind, we can transform the 3D picture into the CT, and we can appreciate what are those lines, whether they are ILS thickenings, whether they are intralobular thickenings, or whether they are something else, and depending upon the presentation and the clinical scenario, we can say whether it is an ILD or anything else presenting in the form of an interstitial lung disease. So as we all know, into the secondary lobule goes the pulmonary arteries and the veins and the lymphatics, and the bronchial opens up into the lobule, and the lobule is having usually 4 to 5 sides, and the secondary lobule will appear like an extended triangle with 2 legs, and anything inside the lobule, the DD is again changed. So here again we can see that the interlobular thickenings, we can see how they are, that is between the secondary lobules, and we can see the parenchymal bands, which are most commonly seen and are not really very clinically significant. We have the intralobular interstitial thickening, wherein you will be able to find thickening inside the lobule, that is in between. There might not be interlobular thickening, but there can be intralobular thickening, wherein that will give you a different DD. There can be honeycombing. Usually it is along the subpleura. It will be in lines. It is not a single straight line, but to develop with, and if you're catching it very early, maybe there can be 1 line of honeycombing, but usually honeycombing, if it is more than 1 line, we call it as honeycombing. And traction bronchiectasis is one thing which is very important for every pulmonologist to appreciate in any form of CT, because the presence of traction bronchiectasis says that there is fibrosis, and it has the potential to become a progressive fibrosing ILD. So traction bronchiectasis is something which we cannot miss to appreciate on the CT scan. So still there will be a lot of confusion about what is hyperattenuation, what is hypoattenuation. So as pulmonologists and radiologists, we should only be talking about attenuation when you're commenting on the CT, and as opacities or nodules, as opacities when we are talking about X-ray. So in the HRCT, if you take the increased lung, sorry for the poor slide, increased lung attenuation, there will be nodules, opacities, and all those things, and cystic lesions, and the hyperattenuated parts will be the air trapping, the mosaic attenuation, and all these things. So now here are 2 cases where The arrow is. Okay. In the first case, you see, if it's a case of lymphangitis carcinomatosa, if you see on the right side, you see the lung is absolutely normal. On the left side, if you see, there is a kind of shrinkage of the lung. You can see so many lines, you can see so many dots. All those things are inter-ILS thickenings and nodules which are present inside the lobule. And whenever such kind of interstitial pattern is confined to just one lobe or two lobes or one side, and if there is a soft tissue attenuation also on a mediastinal window, or if there is any suspicion of malignancy elsewhere in the body, then the first thing that should come to mind is lymphangitis carcinomatosa rather than an ILD, because lymphangitis carcinomatosa is a very important differential diagnosis of ILD, and it changes the whole diagnosis and treatment of the patient. One should never miss identifying lymphangitis carcinomatosa. The most important feature is that in this there will be irregular nodules. I wish I have the pointer. I have some other cases also. So there will be irregular nodules along the fissures and along the thickenings, which is a clue to say that it is lymphangitis carcinomatosa. If at all the nodules are smooth, then it can be sarcoidosis, and it can also be other causes of nodules. But if it is irregular, then you have to suspect lymphangitis carcinomatosa. So the configuration of the nodules along the ILS thickenings also makes the diagnosis. And the second case you see here is a sarcoidosis case, wherein you can see the perilymphatic nodules. It is around peribronchovascular and perilymphatic nodules. They are smooth. There are random nodules. There are peribronchovascular nodules, there are perilymphatic nodules, and if you can see, some part, the uppermost part of the lung is, one part of the lung is paired, and they're mostly perihilar in distribution. And as a rule, except the centrilobular nodules, any nodule can go and sit near the pleura, except the centrilobular. If some nodule is abutting the pleura and or very near to the pleura, it cannot be a centrilobular nodule. So except that, the random and other nodules can touch the pleura. So now coming to intralobular thickening, if you can see, I have put an example case beside, which is a case of hypersensitivity pneumonitis. You can see that in the image on the right side, on the left side of the lung, in the upper zone, if you see, what you see is intralobular thickening. Actually, I request the audience not to take photographs, because we have privacy issues here, and with our patients, we had to put some sections with the names and all, because radiology is cannot be explained with one section. It's my sincere request for everybody not to take any pneumophotographs. So this is a case of hypersensitivity pneumonitis, and if you can see, there is intralobular fibrosis in this case. It's a case of hypersensitivity pneumonitis. Usually honeycombing fibrosis occurring in the upper lobes or in the middle lobes at one end, which is not predominantly in the lower lobe. We suspect HP. We will see that later. And again here, if you can see in the first case, the arrow mark shows, the bigger arrow shows the pulmonary vein, and the smaller arrow shows the ILS thickening. If you see the smaller arrow on the right side of the lung, you can see that there is a triangle with the base to the pleura, which is actually the secondary lobule. That is the secondary lobule, and that is interstitial thickening. Interstitial thickening happens in pulmonary edema very frequently. In most of our ICU referrals, whenever the patient lands up in cardiac failure, we see a lot of pulmonary edema cases. There will be effusions, there will be lobular septal thickenings, and when there are no other features suggestive of any other issue, and when there is fluid overload also for any reason, you will see pulmonary edema. So on the right side, you see pulmonary edema. On the left side, if you see, it is again, you can see the nodules along the thickening, which are very smooth in configuration, and that is sarcoidosis. So in the first case here again, the arrows show that this is a kind of interface sign where the pleural surface is irregular and is disrupted, which is characteristic and pathognomonic of idiopathic pulmonary fibrosis. And you see the arrows, there is an interruption, and you can see that there are also linear opacities coming down from the pleura. They are not lobular thickenings, they are linear opacities. ILD is all about about linear opacities, reticular opacities, ILS thickenings, intralobular thickenings, intralobular fibrosis, and a configuration of all this in different patterns, in different lobes, in different temporal distribution, in different spatial distribution is forms an ILD pattern precisely. So in the second case, you can see that again, it's a case of lymphangitis carcinomatosa, where we can see that in the lower part of the lung on the right side, there's an effusion, there is a soft tissue attenuation. Of course, it's not some mediastinal window, there is an opacity, and you can see that there is uneven distribution of ILS thickenings on the right side, but on the left side, it's absolutely normal. So it's again characteristic of lymphangitis carcinomatosa. So unilateral ILD we call it usually. It's a very bad layman term, but unilateral ILD is usually suggestive of lymphangitis carcinomatosa or ILS thickenings and all confined to one part of the lung. So this is another case where, sorry for the poor resolution, but that's the reason I have zoomed it out and put it the next. You can see that there is honeycombing on the right side, on the right image, over the base, over the lateral aspects and all. This is all honeycombing. Along with that, you can see secondary lobular thickenings. You can see triangular, lobular, and spaces of thickenings, and also honeycombing. Very characteristic of IPF, and in this patient you will typically be hearing clinically velcro rails, and that should raise a suspicion of probably there is a possible honeycombing in this patient. But velcro rails are not diagnostic or pathognomonic of honeycombing. Velcro rails can also be heard if there are ILS thickenings at the base. So velcro rails does not mandate that the patient is having honeycombing and fibrosis, but if you see microscopically, the patient might be having early honeycombing and they might progress, and these are the kind of patients who need close follow-up and monitoring both clinically and radiologically. Now, if you see on the right side, this patient is a young 30-35-year-old female who presented with SOBN exertion since 4 to 6 months and dry cough, which is not resolving with so many medications she has taken. Only X-rays were done, and we got a HRCT done. And if you can see, the resolution is bad on the right side. On the left side, on the right side, if you see, there is differential attenuation. You can see hyperattenuation, and then you can see normal lung and hypoattenuation, and you can also see some bronchiectasis on the left side. On the right side of the upper in the upper sections and all. So this patient also has coarse crackles. There may be associated bronchiectasis, but this patient is essentially having air trapping, and it's almost an imminent head cheese sign. And if you see the lowermost section, you see that there are some emphysematous spaces in between the ILS thickenings and the interstitial pattern. So emphysematous spaces occurring between interstitial thickenings or fibrosis is suggestive, very much suggestive of hypersensitivity pneumonitis, HP. So in HP, emphysema is different. In COPD, emphysema is different. This emphysema is formed because the lung is torn apart by the interstitium, and it doesn't have any other way, so it gets filled up with air, and there's an emphysematous space which forms between the reticulations or the interstitial opacities. So this case is an imminent case of head cheese sign over a period of 2-3 months probably, but this is clinically suspected HP. We were not able to evaluate her. In every case of HP, suspected HP, we need not do a biopsy. Sometimes, most of the times, at least our department, we do not go for aggressively for biopsies unless and otherwise the diagnosis is really uncertain. And in this case, we started treating her like hypersensitivity pneumonitis, and she has shown very good clinical resolution, clinical improvement. Of course, radiological resolution does not happen with irreversible changes. So this actually is a transition from acute to chronic HP, which is a older nomenclature, which is acute HP, subacute HP, and chronic HP is older nomenclature. Now it is all about fibrotic HP or non-fibrotic HP. So if you talk in older terminology, this is a transition phase from acute HP to chronic HP. In between, you are seeing mosaic attenuation, which is characteristic of subacute HP. So you caught this patient basically when she's going into the fibrotic HP stage. There is fibrosis, obviously, and she was having having bilateral velcro rails, and if you see the video, you can definitely appreciate the honeycombing at the extreme basis, and that is why in ILDs, films does not give any information. It should be a video presentation, and it should always be a video you have to see before diagnosing it as an ILD, because videos give much more information. As all of you know, a video of CT will have more than 300, 400, 500 sections, and all you get is some 40, 50 sections on the CT film. You are missing everything in between the sections. So there will be a lot of information which might be, and that is why sometimes you find the discordance in the radiology report and what we see, because what they see we can't see on the films. That is why videos are always preferred when it comes to any lung disease, more so in case of ILDs. Now, this is a case of rheumatoid arthritis, which got admitted in the ICU with acute respiratory failure, probably because of some secondary infection. She was on steroids and MMF, and she was subsequently intubated. It was at an outside hospital. They came for an opinion, and this case I have reserved only because if you can see on the right side, you can see that sorry, if you can switch off the light, the marker will be seen. Light. Recording of the light. That's okay. So if you can see, there is mosaic attenuation on the right side. There are patches of hyperattenuation, hypoattenuation, and you can see interstitial thickenings and all. And the image on the right side, if you see, that coronal view gives a very good clarity of how there are hyperattenuation areas on one space and normal lung in between and all. This is the case of bronchiolitis obliterans in a case of rheumatoid arthritis basically, and bronchiolitis obliterans in a case of rheumatoid arthritis. What we pulmonologists have to do if we identify BO in a case of RA is that we need to request the rheumatologist to augment the dose of immunosuppressant therapy. That is the only way out, and we cannot, as pulmonologists, we do not have anything to offer to them. But our job is to identify the bronchiolitis obliterans in a case of RA whenever there is a mosaic attenuation in a case of RA. So because in RA mostly you find either UIP pattern most of the times, or very occasionally an SIP pattern, and sometimes rheumatoid nodules very occasionally. But bronchiolitis obliterans is a well-known association with rheumatoid arthritis, and it needs to be identified as early as possible with sequential CTs so that we can request the rheumatologist to augment the immunosuppressant dose. Because the rheumatologist always sees in two ways, remission and flare-up. As soon as they flare up, they increase the dose and slowly reduce the dose. But they do not, most of the rheumatologists, of course it's their discipline, it's the lungs are not their purview, it's our purview. That's the reason rheumatology and pulmonology are very closely associated, and we should be behind them to also see the lungs at least once in every 3 to 4 visits, so that sometimes there can be a new onset lung involvement, sometimes there can be a deterioration in the lung involvement which is already there. So this cystal and the honeycomb cystal varia, I wanted to say, because this is a case of scleroderma. As you can see, a dilated esophagus below the trachea. I think everybody can see in the section on the right side also. And the honeycombing which we usually see is different from this honeycombing, because this is a case of macrocystic honeycombing in a patient of scleroderma, and this patient is being treated by a rheumatologist, but she has a refractory cough and SOB, and she absolutely does not have any sputum. But most of the times macrocystic honeycombing is not uncommon or rare. It's not rare but uncommon, but we usually do not encounter in regular practice. What we see is the microcystic honeycombing. But macrocystic honeycombing, according to the configuration of the cysts along the bases, the lining up of the cysts, and the microcystic honeycombing also, which you can see in the upper parts, adjacent to the macrocystic honeycombing, shows us that this is the macrocystic honeycombing and this is the microcystic honeycombing. So basically this is a case of scleroderma with macrocystic honeycombing. There is a chance that this can be treated as a case of cystic bronchiectasis, and whenever there is macrocystic honeycombing, we might also miss on the antifibrotic agent because we might think it's a cystic opacity, maybe something else related, and it's not honeycombing. But the thing is that the idea behind putting this this case is macrocystic honeycombing does exist, and most of the times it associates with microcystic honeycombing. Antifibrotic agent should not be missed, and it should not be treated like cystic bronchiectasis with all the conventional treatment for bronchiectasis, because cough is not going to resolve unless you put an antifibrotic, even though there are refractory coughs in ILD and we cannot control the coughs many a times. And this is the coronal view of the same patient. The coronal images are a must see in ILDs because it will tell us as to how the distribution is from the top to the bottom, whether it is upper lobe predominant, mid lobe predominant, or lower lobe predominant, or if it is patchy, or if it is having any GGOs, or if it is having any other features. So that differentiation from the top to the bottom is most important. Here you can see that the honeycombing is very much confined to the bases, and it's basically almost a UAP pattern in a case of scleroderma. So nodule distribution might change the ILD diagnosis. All nodules are not a part of ILD. This patient I specifically put in the ILD session because the nodules are of two etiologies here. This patient presented with cough with expectoration and SOB and minimal exertion. He has been working in the stone crushing industry for 20 years, and he has a cavity in the right upper lobe. If you see the nodules which are present, we could otherwise attribute it to tuberculosis because there's a cavity, the patient is having cough, fever, loss of weight, appetite, everything, every constitutional symptom he has. But if we ask the occupation, then probably our diagnosis might change. Of course, there is no significant treatment for silicosis, but the thing is that we can at least say that you're having silicotuberculosis, and tuberculosis can be managed, but silicosis is a different ball game, and there's nothing to do about it. And we should monitor silicosis. This is a case of simple silicosis where there is no progressive massive fibrosis or anything, but there can be progressive massive fibrosis over a period of time, and these patients should be monitored for PMF, and there is no absolute treatment for silicosis or accelerated silicosis or silicosis with PMF. But this patient, around 40 to 50% of the nodules have disappeared at the end of TB treatment, and the cavity was still there in a rudimentary stage, but the nodules of silicosis were intact. So HPs are not uncommon. Hypersensitivity, in fact, in a study made in India, in North India, it has shown that the HP is very high compared to South India. We know that can be probably because of more interventions that's once upon a time around 5 years back, more interventions being done for HP and diagnosing HP specifically with a biopsy and all. But we see so many HPs, especially in Hyderabad, with all the kind of PGNs around. It's not just PGNs, there are so many risk factors. And my colleagues who are doctors had hypersensitivity pneumonitis because of they never cleaned their AC vents in the car. There can be ILD HP because of uncleaned and air filters in the ACs, and we usually blow it on our air. So even the car vents are risky for HP. HP is not uncommon. HP is very common. The only thing is we need to have an eye to see at it. And this patient is a young female who came around 32 years old, who came with SOB on exertion since more than 6 months, cough going on and off, and a CT was advised, and we could see that there is again hyperattenuation and mosaic attenuation. If you can see the lower side at the coronal images, you can see that the upper half of the lung is hyperattenuated and the lower half is hypoattenuated, and that is called the straight edge sign, and which is usually suggestive of an underlying connective tissue disease. So this is clinically looks like HP. There were velcro rails also, even though the opacities are not seeming to be like honeycombing. There were velcro rails. That is the reason I asked for HRCT. Otherwise, I would have gone for a normal chest X-ray and everything. So this patient was suspected to be having hypersensitive pneumonitis, but was to be validated for CTD, but could not because of various reasons. So the thing is that smokers do have ILDs apart from COPD, yes, but it's not uncommon. We all know the ILDs there are smoker ILDs, the RB ILD and the DIP, but we usually confine it to the literature and to the exam questions. But in clinical practice also, if we can concentrate a little bit, we can definitely diagnose ILDs in smokers. This is a patient of mine who had a history of TB. There's loss of architecture in the upper in the upper lobes, and there is history of COX in this patient. There's an active superadded infection, and if you see in the lower zones, there are ground glass opacities and superimposed nodules. Lower lobes, ground glass opacities with nodules in a smoker, suspect diffuse disclamative interstitial pneumonia, DIP. And if the same thing is there in the upper lobes, suspect RB, ILD. Disclamative interstitial pneumonia is actually clinically more protracting and difficult to treat than RB, ILD. And this is a case of rheumatoid arthritis, and this patient has been on maintenance steroid and methotrexate. I don't have time, so I'm just going fast. This patient has having rheumatoid arthritis, is on maintenance dose of steroid, is on methotrexate, has been admitted to the ICU in view of deteriorating sensorium, and there's a fall in saturation suddenly after the first day, and then a referral was given to us. And once we saw the CT, we could see that there was, because there is rheumatoid arthritis, we initially thought it is an ILD, but this pattern does not fit into any single pattern because there was very haphazard distribution all over both the lungs, with ground glass opacities, with ILS thickenings, with reticular opacities, with linear opacities, and all kinds of features you see in an ILD. And so provisionally this patient was diagnosed to be having methotrexate induced pneumonitis, methotrexate in lung disease, and methotrexate was stopped, and the steroid dose was actually augmented, which was actually stopped in the ICU because in view of an active infection. But we increased the steroid dose, and then the patient's saturation started improving. So all opacities on X-ray are not infections, and sometimes you need to identify the cause. So because we identified that it could be methotrexate induced methotrexate lung, so increasing steroid, starting steroid dose or increasing the steroid dose will actually make the patient better. And after starting steroids, 3 days, 4 days into the steroids, his saturation again improved, which was below 85, 80, and then he slowly improved to 1992, which was like normal for him. And he has been shifted from the ICU to the ward and then to the house because he's already a bedridden patient with Parkinson's disease. This is one case of mine who has been extensively validated in Australia for sarcoidosis. The funniest part is that this patient has been done colonic biopsies, small intestinal biopsies, every investigation which can be done, including BAL for CD4 CD8 ratio. In this patient, the CD4 CD8 ratio was more than 6, and anything more than 3.5 is considered to be diagnostic of sarcoidosis. And this poor guy is an Indian. He's from Hyderabad. He went there for working, and he spent like 5 to 7 lakhs and up to 10 lakhs for the investigations, evaluated by gastroenterology, by pulmonology, by general physicians, by family practitioners, everybody, but they were not ready to start steroids in him because he's from India and they still suspect TB in him. And that's the reason this guy came here, just to rule out TB. They have done everything, BAL for gene expert, everything, all are negative, but still they were skeptical about the possibility of TB in this case. And there are all symptoms of sarcoidosis like SOP exertion, cough, there was weight loss, probably he had TB and it's gone, I don't know, but loss of weight is uncommon in sarcoidosis. I started steroids, I put in a tapering dose because he was leaving to Australia in 10 days. I put him a dose for 3 months, and then I'm in touch with him. He's tapering the steroids and is doing good now. Now, a little bit into oncopulmonology. Actually, oncology should have been a predominant part because there are so many oncologists here, radiation therapists and radiation oncologists and oncologists. But we could not put an oncology session because of loss of time. This is an interesting case of a stage 4 non-small cell carcinoma. That is basically it's an adenocarcinoma. This patient has been on osimertinib. As you can see on the left side, there's a As you can see, on the left side, there is left lower lobe, there is a lesion, and this patient was actually planned for a routine PET CT. He came for a routine PET CT, but before coming to the routine PET CT, he just had 1 day history of fever and mild cough. So an X-ray was done, which was suspicious of some kind of opacity. So a CT was done by the oncologist, advised by the oncologist, and the CT showed opacities, new onset nodules and opacities in the right upper lobe and the left upper lobe. This patient is also having an incidental azygous lobe. That's a different issue. But because the patient is on osimertinib, which is a 3rd generation tyrosine kinase inhibitor for EGFR positive mutation, and he is immunosuppressed, obviously, we have to rule out infection before going for any other further treatment. And the routine PET CT is anyways stipulated. So this patient, we we have done a routine investigation suspecting that this can be simple pulmonary eosinophilia. Maybe it is due to osimertinib, and it turned out that he has eosinophil of 35% and AAC of 3,350, and the ball culture was sterile, the gene expert was negative, and everything else was negative. This patient was actually supposed to be put on steroids, but we didn't put on steroids because we wanted to see if the opacities are resolving on stopping osimertinib, because then it fits into the diagnosis of TAPO, which is transient asymptomatic pulmonary opacities. This can happen with many drugs, and according to the guidelines, it comes under the the DRP, that is drug-related pneumonitis, and TAPO comes under grade 1, which is actually not bad, but it resolves on its own. You need not put steroids. And the bad part is that eosinophilic pneumonias or eosinophilic nodules are FDG avid on PET, and this patient was as usual done the PET scan after the CT, and PET scan showed FDG avid nodules in the same areas where you could see the nodules earlier. So osimertinib was stopped. There was spontaneous resolution, and the drug-related re-challenge is an issue. Basically, the point is that in most of the TKIs, if they're causing any side effects, you stop the drug, and if you're restarting the drug, re-challenging with the same drug, then the patient might have very serious consequences. So we have to always be careful, but luckily with osimertinib we can re-challenge, and osimertinib was again started in this case. This is a grade 1 DRP, but grade 4 DRP is life-threatening, and that has a separate criteria. So the TAPO is very few cases are reported in literature, can happen with osimertinib and other TKI inhibitors also. And in fact, patients who had TAPO had more progression-free survival and overall survival, PFS and OS, basically. So occurrence of TAPO is actually a good sign for the patient because there is increase in PFS and OS. So this is a case of diagnosed CA breast, incidentally detected ILD on PET CT, that is CT films of PET CT. This is a case of BOOP. As you can see that BOOP in the sense of organizing pneumonia, peribronchovascular consolidation. You can see that all sign in the first section on the lower lobe, left lower lobe, and there is peribronchovascular consolidation, very typical, which we saw in the COVID season. But this patient incidentally detected, known case of RA, but incidentally detected ILD on PET CT. Patterns do change over years. The first CT is of one of my patients around 4 years back. He came with cough as the usual complaints, and the CT was done, and it was there were peribronchial opacities, and it was an organizing pneumonia pattern. But he was having Velcro rails, wherein I couldn't resist myself from starting on Perfinex because I was suspecting that there might be microcystic honeycombing in that patient. In spite of being on an antifibrotic, he came to me recently after 4 years because of some logistic issues, and the CT now shows a UIP pattern. So BOOP from UIP to UIP, I do not have the evidence of biopsy with me for sure, but on radiology we can see that there are peribronchovascular consolidations, and then on the other side we can see that there is basal honeycombing and all the features of UIP. If you can see closely, you will be able to appreciate. So patterns do change over years, and we never know which patterns evolves into which pattern. So in this patient presented with acute respiratory failure as a case of acute community-acquired pneumonia. She was intubated and then extubated. But right from the beginning, we are suspecting an underlying CTD because she has bilateral Velcro rails on examination. And after the resolution of all the opacities of the active consolidation, we again repeated a CT. We could see this pattern, which is like a head cheese pattern. But then this patient turned out to be having anti-Jo1 positive. It is a case of anti-synthetase syndrome. And this is basically an idiopathic interstitial pneumonia, which is usually less commonly diagnosed and less talked about ILD, and which is an evolving subspecialty, sub-subspecialty in ILD with the advent of myositis profile we have now in hand. Though it is costly, there are so many cases which are negative on ANA profile, but OJ and all these things come positive on myositis profile, which has now become a part and parcel of ILD evaluation. So this, I'll stop with this case. This case works as a warden in a hostel, and she basically cleans the PGN droppings. She came with SOP on exertion since 1 week. If you can see on the right side, there is so much of mosaic attenuation and all. If you can see on the left side, the one feature is on the left side, you see there is reduced vasculature, increased attenuation, hyperattenuation, and reduced vasculature, which is sufficient enough to make a diagnosis of HP with the kind of history we are having. I treated her in lines of HP and she's doing good now. This is a case of miliary tuberculosis. No ILD is complete without presenting a case of miliary tuberculosis. Unfortunately, this is a young girl who did not take ATT properly, and somebody started steroids for her for the miliary part, and she had a pneumothorax and presented to us. And again, this is a case of hypersensitive pneumonitis. You can see the head cheese pattern, the 3-density pattern over the bases. This is a case of lovebirds associated HP. This patient had SOB since 1 year, that is around 6 months to 8 months after she rescued a pair of lovebirds in her home, and then she started having SOB. All this was with deep probing of history. There were no risk factors initially. For the first 2 visits, she never talked about the lovebirds, but then at every visit we asked about history, and then she told that she rescued a pair of lovebirds and spending with that the whole day. And then association is there between lovebirds and HP in literature, and we considered this as a case of, she is still under my follow-up since last 8 months and she is doing good, though radiologically there is no much change. Thank you.
Dr. Vamshi presented very clearly and lucid. It is useful for the beginners to read the CT scan. I think the one observation is radiologists have the films video, they give a differential diagnosis. As a pulmonologist, we have a patient and a history. With the films, we can come to a conclusion.
Yes, sir.
With the history and the patient available.
Yes, sir.
So that's why the last slide also, you repeatedly ask questions, the diagnosis of.
Yes, sir.
And last one is drug-induced. I think we forget most of the cases in.
Yes, sir.
Forget the drug, what he's taking. If you take detailed history, what type of drugs he's taking, that will give clue to the diagnosis.
Yes, sir.
Observation. Thank you.
Yes, sir. Thank you.
I think thanks Vamsi for stepping into the shoes of Param Jyoti, and also I think you have covered some of your next topic.
I covered the next topic.
Yeah,
also.
I thought because we are missing a topic, and then I saw the slides.
Yes.
I think you worked with some Trivikram for writing. All these titles are very good. So I want to use your services for the NAPCON scientific.
Definitely,
committee.
sir.
Yeah.
Anytime.
Yeah. So very good. I think there are some of the. I think that's why you are asked to not to take photographs, because there are a lot of signs are there. A tall sign one.
No, not for the signs, sir.
Yeah.
Honestly,
one of the case I have seen
names.
a teardrop sign at the Ajaga slope.
Yes,
so
sir. Yes, sir.
all those exercises, very beautiful films. I think you did a great job. We have time for questions. I think. Yeah, please.
Very nice presentation.
Thank you, sir. Thank you.
Actually, before starting any oncology treatment, it is mandatory to have basic, at least chest X-ray, because most of the drugs like bleomycin, already you have covered other drugs also. Lot of drugs have interstitial lung pneumonia or miliary mottling. So if you have basic CT scan before starting our treatment, and we should also get a pulmonary function test. We most of the time we only get a 2D echo and cardiac fitness, but I personally, most of our chest hospital specialists will be knowing that I always get a pulmonary function test done before starting any treatment, oncology treatment, because these two things will help us in monitoring the disease, and also patient will not die of these pulmonary complications, because when they land up with end stage lung disease, it is very heartening. We would have cured the cancer, but the patient would have died with this end stage lung disease. So this is a must before every, I think in future guidelines also it should come that before starting any major chemotherapy or any treatment, we should get cardiac fitness. Anyhow we are getting, along with that chest X-ray and pulmonary functions and pulmonary fitness we should take, I think. Thank you.
Yes, sir. Sir, that has become a routine now, because in most of... Welcome, Arvijay Kumar, sir. Thank you.
Yeah.
So that has become a routine now, because every chemotherapy started only... after a definitive diagnosis of cancer, and nowadays no cancer is initiated treatment without a PET CT, which obviously will get the lung windows and we'll be able to know what is there in the lungs. So probably because we have the privilege of being in tertiary care hospital, so any malignancy before starting treatment, we would like to know the staging. So they inevitably and invariably we are going for the PET CT scan, except in cases like CA cervix and all, which are very less likely to metastasize. But most of the malignancies, we do a PET scan and we get the lung picture in that. And as you said, rightly said, there will be many incidentally detected lung issues when we do a PET CT. Just like a case which I presented, which has an ILD. She is a case of CA breast who was amenable for excision, but she has saturations of 88, 90, and she was not able to be posted for surgery because of her lung issue.
Yeah, any quick question from the audience?
I have one question.
Sir.
Without red state lung, how did you confirm it to be without red state?
Sir, only based on exclusion. I could have done a ball to see if there is eosinophilia, but the patient is so morbid. He is already a bedridden case since 10 years with Parkinson's disease, and he was not intubated also. So if I do a bronchoscopy, he would eventually require an NIV or intubation, because his baseline saturation was in the order of 80 to 85, 88, or even less than that. So I did not go for a bronchoscopy, only based on the gut. We thought it is methotrexate thing, because the pattern is, after very meticulously studying the pattern of, the opacities on the CT, we concluded that it is not an interstitial lung disease because of RA, but it probably might be because of methotrexate. Because he has been using methotrexate since more than 15 years, sir, and he is on low-dose steroids also since more than 10 years.
We have noticed one case, resumption-induced lung injury.
Sir.
It is confirmed case of pulmonary tractor. During resumption treatment, she developed this ILD picture. She did withdraw it, but with hepatitis. So definitely we withdraw the agent.
Yes, sir.
Then after resolving of hepatitis, we introduced again. She had again. So we thought probably there was a thrombocytopenia also. So we thought resumption induced. So we excluded resumption into other drugs. She totally flew up.
She didn't develop ILD.
She has a question.
Yeah.
I think
so. That is quite interesting, sir. Rifampicin-induced ILD. Probably we should be looking for it.
I think the third most common cause of death in US is the physician-induced or drug-induced deaths. So I think we should be more careful in selecting drug and doing the intervention. I think you have covered all the issues. I think one comment, we have done a organizing pneumonia book. You should have done a biopsy for a tertiary care institute like Yashoda. You should have done it.
Yes, she is already in hypoxia, and they were skeptical about surgery. So if I wanted to prove it, it's difficult.
And I think I welcome Dr. Vijay Kumar, the organizing chairman of the NAPCON. So you have comment? Yeah, please, sir. Yeah.
Thank you. Dr. Vijay Kumar here. As Sir William Osler said, a good physician should know when not to start a drug, as much as when to start a drug. So we should be learning from our mistakes. I think this kind of CME programs are towards that direction. When a patient doesn't do well with your diagnosis, with your treatment, with your drugs, it is very important to see what went wrong. That is how, as an individual clinician, we learn. If more than one patient comes back with a similar issue, with a similar drug, that is when I think we should raise a red flag.
Yes, sir.
So if we don't learn from our mistakes, we continue to do those mistakes, and eventually we deteriorate to a bad clinician. Yes. So I think Sir William Osler almost a century ago said this. Thank you.
Thank you, sir. I think Florence Nightingale also has said, I want to bring the quote, let us do no harm to the sick.
Yes, sir. These days, there are many females who are having recurrent UTIs and are on nitrofurantoin prophylaxis and have encountered 1 to 2 ILDs in patients on nitrofurantoin prophylaxis. They're taking 50 mg once daily, 100 mg once daily for 3 to 6 months. And one patient, 1 year she was taking, she had ILD. And one of my colleagues' mother expired because of amiodarone toxicity of the lung. So drugs, we always have very bad this thing, but
Okay, thank you, Vamsi. I think all the topics you have nicely covered. And if there are no questions, we will wind up the session and hand over the mic to the organizing team.
Yeah, Kirti.
Organizing.
Now I request Dr. Bhaskar sir to come and accept the memento, sir. Dr. Pramod Kumar sir to hand over the memento to Dr. Bhaskar sir. Pramod sir, please stay next. Dr. Vamshi Krishna sir to accept the memento. I now request Dr. R. Vijay Kumar sir. Dr. R. Vijay Kumar sir, welcome sir. Sir, please come and hand over memento to our chairperson, Dr. Subhakar sir.
Subhakar and we keep meeting almost every day. But this mission.
Thank you, sir. Sir, to our next chairperson, Dr. Pradyut Pagre, sir.
We have it together in the chest hospital since 1986. Yeah.
Sir has been my teacher also. It's a privilege. Thank you.
Dr. Pramod Kumar, sir. Now we'll break for lunch and gather back for the next 2 sessions.
pulmonologist should possess. And review of literature says that lung contusion in polytrauma, road traffic accidents, which is one of the commonest in the West, it is increasing now in our country, is a very important factor. And in the West, they have tried for polytrauma doing an emergency department thoracotomy, but very soon they realized that it's a big mistake. Because in those cases where they did this emergency thoracotomy to see what is happening to the lungs, the survival was 1.5%. So they stopped doing it. So you will have to go by the clinical, radiological, and your knowledge. One of the important things is to make sure that the patient is having a good hemodynamics and good vitals. Again, during my hospital practice, when I went to the ICUs, I used to go and touch the feet of the patients. So after the patients got better, they used to come and say, "Sir, you used to come and touch our feet. That's a nice gesture. So we would like to come and touch your feet now that we got better." Actually, I was touching the feet to feel the dorsalis pedis artery, because it is the most peripheral, palpable branch of the aorta. If the heart can pump blood all the way to the dorsalis pedis, it means hemodynamics are good. You don't have to really look at any of the graphics, you don't have to look at any of the other parameters. Having said that, if the patient doesn't have hypoxia, doesn't have hemodynamic instability, it doesn't mean that there is a major issue such as aortic injury. So I'm sure Yugandhar is going to describe about how you can make out different injuries inside the chest. And aortic injury, blunt injury, is one of the important ones because it can lead to death. And there are a lot of ways that you can make out aortic injury simply by looking at the chest X-ray. I request Avinash to introduce Yugandhar Bhattu.
Good afternoon all. So today I am going to introduce Dr. Yugandhar Bhattu. He is the head of the department, consultant interventional pulmonologist at Yashoda Hospitals, Malakpet. So he completed his MBBS from Kakatiya Medical College in 2005 and completed his MD chest from Osmania Medical College 2010 and worked as senior resident in Care Hospitals, Banjara Hills from 2010 to 2011. And from 11 to 15, he worked as junior consultant pulmonologist in Care Hospitals itself. And from 16 to present, he is now working as consultant pulmonologist at Yashoda Hospitals, Malakpet. So it's been 7 years. So, and he also received Dr. APJ Kalam Award in October 2021. So I request Dr. Yugandhar Bhattu to come and take over the talk.
Thank you, dignitaries and R. Vijay Kumar sir, for the brief introduction about the importance of ICU knowledge, both from the clinical, as sir said, dorsalis pedis. That's a beautiful clinical point. Even in COVID time also, we used to auscultate the patient once the fomites are not the major transport modality, so that is the only method we can identify bronchospasm. No other radiation imaging and will pick up that particular thing. So these are the clinical things which background theoretical imaging knowledge will help in decision making. And I chosen this particular topic. As sir said, we should come out of from the OPD. Yes, first talk is in OPD, second talk is in radiology room, third talk is in ICU, next talk in OT. So with this, I want to start my talk. with the subheadings of contusions, lacerations, hematoma, herniation of the lung. So among all, herniation of the lung is the last common. And this will be highlighted because parenchymal injuries are more common when compared to the other tracheobronchial and vascular injuries, which are grievous in terms of severity grading, where surgical intervention is mandatory. And pleural, pneumothorax, hemothorax, and tracheobronchial tree injuries will be trachea, because usually trachea will be unstable at the level of carina. So that is the particularly posterior membranous portion where cartilageous support is not there. That's the reason if you want to look for tracheal tear or injury, look this particular area. This is the theory knowledge that you have to before ordering CT and looking for that. And right main bronchus injuries are more common when compared to the left main bronchus. The reason is short mediastinal course, because right main bronchus is short and stout and it has a lesser mediastinal course. That's the reason it will easy to tear when compared to the left main bronchus. And vascular injuries, yes, aorta is, as I said, dorsalis pedis is palpable. Yes, aortic function, hemodynamic is good. If you have a hemothorax on left side, don't hurry in putting placing a ICD just by seeing the radio opaque hemithorax, particularly on left side. We have come across the similar case in our PG days where we have to confirm with our seniors before putting ICD, because aneurysm of aorta, collapse of the lung, and aortic dissection can mimic the same, where if you put ICD, it will be catastrophe. And arch of aorta is vulnerable site. This site is important. This is the applied anatomy, because arch of aorta will be supported, ascending aorta will be supported by the base of the heart, and descending aorta will be supported by the intercostal arteries, but arch is free. So if you want to search for the injury of aorta, you have to search at arch. Subclavian arteries, yes, though these are not so uncommon, we have a case report which I am going to depict next slides. So as sir said, contusion and laceration, this is the point of theory knowledge I want to you residents to give. Why? Because once you complete your degree, these are the most common consultations in your periphery when you freelance, or if you work in a cross consultation, work in a ICU or corporate hospitals. So there should be a difference, different even radiological, pathological, prognostication wise, there is a difference between two entities which mimics the same in knowledgeable persons if you don't have theory knowledge. Lung contusion. This is the most common injury of the lung parenchyma in road traffic accidents, which accounts 75%. Lung parenchyma here it is intact. So the beauty of this particular contusion, though it's grave in presentation at the time of presentation, most of the times it is a trivial injury, with if you follow up, it will completely resolve because parenchyma is intact, which is a contrary feature of laceration, and it resolves in 2 weeks without any sequelae. So here the point of notice is first 6 hours of the injury. If you have an immediate CT chest and patient presented to your tertiary care, not having any lesions on CT chest, but still patient is hemodynamically unstable that by the time he reached to you, so it may be ongoing contusion after 6 hours, where it will reach its peak by 72 hours. So this is the time where you have to follow up the contusion of the lung, just like a neurosurgeon, how they follow up brain imaging twice more than one. And laceration, in contrary to that, 12% of the road traffic accidents, less common, but it indicates a grievous injury. And lung parenchyma here it is disrupted. That's the reason there is a fluid levels will be there, which is also known as traumatic nematocele. Why I mentioned this traumatic nematocele? As you all knew, there is an infective nematocele, and where you can see the virulent organism like Klebsiella and Pseudomonas. So Staphylococcus, you can call it as Staphylocele. So those infective nematoceles, traumatic nematoceles, both will mimic most of the times the same. History will make the difference, and it will reach peaks by 1 week and ends by the fibrosis, cavity, and sepsis, abscess, all those complications. So once you identify contusion, you can prognosticate patient family with a good recovery and contrary to the lung contusion. So how radiological pattern will differ. Diffuse non-segmental ground loss opacity or haziness is the pathognomic feature of lung contusion. Why diffuse? Because of the whatever that blow, that pressure wave in blunt trauma chest will not respect the anatomical boundaries, just like your infective etiology. If you have a consolidation of infective etiology, it will follow the tracheobronchial tree, but here it is a blow against that particular chest, so it will be just opposite to that, perpendicular to the tracheobronchial tree. So it will not respect the anatomical boundaries. Non-segmental and diffuse ground loss opacities holds good for the diagnosis of contusion. When compared to the lung laceration, here there is a elliptical and spherical shape is very key to identify the laceration. Why? Because linear opacities are more common in other solid organs of the lung where blunt trauma injury was there, like liver or kidney. But which is a different feature of the lung is it is having a intact or elastic nature where lung tissue will be under continuous elastic tension, that normal structures, normal parenchyma of the lung will pulling that particular abnormal lacerated area equally and resulting into a spherical shape. So secondary infections are common, but much more common in laceration. And here the point of interest here is laceration will have a parenchymal injury. Parenchymal injury will lead to the mucociliary defect, so there is a possibility of obstruction with a high possible recurrent ET tube blocks. So if you have a laceration in your first visit, warn your intensivist colleague. So there is a high chance of tube block. Be ready with the resuscitation, and frequent suctioning can prevent that. So these are the basic things, and types of contusion, mild and severe. And here the laceration will be divided into based on the force to the blunt trauma chest. Compressive rupture, this is because of the rapid reflex spasm of this particular glottis, just like a Valsalva, where positive intrathoracic pressure will create that particular pressure wave in the medulla of the lung. Medulla and cortex of the lung is a new concept. Our professor used to tell, it's not a new concept, but distribution. Central part of the lung on either side is site of the lesion when you have a compressive type of force. And compressive shear, it is alveoli is pressure against the vertebra. This is whenever you have a laceration paravertebral, this is the mode of injury. Rib penetration tear, it is adjacent to the rib. Whenever you have this type of injury, lung contusion will be associated with pneumothorax. Search for pneumothorax. And adhesion tear, where it will be near to the scar with the whole history of Cox. So this is one patient presented with a run over by the tractor, but he concealed the history. At the time of discharge only he revealed when I probe, because this much whatever that ground loss opacities, bilateral diffuse opacities will not be happen when there is a simple long bone fracture. He was admitted with a long bone fracture. Fracture was orthopedicians fixed that fracture, but hypoxia was resolved over a period of time with a conservative management, thinking that this is a contusion, and with the followed up CT at the time of discharge with a one week gap, it relieves majority of the lung parenchyma resolves. This is a lung contusion, typical. And this is the another case where lung laceration, left upper lobe there is a laceration, which I mentioned just now. So this is elliptical in shape because of the tensile force of the normal parenchyma will pull this pathological lung. So whenever you have this type of opacity with a lucency within inside, trauma history, elliptical in shape, think about the laceration. This is the one another case with a traumatic pneumatocyst. This is a paravertebral lung laceration. So identifying the laceration and contusion is key whenever you have a consultations in ICU with a RTA. So this is another case where a patient was 23-year-old with a road traffic accident, and he was admitted in a primary hospital with a traumatic hemopericardium which was in a tamponade state. But this was identified after reaching the tertiary care care, and there I identified, ruled out neuro-related issues. Hypertension was their diagnosis at the time of shifting to the tertiary care, and that hypertension leads to pre-renal AKI. Patient was intubated. After that, receiving our area, this is the abnormality. This particular bump in this chest X-ray will gives a hint. You have to go ahead once your oxygenation is good, but pressures are low. As such said, this is something we are dealing with the cardiovascular. Immediately, whatever that cardiologist was on call pulled for this pigtail placement for the pericardial hemopericardium, which was about to tamponade. After pericardial effusion was tapped, and patient was happily extubated, and even this clavicle fracture, everything was conservatively managed without opening the pericardium by a CT surgeon in a timely intervention. The point of here it is, if you give a fluids without diagnosing hemopericardium is the key. Patient will be succumb on the same day itself of a 23-year-old. So another case where a patient was treated for the organ of phosphorus poisoning, and he was intubated. Because of the prolonged ventilation, he was tracheostomized. In spite of tracheostomy, unable to wean, and they referred the case for further management. Here our intensivist identified timely peak pressures are going up and P/F ratios are going down. Any clue what might be the lesion? These are the X-rays. Of course, X-ray may not pick up, but some imaging will give a clue. If any enthusiastic PGs can answer. So that is ICD for this pneumothorax, hemothorax, that is okay. Why peak pressures are high? Why oxygenation is not good? So peak pressures are high whenever you have a tube block. Here the plausibility of tube block is there very clearly. Being a pulmonologist, aspirant interventional pulmonologist, you have to look not only parenchyma, see the atracheogram. This was a favorite word of our Professor S.V. Prasad sir, atracheogram, which will be useful even in chest X-ray and also here, where it should be forming the normal tracheal lumen, that's convex anteriorly, posteriorly flat. So here this particular, whatever that opacity was suspected as a clot, identified by our intensivist, thanks to Dr. Aditya, he is here, and he was the person who given referral for me in terms of rapid evaluation. This was the CT chest, bronchoscopy when we are through the tracheostomy tube. There is a big clot occupying at right main bronchus, and left main bronchus is free. And here the point of interest is this right main bronchus totally occluded with a big clot because of the recurrent tracheostomy tube suction, which was done blindly in another center, where there is a high possibility of bleeding source and tracked down to the anatomically dependent area, which was tried to dislodge before going for the cryo extraction in toto. This was the cryo extraction. So why we want to go for a cryo extraction? Because to avoid the multiple entry and out. The clot was too big, even the inner diameter of the tracheostomy tube was not allowing the clot inside. So we have a help of intensivist with a newly placed another tracheostomy tube. Clot was removed and successfully patient weaned to next happily discharged. This is another case where 63-year male with a left side chest pain, fractured left rib, and he was admitted with a shortness of breath and hypoxia. Initial part of the X-ray suggestive of mild hemothorax, where our CT surgeon colleagues were anticipated it is a spontaneous recovery, but just before the discharge, patient suddenly went into desaturation and surgical exploration was needed. This was the X-ray at the time of discharge. Almost like this X-ray was there at the time of with CP angle blunting, and this is the left side radio opaque lesion and hemithorax opacity, you can say, and without any much shift. So in a trauma, you have to think about this may be the hemothorax. But before going for that, you have to cross-check with the vascular injuries. Here, if you see carefully, there is a ribs are displaced. This displaced rib was the source of intercostal artery damage, and whatever the pleural cavity on left side filled with the blood over a period of time, not acute. That means complications need not to present at the time of your visit. It may present at the time of discharge. If you don't pick up, it may be catastrophe. This was the fixed ribs. The ribs were fixed with this. This was the intra-op surgery ribs fixation by this staplers and fracture ribs and clavicle. These are the two ribs, two bones where surgical fixation may not be required in all the time. Exceptions are flyal chest, where the dislodged particular portion of the ribs, either it may be on one side, more than one rib, two ribs on either side of the dislodged segment, going inward displacement when patient is inspiration, resulting in paradoxical breathing, resulting in VQ mismatch, so that you have to fix that. Vascular injuries, like this case, hemothorax, we have to go ahead. So small brief introduction about hemothorax. Whenever you have a hemothorax, think about this fast protocol. ICU intensivists are interested to rule out immediately that ultrasound fast protocol, and CCT chest reasonably will clear that vascular injuries. 30 to 70 ounce full unit uptake, if it is present in the pleural cavity, think about a hemothorax. That is also known as hematocrit sign, where blood products will be layered in the pleural cavity. And differential diagnosis, this is one of the rare differential diagnosis of the hemothorax, that is extra pleural hematoma, where hematoma because of the superficial injury accumulating superficial to the pleura itself. So the clue here is inward displacement of the extra pleural pad of fat, CT chest. This may be not picked up by our pulmonology, but we can discuss with the radiology colleague whether pad of fat is displaced or not. Because if you don't identify this particular rare entity, putting ICD in this will not be helpful, where you have to go for a surgical exploration. And what are the complications if you don't identify the hemothorax? Fibrothorax, that is fixed mediastinum and trapped lung, and calcification also. Fixed mediastinum because of this organized mediastinal pleura. So left side hemothorax, as we just pointed out, rule out vascular injuries with a contrast imaging. Don't hesitate to repeat with a IV contrast. Most of the times you will come across a problem, they will come up with a plain CT chest. You cannot convince them until you, unless you have a strong intuition. Vascular injury has to be ruled out on left side hemothorax with contrast enriched CT scan alone. And think about the aortic dissection before placing a left side hemothorax ICD, and most common, as I said, arch of aorta. This is the one more case where RTA resulting into hemothorax. After that, there was a, if you carefully observe, this is the descending aorta where there is a aortic dissection, which was clearly mentioned on this coronal and reconstructed images. So if you put ICD for these type of patients, it will be sudden disruption of the natural supporting mechanism of the blood clot for the dissection part, where we managed this case without opening either by exploration or by ICD placement. Conservatively, it was recovered. So this is one more case where patient was presented with a clavicular fracture. This clavicular fracture was retrospective history. Patient was presented with a hemoptysis, and after probing here the proper history, this was a case of subclavian aneurysm, pseudoaneurysm, secondary to the entrapped callus formation, secondary to this fractured clavicle, and leaking that particular aneurysm into the bronchus, presenting as a hemoptysis. This was published in this particular journal. And another case where the patient was presented to the emergency room with this triad. Can anybody guess what is this triad of vomiting, chest pain, swelling of chest? Patient had boozing, and after that, after celebration of Dasaras, I think, and he brought down to ER with a semi-conscious with these symptoms. This is nothing but Borhaus syndrome. Wonderful. So McLeod's triad, where all three are the key, and here we have a subcutaneous emphysema, which is a whatever the swollen chest, and which is a palpable crepes and painful swelling, and apart from that, we have a ICD and patient was intubated for that respiratory distress. This is the right lower zone opacity where it was contusion and also pleural effusion on either side. So subcutaneous emphysema, whenever you come across, these are the possibilities. Iatrogenic central line placement, tracheostomy, need not to be always, it may be trauma, it may be iatrogenic also. Barotrauma, McLean effect, this is a barotrauma in a pressure volume control ventilator settings in a ARDS patients. Tracheal injuries, as we saw, it may be motor accidents or it may be repeated suctions. If tracheal injury in a motor accident causing tracheal rupture, the clue here is once patient is intubated, endotracheal tube image is exceeding beyond the tracheal wall line, that is a tracheogram. Then you have to think about the tracheal injury where you have to fix with the surgeons. And esophageal rupture, the clue here is whatever that air pockets will be localized around the paraesophageal area. So this was an ultrasound of the same patient, multiloculated right side empyema, and this was the consolidation after placing ICD. This ICD, whatever the NG feeds are coming into ICD tube, which was the complication in our chest hospital. Used to see these type of patients in occasionally in a chronic empyema case, poorly managed nutrition and poorly background immunity. So in this trauma background, we have to think about the esophageal rupture seeps into pleura, which was this is a non-contrast, this is the oral contrast, esophagus contrast leaking into the right pleural cavity, and this was immediately by medical gastros placed self-expanding metallic stent, so that will prevent the further siling of right pleural cavity, and right pleural cavity, which was empyema, decatechised by this immediate exploration by the surgical gastro and surgical thoracic surgeon. And this was the case, the X-ray at the time of discharge. A proper identification of the esophageal rupture with a proper stent placement and conservative management for the rest of the things saves this costly, what is that, alcohol. It was almost 10 lakhs he spent for this one incident of boozing episode. And this was another case where patient was presented with after RTA. Anybody guess? This was there in the flyer also. This is a chest lung window, mediastinal window. There is a fractured rib segment, and the heart is good. This is that lung contusion. Here the laceration part is also there. If you carefully see, this avascular zone is nothing but a pneumothorax, traumatic pneumothorax. This is a collapsed lung. It is not fixing into the thoracic cavity. It is also extending beyond the thoracic cavity through the defect that is nothing but a lung herniation, which is not so common. So this is the lung herniation in a different cuts. So with this I want to conclude my talk. This is the severity of the injuries according to American Association of the Surgery and Trauma from grade 1, 2, 3, 4, 5, 6. Grade 1, 2, 3, it is our physician domain, and where intensivist physicians can identify, immediately inform and follow up the case when it is progressing into worsening into grade 4 and 5, 6, where surgical intervention is needed based on the contusion, unilateral, contusion bilateral, laceration, and hematoma, vascular injury, or tracheobronchial injuries comes under grievous injuries. With this, I want to conclude. If any questions, most welcome. Thank you. Madam.
Just one comment.
Madam.
A lot of time we miss diaphragmatic injuries.
Yes, madam, yes.
So I think for every trauma, I've had bilateral diaphragmatic injury which was missed.
Correct.
So I think in the protocol that also
Yes,
we should
yes.
look for.
That fast protocol diaphragmatic excursion will be identified by, so that is one. Yes, obviously. So before diagnosing the diaphragmatic error, we used to identify Riles tube placement and take a X-ray, or before putting a ICD for a hydropneumothorax, hemothorax mimicking part, that is diaphragmatic hernia.
My patient had bilateral effusions. So one day it was on one side, the second day it was on the other side.
Oh.
So it took a while before it was diagnosed.
Okay, thank you.
Just physiotherapy can cause injuries?
Violent chest physiotherapy can cause, sir, because we have a calf rib fractures. So people will present with a chest pain, particularly if it is on left side after evaluation with the TMT and this one. End of the day, rib fracture was the possible reason. Apart from the conjunctival hemorrhages, all are the rare complications with the pressure effect.
That was a good question, Dr. Shailaja. Diaphragmatic injuries are missed most of the times. And then ultrasound at the point of care.
Yes, sir.
Focus is a very important one. And what you mentioned, the fast, now it is the extended fast where you evaluate with the sonography for all trauma cases. By just putting the probe, you can make a diagnosis of pneumothorax. By just putting the probe, we can make a diagnosis of pericardial effusion, pleural effusion, hemoperitoneum. And it's such a valuable thing. And also it will tell us where to put the ICD. And Dr. Sriram question again is very important because the new guidelines of Critical Care Society says, don't do just physiotherapy in the ICU. It has caused more morbidity and mortality. So there is no role for just physiotherapy in the ICU. So we have been telling this for a very long time, but then old habits, they keep continuing. So, and one of the things about the aortic injury is the midline shift. One, of course, is the mediastinum widening happens because most of the X-rays in the ICUs are AP views, and if the mediastinum is 8 centimeters wide, then you have to suspect aortic leak. And similarly, midline shift, like your nasogastric tube has shifted to the right, or your endotracheal tube has shifted to the right. And if the left main bronchus is pushed down because of the leak in the aorta, of course, the hemothorax is a very clear cut. But we want to diagnose it before, and then a lot of criteria have been developed whether to do a CT scan or not. Of course, here we have no issues, but in the Western countries there are issues. You can't just do a CT scan for everybody because insurance doesn't pay.
But
here the patient pays.
Medical legal is very strong there.
Yes.
We have to protect ourselves and also saving the patient.
Correct.
Yes.
We have to do a CT scan, and for that there is what is the nexus criteria. But then now they say if the chest X-ray is abnormal, and if the patient has got tenderness over the sternum, over the ribs, over the scapula, do a CT scan. So if in doubt, do a CT scan. And this CT scan should always be contrast enhanced CT scan. That's very important. So that you can make out leakages, like Dr. Shailaja mentioned about the diaphragmatic injury, that also can be picked up. But ultrasound picks up diaphragmatic injury better than a CT scan. Congratulations.
Thank you, sir.
That was a very nice overview of polytrauma and chest. Over to Avinash.
Thank you.
So one small addition would be simple aspiration pneumonia also may be aspiration.
Yes.
RTAs, they may become unconscious and the secretions get pulled up.
Correct.
It also causes aspiration.
Yeah, while they are intubating, they can give a clue whether the food particles are there and secretions are more. Thank you.
So,
next session is streaming, I think, web. Thank you.
While we are getting ready for the next talk, I just want to mention here that respiratory therapist plays a very important role, because Yugandhar showed a case where the peak pressures go up and the patient becomes hypoxic. It's a clear-cut case of airway obstruction, especially the upper airway. There is a trachea. Here the trachea, the endotracheal tube is kinked, blocked with mucus, blood, whatever it is. So it is a respiratory therapist who picks it up first. So it is better to have a well-qualified, experienced respiratory therapist taking care of your patient of polytrauma.
Good afternoon. It's my pleasure to introduce Dr. Bharat, who has graduated from SVS Medical College and has done his MD from Kurnool Medical College and done his fellowships in interventional pulmonology and allergy and clinical immunology. Today we are having him to give a brief presentation on X-rays in ICU, the very talented and very versatile. I welcome Dr. Bharat Katti.
Yeah, is it audible?
Yeah.
Okay. All of you, very good afternoon. So today my topic will be X-rays in ICU, a different ballgame. So my theme of discussion today will be 5 elements in ICU radiology. I think most of you know regarding the 5 elements of life. So it is air, sky, earth, water and fire. In the same way, within the ICU chest X-ray, what are the 5 things that every physician should know? So with respect to earth, something is solid. Is there any lung parenchymal opacities? With respect to air, is there any air in the chest? With respect to fluid, water, is there any fluid in the chest? And sky is something outside. From the outside, is there any abnormality in lines or tubes? And fire is nothing but the fire inside you to correlate all this and treat appropriately. Now coming to the solid lesions, lung parenchymal opacities can be seen in the ICU or consolidation, collapse, bilateral diffuse parenchymal opacities. So I'll show you what is the pathology and also I'll explain with some of my cases. So consolidation, generally patient will have history of fever, there will be bronchial breathing and there will be no significant mediastinal shift. The tracheum will be maintained, the heart will be maintained and you can see lesions called as air bronchograms. Now whereas this is a case, a 68-year-old male underwent open cholecystectomy 48 hours ago and now complaint of shortness of breath and cough. SpO2 is reducing, chest examination reveals decreased movements of chest wall, right side and breath sounds not audible. This was a chest X-ray. Now if you notice, there is a typical deviation of trachea towards the same side and also whitish abnormality. So this is a classical case of whitish abnormality with pull of mediastinum. It is suggestive of collapse. So this patient underwent bronchoscopy. Later we have retrieved that the secretions. So another case, post-operative patient with decreasing SpO2, and this was also showing whiteout lung, suggestive of collapse. And after retrieving, this was the X-ray. So we could remove few mucus plugs, and later on patient could improve. Then coming to bilateral diffuse infiltrates. So this is one situation where a pulmonologist is given frequently referral in the ICU. So let us see with help of a case. A 19-year-old female involved in road traffic accident. She received so many RPCs and on evaluation in the ICU, her PF ratio is 150, suggestive of moderate ARDS. And echocardiogram performed was showing a hyperdynamic small left ventricle with no pericardial effusion. So when there is acute shortness of breath, and chest X-ray showing bilateral diffuse infiltrates, adequate clinical scenario, trauma and blood transfusion. So what this can be ARDS, acute respiratory distress syndrome. So one can notice bilateral, top to bottom, side to side, in all quadrants, there will be infiltrates. Now this second case, a 53-year-old male presents with substernal chest pain, dyspnea for 2 hours. His febrile, tachypneic auscultation of the lung shows bilateral crepitations. SpO2 was with oxygen 5 liters 96, chest X-ray is shown, and a CT scan was advised in view of abnormal X-ray. So this was during the COVID era. Any abnormal X-ray, they used to take a CT scan. Now what is different here? Here also you can notice bilateral lesions, but see this, there is a cardiomegaly, and these lesions are having a shape of bat wing appearance. Now tell me, is this ARDS? The answer is no, this is not ARDS, this is cardiogenic pulmonary edema. Next thing what you should know, when to refer to your cardiology colleague. So same thing, here also in CT scan, you can notice bilateral pleural effusions, and also there is this central wing-shaped opacities. And there is also another method to assess this for postgraduates sitting there. There is something called as vascular pedicle width. Vascular pedicle width is measured on the right side, SVC, agigus vein complex, to proximal descending thoracic aorta on the left. If it is more than 7 centimeters on a chest X-ray, think of cardiogenic pulmonary edema. So bilateral diffuse pulmonary infiltrates, apart from ARDS, very common is cardiogenic pulmonary edema. So another case, 50-year-old female, shortness of breath, hemoptysis. She was also desaturating, requiring 10 liters of oxygen, and CBC, anemia, RFT. The parameters were very high, and WBC were also high, and the urine examination was also showing RBC, echo was normal. So this is the chest X-ray. Again, they have referred to me calling this as ARDS. Now, if you notice here, with the above parameters, there is anemia, there is blood in the urine, and renal parameters. I suspected it to be pulmonary renal syndrome. This is how a diffuse alveolar hemorrhage looks like. So in the X-ray, it might look like ARDS, but you have to think beyond ARDS with the additional points here for bilateral diffuse pulmonary infiltrates. So differential diagnosis starts with A, B, C, D, E, F. A stands for acute cardiogenic pulmonary edema, alveolar proteinosis, acute interstitial pneumonia. B for, can it be any bilateral aspiration pneumonia, cryptogenic organizing pneumonia, diffuse alveolar hemorrhage, eosinophilic pneumonia, and also acute HP, so farmer's lung. So these are the acute situations where you can see bilateral diffuse pulmonary infiltrates. Don't think that anything that bilaterally opacifies is only ARDS. All these possibilities can happen. You have to take adequate clinical history with supportive investigations. You have to come to a conclusion. Then this was an interesting case, 19-year-old male construction worker, 10 days history of fever, cough, shortness of breath. On examination, saturation 70% on room air. So this was a chest X-ray showing bilateral infiltrates. On the CT scan, we were seeing ground glass opacities, consolidation, here and there crazy paving. Young male construction worker, we were thinking any possibility of hypersensitivity pneumonitis, any possibility of alveolar hemorrhage, any possibility of pulmonary alveolar proteinosis because of crazy paving pattern. But his CB-NAT came as positive. So as long as you are in India, when there is a bilateral disease, also suspect TB. It can still be TB where you think it cannot be. In ICU, presenting with acute history, you think it is not TB. But in India, it still can be TB where you think it cannot be. Then second element you should know in the chest X-ray and ICU is air. Is there any excess air? So very frequently confused by my postgraduates is, sir, is it pneumothorax? Is it a large bulla? How to identify a chest X-ray? I'll tell you an easy method. So pneumothorax, generally the visceral pleural line. If you see the visceral pleural line, it is usually convex towards the chest wall. So visceral pleural line is generally convex towards chest wall. Whereas in a bulla, they have noticed the line that you see and you think as a pneumothorax is usually concave. So this is one basic difference. So if you find any air-filled area like this, even though patient is sick, don't immediately put an ICD, think twice. But if it is like this, you can put an ICD thinking it as pneumothorax. And especially in ICU, you need to know signs of pneumothorax on a supine projection. So whenever a patient is in supine position, air rises to anterior and inferior portion of thorax, first medially and then laterally. The air may cause the costophrenic angle on the side of pneumothorax to project more inferiorly than costophrenic angle on the opposite side. So this is nothing but the deep sulcus sign. So this is very, very helpful in ICU to identify any pneumothorax is present or not. Now this is an interesting case that I have seen. A 20-year-old male, known asthmatic in emergency department with exacerbation of asthma, not improving with conventional treatment, shifted to the ICU. So he was given bronchodilators, steroids, magnesium sulfate, everything. Then this was the chest X-ray of the patient. When I examined, I could hear wheeze more on the right, but left it was reduced. When I have keenly seen, when compared to this side, the vascularity was slightly low. And if you can see, there was also a thin border, suggestive of a visceral pleural line. So, but this is actually a digital X-ray. So if we had have the original film, it would have been very well appreciated. So whenever you are having a doubt that it can be pneumothorax or not, always you invert the film like this. So you invert the film and see for any visceral pleural line present. So here this was the visceral pleural line present and this was the hypertranslucent area. Still we went for a CT scan, you can see there is a pneumothorax. So the reason why his asthma was not improving because of presence of concurrent pneumothorax. When we put an ICD, there was very good improvement. So this is a left pneumothorax. So again, another patient presented with shortness of breath and there was some hyperinflated area. But there is all vascularity till the periphery, even though there is a shift of mediastinum. CT scan has shown it to be more of a congenital lobar emphysema. And in this situation, when there is no visceral pleural line, just hyperinflation also, you should not put an ICD. So that's why what I want you to know is, sometimes pneumothorax can appear grossly like this, easy to identify. Sometimes it might be difficult to identify. Still, a small rim of air is still a nightmare for a patient. So maybe a big pneumothorax patient might be comfortable. Sometimes even a minimal pneumothorax patient might be having a lot of symptoms. Then the third element is fluid. So fluid, generally pleural effusion is very common. So you usually see it as whitish homogeneous density with meniscoid fluid level and shift of mediastinum to opposite side. So when there is a large pleural effusion, expect a mediastinal shift, especially in the ICU. Now here there are two X-rays. So they call me for this patient to put an ICD. Thinking because there is whitish homogeneous area, they thought it as a pleural effusion. But when there is this much amount of opacity, you expect the heart to be shifted to more towards the left. So everything has been pulled. You can also see the trachea being pulled. This was actually a right-sided collapse because of mucus plugging. Later we have extracted it. Now this is a classical pleural effusion. Homogeneous whitish opacity with the shift of mediastinum to opposite side. So whenever you are in doubt whether it is collapse or effusion, apart from clinical examination, just to get an ultrasound chest. So if it is fluid, you can easily recognize. Then this was an interesting case, 30-year-old male, right chest pain, shortness of breath, effusion was exudate, neutrophilic, predominant ADA, 50 international units, started on ATT outside, he was not improving, now presented with acute shortness of breath and chest pain. Later, when we have evaluated, it was suggestive of pulmonary thromboembolism. Because of lack of time, I'm not showing the films. So whenever there is an effusion with a lot of confusion, kindly roll out pulmonary embolism in our setting. Nowadays, in emergency and also in ICU, we are seeing a lot of pulmonary embolism which are first being presented as pleural effusion. Then something coming from outside into the chest X-ray, that is line or tube. So this is the fourth element. So endotracheal tube, ideal position should be in the mid trachea, 5 centimeter from carina, when head is neither flexed or extended. The minimal safe distance is 2 centimeter from carina. When the carina is not visible, the tip of endotracheal tube should be approximately at the level of medial ends of clavicle. So this is the ideal position. At the level of medial ends of the clavicle, you should expect endotracheal tube ideal position. So what can become wrong? Tube far advanced. And typically if you put it in right main stem bronchus, the right lung will be ventilated, left lung can undergo collapse. So that is the reason each and every time you put an endotracheal tube, you have to take a chest X-ray. And sometimes placement in esophagus resulting in over-distended stomach. Tracheal stenosis can happen following long-term tube placement. Now what is the mistake here? This tube was pushed more into the right main bronchus. And because right main bronchus was only getting ventilated, left side was not getting ventilated and there was collapse. And later when we have adjusted the position of the tube, the lung expanded and ventilation was proper. Then nasogastric tube tip should lie 10 centimeter distal to gastroesophageal junction. What can be wrong? Coiled in mouth, too distally past the stomach, placement with bronchial tree and enteric perforation. So the ideal position is here. So normally it should be here. Whereas sometimes, can you notice here, this NG tube has come into the lung. It has coiled into the right main bronchus. So this is a very, very bad complication. Then tracheostomy, tip should be approximately at mid T3 level. The width of the tube should be 2/3 and cuff should not over distend the tracheal wall. It should be parallel to trachea. And possible complications. Whenever there is tracheal injury, air can escape and there can be surgical emphysema, pneumomediastinum, pneumothorax, hemorrhage, false tract, tracheal stenosis. Now this is the ideal position, but in this what has happened, there was a tracheal tear. Because of that, air has escaped and a lot of surgical emphysema, pneumomediastinum, there is also pneumothorax. So all these complications can happen with tracheostomy. Then central venous catheter, important line. So you can either go through subclavian or internal jugular vein. The tip should lie within the superior vena cava. This is some basic anatomy. You should make sure that tip is in the superior vena cava. So right jugular, right subclavian, left jugular or left subclavian. So the tip of the line should be distal to last venous valve, which is located in the junction of internal jugular and the subclavian veins. So this can be considered a near ideal position, lateral to thoracic spine and inferior to medial end of right clavicle. So this is the ideal position of a catheter. What can happen? Pneumothorax can happen when you go by subclavian approach. You might inadvertently puncture the lung apex. If central venous line is abutting the venous wall, there is the risk of vessel perforation and abnormal course going into another vessel such as azagus vein. And if you go more into the heart, there can be arrhythmias. So here I hope everybody can recognize a subclavian and there is compressed lung margin and hypertranslucent area. So this is a pneumothorax. And whereas here the line has gone very much into the right atrium. So these are all lines which do not align. So it is not aligning where it has to be. It has gone more into the right atrium. Then most important for a pulmonologist is a chest drain. Position depends on why the drain is inserted. Classical teaching, pneumothorax, you point towards the apex, whereas in effusion, you point inferiorly. But usually that is not that easy. No side hole, this is very important. No side hole should lie outside the chest or pleura or else drainage will not be proper. What wrong happened with pneumothorax? Improper location of chest tube, poor drainage and accumulation of air or fluid in chest wall, tube sinking and blockage. Any intrafissural location, we usually see the tube goes into fissure. So immediately there might not be a problem, but as time progresses, there can be herniation of lung parenchyma into holes and that can cause infarction, delayed complication. Inadvertent parenchymal insertion, if you push very hard, there will be pulmonary laceration, hematoma, infarction and bronchopleural fistula. So here if you see here, the holes are outside. Because of that the air is not draining properly. and the pneumothorax has persisted. Then this is a case that I have seen. So this was a patient, 50-year-old male. He was having hydropneumothorax post-thoracentesis. So I hope everybody can identify this. So 19th January, they have taken a first X-ray. So then they have taken another X-ray. He waited for 6 days. So he have taken on 25th. So the next time they have put an ICD. So I think you can see the ICD here. But still, even after putting ICD, patient was not improved. Daily, you see there, 25th, there was an X-ray, 26th X-ray, 27th X-ray. Again, 27th evening, they have taken an X-ray. So it is progressively increasing. Still, patient was not improving. Then it was the 28th X-ray. This was the 7th or 8th X-ray. So this was the X-ray when he was referred to us. So again, 3 days, they have taken X-rays. Now, when this patient came to me, this was the position. Now, can anybody identify what is the problem here? So why this was increasing, it was not draining. The reason was this tube got kinked. So you can see this tube got kinked like this. See, without adjusting the tube for 10 days, they keep on repeating the X-rays. So valuable time they have wasted. Sometimes it happens. So when this patient came to me, because already the fluid was getting organized, we had to do a thoracoscopy, and later we could expand that lung. So a simple mistake made the patient's life difficult. So it is just small position of tube. So that's why when you put a tube, putting tube is very easy. Maintaining it and getting out is most difficult thing that everybody should know. So the learning point here is putting tube is easy, but make sure you are maintaining it and it is draining properly. So with this, I am going to conclude my session. So we have discussed this 5 elements in ICU chest radiology. We have seen what are the solid abnormalities, what are air abnormalities, what are fluid abnormalities, what are the abnormalities in lines and tubes. So I take this opportunity to thank the organizers for giving me the chance. So all the very best and thank you everybody.
Getting a chest X-ray in the ICU he has got a lot of logistics involved. Getting a proper chest X-ray because the patient is on a ventilator, very uncomfortable, not in a proper position, the bed is not right, there is not enough place for the X-ray equipment to move. So with all these limitations, we are getting a chest X-ray done. That is where the focus, the point of care, ultrasound is very useful to pick up pneumothorax, pleural effusion and things like that. And when you're looking at the chest X-ray, one of the common pathologies is pleural effusion. But it may not look like the pleural effusion that you are used to see in an erect film. It will look like a uniform haziness, the entire hemithorax. Sometimes hemothorax, either it is because of the diaphragmatic injury or because of the aortic injury, the blood will migrate towards the apex and it will look like the apical cap on the X-ray. So if you see an apical cap, it means it is a hemothorax. You should be very careful. Dr. Bharat Katti mentioned about the ICD. The ICD tube, I am sure all of you have seen it. It has got several holes. But the speciality of the last hole is that it is placed on the radiologically, you can make out the, what is it called? Radio opaque line, the blue line, the radio opaque line. That last hole is on the radio opaque line. The other holes are not on radio opaque line. So it means when you see a hole in the ICD tube, it means that is the one which is over the radio opaque line. That hole should be inside the pleura. So that is why it is very important to make sure to take an X-ray after the ICD. So any questions? Clarification? Dr. Sriram.
So simultaneous X-ray and ultrasound in the intensive care setup is ideal or what? To be more precise in diagnosis.
Logistically, again, doing a point of care ultrasound is very easy, provided we are trained. So I urge all pulmonologists who are in training to get trained in ultrasound, routine ultrasounds for pleural effusions, and also ultrasounds in the critical care in the ICUs. Of course, the X-rays have got their own place. It will give a holistic sort of a picture, because we cannot do an ultrasound all over the chest. We can only do it at specific points. So coupled, both the investigations together definitely will give more information, but the rapidity of making a diagnosis lies with point of care ultrasound. So get trained, and also get trained in critical care. At least as far as the lung is concerned, you don't have to worry about the sepsis, you don't have to worry about pancreatitis, you don't have to worry about hepatitis, you don't have to worry about, different varieties of brain injuries. But at least as far as the lung is concerned, you should be thorough with intensive care, how it looks like, what are the things, especially mechanical ventilation. Patients who are on mechanical ventilation, you should be in a position to determine what kind of a mode is required, what are the problems happening, because only a pulmonologist will be seeing patients before he goes into the intensive care and after he is discharged from the intensive care, and while he is in the intensive care for 6 days or 7 days. Unlike others who are looking at the patient only for those 5-6 days in the intensive care unit. So you can understand the pathology better, how an asthma looks like, how a COPD looks like, ILD. So what are the requirements of flow, volume, and pressure for these patients? So you should have a knowledge of that. Any other questions? Okay. If there are no questions, our co-chairpersons want to say anything? We'll have to call the bridegroom one more time to talk about gut and gumption. Dr. Vamshi Krishna.
Are you married?
Sir, actually, I had to replace Dr. Paramjyoti sir's talk, so that is why I'm appearing frequently on stage. Otherwise, I would have enjoyed sitting, and talking with people.
So introduction is not required because he is the most familiar figure in this hall. We're all very eagerly waiting with bated breath to listen to the gut.
But what happened is, from morning, my gut has been many times told the topic which I put here. So just now Bhattu sir said that, I think, the topics which I am considering here has already been spoken of many times since morning, but I have no choice because I very hardly prepared yesterday midnight this PPT. So I'll just finish it off as soon as possible. So why I put this topic is, shall I start, sir? Yeah. So why I put this topic is gut and gumption, the path changes, because in ICUs, I'm not an intensivist, but I have been practicing since the last 11 years and very closely associated with ICUs because I have always been in corporates, and ICU is the mainstay, the center of any corporate hospital. And in ICU, the kind of importance given to a patient in ICU is of the most prime concern is given, and there sometimes you don't have the privilege of going for investigations. You don't have the privilege of doing so many tests. There will be so many people who will be admitted for one day and will be gone because of financial constraints. And all kinds of challenges will be there, along logistic challenges, societal challenges, and also academic challenges. So sometimes gut and gumption is what decides as to what to do next. And I have seen some cases, all these cases I have seen in the last 6-7 months, and I chose to put them because this is where I used my gut and without proper evidence, and fortunately could save those patients. And fortunately, because of my gut, nobody has gone yet. But I won't be misusing my gut all the time, sir. And so with that, I'll start in case 1. This is a young male with road traffic accident and head injury. He was intubated and mechanically ventilated. Decompression craniotomy was done. Intracerebral hemorrhage and subdural hemorrhage were there, and subarachnoid hemorrhage was also there. There was intracranial bleed. Tracheostomy was done in view of long-term need for airway protection. The patient planned for rehab shift. Everything was going in line and everything was fine until one day he started desaturating progressively, and there was hypotension and clinical deterioration. Dr. Aditya might be knowing this case very well. He is here, our intensivist. ET cultures sent earlier, before to the desaturation and all. The reports came by the time he was desaturating, and it showed Acinetobacter baumannii, and so it was considered as ventilator-associated pneumonia because he was intubated and tracheostomized for a total of 5 to 7 days by then. And then in view of refractory shock and no response despite broad spectrum antibiotics, a CT chest was repeated, which we usually do not do in any case unless otherwise it is very badly necessary, we go with the x-rays. But in this case, because the patient was not improving, he was doing fine, the attendants were also told that he will be shifted to the rehab center as soon as possible because most of the neuro cases we sent to the rehab, they take months to recover. So the CT chest showed these findings. The rest of the lung fields were normal, except there were some patchy groundless opacities on both the sides of the lungs, and here is the mediastinal window and the lung window, and the CT chest showed peripheral consolidation, and there was nothing significant and suggestive of ventilator-associated pneumonia in this patient, though there is a report in hand saying that there is Acinetobacter baumannii, which is the most feared pathogen in most of the ICUs, that is, it's an MDR pathogen. But somehow, the gut was, no, it is not the Acinetobacter which is the culprit, which is causing the refractory shock and the sudden deterioration. And this pattern I have become familiar over the last 2 to 3 years, and more so in the last 1 year, because this pattern has caught my attention like an obsession, and I was thinking it was a pulmonary infarct because you could see there's a hump which we call the Hampton's hump. But more than that, there is this bubbly consolidation. To my bad, this is not working. Morning also it didn't work. There is a bubbly consolidation adjacent to the homogeneous consolidation, and bubbly consolidation is better appreciated on the mediastinal window. So any peripheral pleural based opacity with a small hump and an adjacent differential attenuation might indicate a vascular pathology ongoing, or probably there is gradual loss of perfusion, and this bubbly consolidation is usually suggestive of an infarct. So with that gut, this patient was actually not on prophylactic anticoagulation because there was intracranial bleed and the drain was just exhausting. And luckily by the time the CT was done, the drain was very minimal, and he was on sequential compression devices. The first thing after I did, after seeing the CT, was I removed the SCDs, and then I have examined both the lower limbs from the groin to the toe, and I could immediately make out that there is a left lower limb whole swelling. And then the first thing we did was an immediate venous Doppler, which showed both proximal and distal DVT. So the gut possibility was PTE, and the supporting factor was the patient was not on prophylactic anticoagulant due to hemorrhage in the brain, and he is on sequential compression devices. SCDs were removed, the venous Doppler was ordered. So CTPA has to be done to establish pulmonary thromboembolism because this explains an embolism. But then because anticoagulation is an issue, the drain is scanty from the from the operative site. Prophylactic anticoagulation was started because the blood is very scanty, and we wanted to wait for therapeutic anticoagulation because that is what has to be given in a case of high risk PE, that is wherein there is hypotension, and also thrombolytics, which we could not in this case because this patient is already having a history of intracranial bleed. CTP was deferred because his creatinine was also high, which is again suggestive of ventilator associated pneumonia. And then we took a nephro opinion. The nephro has said that in acute kidney injury, there is no need to defer CTPA or any contrast studies. It can be given. Studies show that there is no bad deterioration in AKIs when you give creatinine if it is absolutely necessary. And in this case, it was absolutely necessary because this patient might recover from the neurological injury, maybe over a period of months or years. And that is a different call. But if this patient has DVT actively and he's already having an infarct, that means that the thrombi can always travel up again, and second or third time it might turn into a life-threatening PTE. Already it is a refractory shock and it is a high-risk PE, and so the call was taken to go for CTPA immediately. CTPA showed pulmonary thromboembolism and therapeutic, you can see here. You can see that the subsegmental, it's actually not clear, but there was a subsegmental thrombus here, and the thrombus on the left side you can see very clearly. And therapeutic anticoagulation was started. So this case, I just want to index with this case, wherein this is another such case which we saw previously in the ICU, wherein the patient presented with chest pain and nothing else. And when we did the CT, we saw this. And we could not understand as to what is the cause for the chest pain. At that time, we were new for public consultation, and then when we were going through the literature as to what might be the possible cause of this, and when we saw that public consultation can be an infarct and it can be due to pulmonary thromboembolism, then we went ahead with the CTPA in that case also. And as you can see, there is a thrombus and the public consultation here. You can see the thrombus clearly in the arrow in the second lower part. The thrombus, which is, and adjacent to that there is public consultation, and in the above picture also. So this case helped me out in in this case, and basically that was the gumption I used and ordered for a CTPA and a venous Doppler, and that was the gumption which made me remove the SCDs and see as to what is wrong and that this is not VAP. Otherwise, it is very common scenario in ICUs where intubated patients have VAP, they go into refractory shock, sepsis, MODS, everything, and then the story goes on. So this is the first case. Case 2, this is a young male again who met with a road traffic accident and sustained bilateral femur fractures. Admitted elsewhere and operated on one side with open reduction and internal fixation. Intraoperative transfusions were given due to blood loss during the accident. Developed acute onset SOB with hypoxic respiratory failure and referred for further management to our center. Because the moment he was operated, within 1 to 2 hours, he developed acute onset SOB and was referred to our center with type 1 respiratory failure. In the ER, he was in respiratory distress. The actual plan was for intubation, but we waited and we thought of giving an NIV trial. There was respiratory distress despite being on an IV. This patient came in the midnight. Early in the morning, we have seen CT was done by then. And so this is the CT picture. So as we can see, there is bilateral consolidation. We cannot call it an ERDS picture because it is not completely in the 4th quadrant, but there is bilateral consolidation, and we can see that in the coronal images that almost from top to bottom, except in the episis, there is involvement of the lung. So somebody who is having a femur fracture and then operated developing acute SOB, we all have that gut. What it is? fat embolism. But how do you prove it? It is not easy. It can, there are people who will argue that it can be community-acquired pneumonia, but how come community-acquired pneumonia happens at the time of trauma? You must be having symptoms before that. It can be transfusion-associated lung injury as well, because he was given multiple blood transfusions during the operation, and it is very much possible it was the biggest DD to be ruled out. But and it can be TACO, that is transfusion-associated circulatory overload, and then the gut, that is the fat embolism. So proving fat embolism is one aspect here, which we did with some criteria, but it is not sufficient enough to start treatment. So if it were CAP, it does not happen suddenly. If it were HAP, the patient was in hospital for 2 days before surgery and there was no hypoxia until he was operated, he was stable. If it was TRALI, it is possible, but usually develops 6 to 72 hours after blood transfusion. Here the hypoxia was almost sudden in onset. Within 1 to 2 hours, the patient was hypoxic, immediately post-op. And TACO, the echo was fine, the IVC was normally collapsing, so there was no circulatory overload. So we ruled out TACO. The only thing remaining was, the TRALI, which we still can't rule out. But to justify the gut, I delved into the CT, deeper look into the CT. Actually, there is no conventional method of seeing the CT in this way, but if you can see here, basically CTPA is done in this case to rule out if there is any segmental or subsegmental thrombi, which could be fat also, but there is nothing which is suggestive of like that. And if you see here, if you can see the attenuation difference here, in the collapsed lung, you have two different attenuations, both on the left side and the right side. On the left side, you are able to appreciate it better. And there is, it is like a fat attenuation. And then if you can see the other pictures also, in the sagittal view, if you see, in the upper part, in the collapsed lung, you can see a blackish attenuation, which is again possibly a fat attenuation. But then the radiologists say that you cannot see fat attenuation in the lung parenchyma. It couldn't be due to an artifact. So we cannot prove fat embolism in this case. This patient was having anemia. This patient was having mildly deranged LFTs. This patient was meeting the Gertz criteria of fat embolism. But then proving it, taking it to the gut and starting on steroids. Because again, there are two schools of thought in fat embolism and fat embolism syndrome. One school of thought believes in pulse steroids. One school of thought does not believe in steroids at all. So taking a decision is not easy here. The patient is on NIV and he is imminently going to be intubated. So there was no other choice. Unconventional way of this thing here, what I have did is that because the fat usually, whatever attenuation we have seen there, it is the basic thing, but the fat tends to go to the periphery of the lungs and then settle somewhere in the epices or in the near the diaphragm or to the last of the vasculature, because it has to travel through the vessels. So what I have done is I have went to the CT console and I have checked the attenuation at the epices where there is patchy consolidation. It is showing -163, which is suggestive of fat attenuation. And again on the right side, here it is in the periphery. In the periphery, almost at the apex, you can see a pleural-based small patchy opacity where the fat attenuation was -129. These two things I took into account and I advised steroids, not a pulse steroid, but a Dexa 4 mg IV BD. This patient, surprisingly, within 1 day he came out of NIV and he was on 2 liters of oxygen. As I told you, steroids and fat embolism, two schools of thought, and the Gertz criteria are fitting, but no documented evidence, which is not sufficient. Urine for fat globules also we have sent, it was negative. Steroids were started, the pulse steroid was avoided. From NIV to oxygen on nasal prongs in 1 day, off oxygen in 2 days, operated for the second femur and discharged on room air. So steroids did make a difference. Radiological signs fueled the gumption. So sometimes we have to go out of the way and see for evidence to justify whatever gut says, and then we have to take a call, because if this patient is left like that, what other possible cause can be there? If it were TRALI, actually it would usually subside within 2 to 3 days, and there will also be other blood parameter abnormalities and all these things. But it was somehow, we have seen many cases of TRALI, but it was not fitting into TRALI picture at all. And The only thing was that the fat attenuation, the globular fat attenuation, which you can see here, here in this part, which triggered everything, and probably I thought tracing the fat to periphery and checking the attenuation might give us a clue, and we went ahead with steroids. The patient was out, and Dr. Aditya knows this case very well. So the case 3, this is a case of polytrauma in elderly female. Multiple fractures are there. There were fractures almost everywhere in the body. She was in poor ICS when she came to the ER, intubated and ventilated. The initial CT brain was normal, and there was left lung collapse, which because of the ET went into the LMB and it was repositioned subsequently. The issue with this patient was, basically, I was given, it was under me because, there were polytrauma, but the major issue was she was in respiratory failure. She had lung contusions and lacerations. And from day 2, she had 106 fever, and it wasn't subsiding despite giving paracetamol in the highest of the doses. Despite maximal medical therapy, the fever was not responding. On day 5, there is no fever resolution despite broad spectrum antibiotics. There was no improvement in sensorium and the lung opacities on the right side. The lung opacities are not expected to resolve within 5 days or 1 week, but why shouldn't the fever come down? Maybe it is a neurological cause of fever. The CT brain was normal. So the only thing which we could do was go for an MRI brain. MRI brain was done to rule out neurological cause of fever. The ball was actually sterile in this case, and MRI shows a starry appearance, these whitish things you see on the MRI. The starry appearance, and it was reported as a possible fat embolism or possibly influx. So when discussed with the neurologist, he said that influx can also present like this. We cannot guarantee that it is fat embolism, and he has given some drugs also to reduce the neurological fever, but fevers of neurological origin, but there was no response basically. So again, going by the gut, if this were due to fat embolism, the only way we can reduce her fever is probably by giving steroids. Again, going by the gut, we have given her steroids. Her temperature came down to 100 F within 2 days, and her sensorium improved. She was obeying commands at the end of 3 to 4 days, and FES establishment is difficult. Steroid practice in FES is controversial, but then gumption defies guidelines sometimes. And again, this patient, fever is not the point here, but why should the fever happen, and what is the next consequence? Because if the fever is there and there are so many fractures which are not operated, basically they were prospectively posted for surgery, but with the kind of fever she is having, though she was relatively stable on mechanical ventilation at an FA of 40 to 50 like that, because of the fever and all these things, if at all she has a secondary infection again, then probably she will land up in sepsis mods. Fortunately, she wasn't in sepsis or mods until that point of time. So giving steroids, her fever came down to 100, but it was continuously 100 all the while through the hospital stay up to probably 12 days. She stayed in the hospital for 18 days and then shifted to the rehab on tracheostomy. So case 4, a middle-aged male admitted to the ICU in type 1 respiratory failure for community-acquired pneumonia. Intubated and ventilated, received a call in view of right lower lobe collapse. I don't have the picture of right lower lobe collapse, but there was right lower lobe collapse, and the bronchoscopy was planned to extract mucus plugs, if any, because that is the most common scenario why we get a call in ICU. There will be a collapse and there will be mucus plugs. We go suction them out and come. If they are very bad, we use the cryo and do it. And we also take ball at the same time, just in case if we find any organism. So that and send for biofire or something. So that was the basic plan for this case, because it was like any other community acquired pneumonia with type 1 respiratory failure who was mechanically ventilated and intubated. But then the CT showed right main bronchus narrowing, as you can see. There was right main bronchus narrowing. I do not have the pictures of the right lower lobe collapse. Somehow I missed them. But at the same time, you can see some ground glass opacities on both the sides. And the ground glass opacities are basically very adjacent and almost they are coming out of the vessels. They look like they're coming near the vessels. So there was some kind of skeptical thing before going for bronchoscopy, but still we went ahead. The right lower lobe collapse possibly was due to secretions pulling up and all. The bronch revealed what seemed to be a clot, but was very fleshy. Initially it was red in color. We tried to remove with forceps biopsy, it didn't come. Then we put a cryo. Even with cryo, we were able to remove bits. Usually with cryo, we can remove any clot in toto. But in this case, we were only getting pieces and pieces, but it was not coming. Fortunately, it did not bleed. After 2 passes of cryo, we stopped doing it only with the gumption that, this is possibly a fungal infection because there are groundless opacities and they are around the vessels. He is a diabetes de novo and there is a possibility of fungal infection. So if you can see the bits, they are almost like clots. But they were actually, they were expanding. They were not like, you are not able to break them and this thing. And those are the bits, after putting in saline, they have actually turned their color. They are not looking like clots, they were like fleshy material. And then I was like behind my pathologist asking them, sir, is there really no clot in it? No clot in it, not at all. No, there's no clot, no blood at all. The blood which was there, which was small bleeding was there, it was suctioned out, but it was complete tissue. And to our surprise, though the endobronchial growth could be debulked using rigid bronchoscopy, the option discussed and denied with the attendants. Because this patient is already on a ventilator, we can as well take him to the OT, do a rigid bronchoscopy, debulk the tumor. But then we have the suspicion that it could be fungal. And if it is an angio-invasive aspergillosis, it would badly bleed and there's a possibility of death on the table. This gut was basically a medical-legal gut. Sometimes this gut is very important because we will land up in troubles if we try to intervene in such cases. This case was deliberately avoided because basically any fungal infection, it is a poor prognosis. If it were really an angio-invasive aspergillosis, it is even more a bad prognosis. If it were even having an endobronchial component also, then it's really grave prognosis. So in 2 to 3 days, there was bleeding from the ET and extensive opacities on X-rays, as expected. And there was massive hemoptysis. Subsequently, there was a massive bleed from ET and the patient succumbed. And then the pathology report came. The HP revealed aspergillosis with angio-invasion. Not intervening, especially when the prognosis is expected to be grave, is the bravest gut ever, is what I gut feel, basically. So this case, we were really fortunate that we didn't intervene and we didn't go aggressively. Not going aggressively is also a very, very important thing, especially when the patient is in the ICU. So case 5, this is very typical WhatsApp gut. WhatsApp gut is, this patient is actually one of my patients in another town as recommended to WhatsApp chat with another patient because it was a middle-aged male, was apparently admitted to hospital with right chest pain and fever. He was diagnosed as community-acquired pneumonia and treated with antibiotics. CRP, which was high, came down and fever subsided. 5 days of antibiotics was given and he was discharged from the hospital. And then fever recurred again after coming back to home. There was no SOB, chest pain reduced, and he was contacted for guidance. On deep probing, actually, everything started with chest pain on the right side. After 1 week of bed rest, for a small fall and ligament tear, for which a cast was put. Fever for 1 day after chest pain. That is, after 1 day of chest pain. Initially, there was chest pain on the right side, and then he developed a fever. I asked them to send the CT films and asked them to send the pictures of the lower limbs on WhatsApp. Again, they didn't put the CT properly because, if you see the pathology is on the left side, it was a reversed CT. If you can see again, there's a pleural-based consolidation. And if you see in the mediastinal window, if you can zoom and see, there is again bubble consolidation in this. So again, bubble consolidation came. So, and now if you see the limbs, both the limbs appear to be fine in the first picture, but if you see the second picture, you can see that the right limb is somewhat swollen. And with the cast there's all possibility that there is a formation of clot. So the first thing I advised is, it's not pneumonia, it could be PTE, it's a possible infarct which got infected. I advised them to ask to go for venous Doppler, 2D echo and CTPA straight away because, and a cardio consultation wherever possible. The last thing which the patient attendant told is that the patient is on antidepressants. It was actually a picture sent wherein I could find out antidepressants and antipsychotics in that. This is a patient of paranoia, schizophrenia, and he was on treatment for both depression and schizophrenia. So antipsychotics and antidepressants in the prescription are more risk factors for PTE basically. Basically all antidepressants are risk factors for PTE and most of the antipsychotics, especially this there's one newer drug which the psychiatrists are using very commonly. I'm certainly not getting it, but you know that, sir? Risperidone కాదు సార్, న్యూవర్ డ్రగ్ ఒకటి మిత్రాజిన్ ఎంతో వస్తుంది అనుకుంటా సార్. కాదు సార్, నాట్ మిత్రాజిపిన్, ఇంకేదో ఒకటి ఉంది సార్. ఐ హావ్ సీన్ మెనీ ఆశా ప్రిస్క్రిప్షన్స్. That drug I googled, and it has a very high risk of PTE, but the literature says that all antidepressants has the same risk of PTE, and they also contemplate that depression itself is a risk factor for PTE. Very surprisingly, all of this I came to know after seeing this case. So the thing is that again here the gut feeling is that bubble consolidation is there. The fever is coming. Fever can come because of probably it is an infarct and it got infected, or maybe necrosis is going on. Fever can happen. What is there? Surprisingly, the cardiologist saw the case and he advised 2-deco and D-dimer. The 2-deco was unfortunately normal, and he advised a D-dimer, and the patient was sent home reassured that it was infection. Go meet the pulmonologist you are meeting, and there is no PTE. But then the D-dimer result came in the evening, which was 11,000. So then I told them, you go get a venous Doppler. For one day they didn't get an appointment for venous Doppler. And then I insisted on venous Doppler, even though they went and met a cardiologist. No, you should get a venous Doppler. And then the Doppler showed DVT. And then he was hurriedly rushed to the hospital and admitted. And then a CTPA was done. There is pulmonary thromboembolism. So it was nearly 10 days from his onset of fever that a pulmonary thromboembolism was diagnosed in this case. And in this 10 days, what happened to the infarct is that it got necrosed and got cavitated. The latest CT film, I don't have the film, I have the report of the latest CT. It shows there is a cavitation pleural based. So it was cavitating and it is undergoing its own degenerating issue. So that can as well get infected, and he might be having recurrent episodes of fevers, and we don't know how it ultimately turns out to be. But here again, the gut it's a WhatsApp gut. The gut was on the WhatsApp. But it's basically an ICU case because he was immediately asked to come to ICU and get admitted in the ICU once the doctor saw the DVT report. So these are my guts, sir. With that I close. Thank you. I am hoping there are no questions.
Still there can be some questions. So one of the takeaways from Dr. Vamshi's talk is use the clinical information, get into the history very deep, methodically, and importantly, don't treat the reports. Just because bronchial wash has shown a fungal element doesn't mean that patient has got full fungal infection in the lung. You'll be missing something else. You may be treating the supposed quote-unquote fungal infection, but you will be missing something else. So don't treat the reports. And one of the things where we can't give anticoagulants, like in this case, where the patient had a subarachnoid hemorrhage, but patient has got DVT and pulmonary embolism, one of the things is putting a greenfield IVC filter that would stop any further occurrences of the clots. And for fat embolism, we used to use a triad. The triad is suddenly the patient, there is a change in the sensorium. And the second one is patient becomes hypoxic. And the third one, patients may have petechial spots on the skin. Of course, they say you will also see something in the conjunctiva, but our ophthalmologists have probably never picked it up. But at least, the sensorium change, the petechiae on the skin, and hypoxia, and the most important, the history of the fracture, because femur fractures are notorious. Although femur fractures are so common, but it is only 1 to 2% of the femur fractures produce fat embolism. The remaining 98 to 99% get away. So if there is a fracture and if you have these three things of the triad, no matter what, think and put fat embolism on top of the diagnosis. Then Dr. Vamshi mentioned about the cardiologist doing a 2D echo. 2D echo was normal and the patient was sent back. There is no role for 2D echo in the diagnosis of pulmonary embolism. It will only reflect the pathophysiological changes happening because of the pulmonary embolism, but it is not diagnostic. What is diagnostic is the situation where the patient is. Patient had a fall, patient had swollen leg, and patient was using antidepressants, and patient is becoming hypoxic. So, and most important, keep doing the D-dimer in all these situations. D-dimer is very sensitive. And of course, in trauma and in surgery, it may not be very specific, but in without the trauma, without the surgery, a patient walking in with a high D-dimer is a clear-cut candidate of pulmonary embolism. And of course, you can do a DVT scan. Even if it is negative, you can go ahead with CTPA, and then of course, the diagnosis will be on the wall. So these are my comments and comments from my co-chair. Yes.
The very high index of suspicion is in the right circumstances is the one which we taught in our internet. Whenever you have a right circumstance like a polytrauma, a bedridden patient, malignancies and all those things, a very high index of suspicion should be there to diagnose a problem. I mean, you want to look at it. If you look at it, you will get it.
Yes, sir.
That's one thing. And then regarding 2D echo, sir, I mean, like if there's a right heart strain in that setting, it decides to treat. If you go for enzymes also like TROP and then ProBNP, you can go for a treatment aspect. Treatment will be decided based on a echo,
Yes,
echo, and then the evidence of thromboembolism. These are 2 points I want.
Yes, sir. In pulmonary thromboembolism, most of the times the 2D echo will be reported normal, or there will be mild elevation in pulmonary pressures, which can also happen with airway hyperreactivity. But the problem is the heart endures a lot. The right heart endures a lot, basically. So if the patient is having PTE and is having RVSP of 60, 70 or 50, then it is possibly an acute and chronic PTE. If the patient the echo is normal, and if there are signs of PTE and there is documented PTE, then probably it is the first time that the patient is having PTE, because the heart can endure to the maximum extent possible. That is why they say that many pulmonary thromboembolisms are come and go silently. And that is why we have an entity called CTEPH, which is a group for pulmonary hypertension, CTEPH, because CTEPH develops in patients who had a history of pulmonary thromboembolism. They might not even know. Of course, the percentage of patients having PTE who develop CTEPH is less than 5%, I suppose. But still, CTEPH is a big entity, and we have seen cases of CTEPH also. So the thing is, echo is not a deciding factor at all in pulmonary embolism. If at all the RVSPs are high or the PAPs are high, then probably it's a supporting factor. Ultimately, we have to prove it. And in this elderly woman who had many fractures, there is no long bone fracture. A long bone fracture would have reinforced our suspicion, but that patient was not even having a long bone fracture. It was lacerations of the toes, fingers, everything, and she had clavicle fracture, scapular fracture, but no long bone fracture in that case. And MRI, we are not competent enough, though it was reported in favor of fat embolism or infarct. So if at all, it was a tough call to make, but because I was the primary consultant, I could make it easily. And if it is a secondary referral, you need to convince a lot. That's the only difference.
So again, in heart embolism, I understand, so like there is no evidence for, strong evidence with regard to use of
steroids.
Steroids may help in relieving the hypoxia, but there is no effect on mortality.
Yes, and mortality. And second thing is that if at all the patient is also having an infection, it might as well increase, the severity of infection. So it is a very big challenging decision to take, and risk to take, basically, more than a challenge for the patient and for us also.
Dr. Sriram has a question.
Sir, pulmonary embolisms after workup, we found that almost 10 to 15% of the time would give the diagnosis of occult malignancies.
True, sir.
Literature. And the malignancies itself are the triggering point for this.
PTE.
Yeah.
Yes, sir. In any case who comes with a PTE, see, basically there is a previous terminology called provoked PTE, unprovoked PTE. The last case, the WhatsApp gut which I told, is a provoked PTE because of the trauma. And the other cases also, they were provoked because the patient was not on anticoagulation, he was on the bed for a long time, he was a kind of obese, and there might be other risk factors also. We have to see the thrombotic profile also, we have to see if there was any protein C S deficiency and these things. But unprovoked PTE is always the concern because we do not know what provoked the PTE, and in those cases the incidence of malignancy will be high. That is why if any patient out of the blue has come with PTE, we usually in the recent past have started advising PET CT scan to see for any primary of unknown origin.
Sudden death syndrome on postmortem has revealed a lot of this pulmonary embolisms in malignancies.
Yes, sir. Yes, sir.
Very good point, Dr. Sriram, because when a case of pulmonary embolism comes, we start looking for a cause. Why did pulmonary embolism happen? Yes, the textbook shows a long list of causes. But you do everything and then ultimately you don't find a cause. And studies have shown that when you follow up these cases, eventually there is some one malignancy somewhere. So we cannot just leave them alone. We have to follow them up. And in these days where PET scan is easily available, maybe a PET scan would be useful to pick up a primary malignancy and then go forward. Very good point. Anybody else?
And D-dimer has a negative value,
Yeah.
positive negative value rather than substantiated pulmonary embolism in any such case.
Correct.
At least, to that extent, we should keep on doing the D-dimers in such cases. At least it will exclude pulmonary embolism as a cause for the peripheral shadows which you see there.
Yes, sir. That fat embolism case, sir, D-dimer was normal, sir. Yeah.
In fat embolism, D-dimers are not reliable.
Yeah, but we also had the suspicion of normal PTE also. That's the reason CTPA was done actually. Though fat embolism was on the highest on the cards, but still we wanted to roll out PTE also.
If there are no questions, I will ask my co-chair to give some comments. Yeah, no?
A very good talk, Dr. Vamsi. So these kinds of talks are required because there is no theoretical backing as such. We do read textbooks, but there is no clear-cut, we can't derive at the diagnosis. So it's a very good talk.
Thank you, Dr. Avinash, and for all of you, Dr. Avinash and myself are MBBS classmates. Yeah. And he has been the same since day one of MBBS to now. Not even an iota of change.
One said from his side, sometimes we have seen some hemothorax like pictures in severe pulmonary infarcts, wherein aspiration revealed it was like typical blood tinged this thing, but it turned out to be pulmonary infarct. Did you?
In the sense, turned out to be pulmonary infarct, in the sense like
patient presented with consolidation, with effusion. Tapped the effusion, it was blood tinged, dark, hemothorax like picture. Yeah. So that also sometimes can be.
Yes. The other tricky part here is pulmonary thromboembolism is the only condition which can cause both a transdate and next date, and also hemorrhagic effusion. So, Dr. Bharat was saying in his talk, nowadays people are coming more with effusion and consolidation are turning out to be PTE. So, I think we are seeing more PTEs these days than before in the last 3-4 years. Some attributed to COVID, some attributed to vaccine, but we never know.
Most important is lifestyle.
Lifestyle.
Lifestyle is disease.
Yes, sir.
That is why there is a change in the pattern of the disease.
Yes, sir.
Okay, thank you.
Thank you, sir. Thank you very much.
Next, I would like to invite Dr. Subakar Nadella for a talk on pulmonary nodule of the left upper lobe. And Dr. Subakar Nadella So let me introduce Dr. Subakar. He did his MD and PDCC in interventional pulmonology from SGPGI. Now he is a co-consultant, my co-consultant at KIMS Kondapur. He has 4 years of experience in critical care. And okay. Yeah, so I take over, you can take over from my side.
Thank you, sir. Thank you very much. And thank you, Dr. Vamsi sir and Yugandhar sir, for having me over here. I just was going through your talk, sir. You really had good gut feeling. Unfortunately, I just wanted to share one thing. So where we didn't have that gut at the time when I was doing it at SGPGI, young female of 35 years, she came to us. So it was there was some opacities in the lung, so she was posted for bronchoscopy. Unfortunately, problem in institutes is one person will be seeing in the OPD, the other person will be posted in the scopy suite, and the other person will be there in the ICU. So as a routine, she was taken for the procedure, and endobronchially, they just saw some endobronchial whitish mass. So that was there in the right middle lobe. I was also there with my HOD doing some other work. So as soon as the person who was operating, who took the bite and who came out, along with him came the blood. So immediately there was a code blue and we just rushed it, we intubated her and we have shifted her to the ICU, but we could not revive it. So it was a horrible time convincing a patient, convincing the attenders that who was walking and talking, and a young female of 35 years, around 35 years age. So we had lost her on table. So later we just went ahead and saw it came to invasive aspergillosis. So nice gut feeling, sir. So let me confess, probably I couldn't get a nodule on the left side. So I may be presenting with some consolidation-like thing. So an elderly male, 72 years old, he came with cough from the past 2 months. Initially, it was with expectoration. Gradually, from the past 2 weeks, it was more of dry in nature. He also had shortness of breath, which was gradually progressing from grade 2 to grade 3. He has generalized weakness and fever for the past 2 weeks. He was a current smoker, almost 40 pack years. He was a known case of COPD and was on irregular treatment. As you see, comorbid diabetes was there, and he was treated with peptazine, tazobactam, cephalosporins, etc. So this was the CT with which he was referred to us. So for this CT, he was attempted CT get a biopsy outside. Can you get a pointer? It's not here. Okay, so like I think it's just like what the previous image with what Dr. Vamsi sir has that gut feeling over there. The same kind of picture it was seen. So they did a biopsy, but even with the first shot, patient had hemoptysis, so they stopped it and they referred to us for further evaluation. So with this, only these were the things, and he was basically referred for endobronchial biopsy. So fine. Rather than clinical part, I will just be more on the theoretical or practical part of how we do a procedure or how it has to be done. So yes, if you have a bench, if you have a luxury of virtual navigation bronchoscopy, it is very fine. You just need to load your CT, you just need to load the track and just follow what the track shows. What if, or are everyone, does everyone has this luxury of around 1 or 1.5 crores? So if you're not having this, then what can we do? Yes, this is a thing. We have to sit with the radiologist and we have to go through all the tracheobronchial tree. You have to have this spatial orientation. So just for the change, I just kept this. The same thing, literally this was the position or this was the thing which myself, Dr. Avinash sir and Dr. Kiran did in our discussing chamber. So just a small puzzle for you, especially postgraduates. Which figure is a rotation of this object? Can you just say A, B, C or D? Yeah. Any guess? It's a simple thing, just to test our spatial orientation, how it is. I know you're drowsy post-lunch session. I know it's the wrong time to ask these kind of questions. B, yes. You're good to go ahead with bronchial branching and tracing. So this much is enough. If we can just have this much of thing, we can just follow a little bit, we can read and we can just, with time we can be perfect without needing a lung point. So don't get confused. This is the overall picture, how it looks. So I just wanted to say, get yourself oriented with the tracheobronchial tree. So that's it. So first, basics are the basics, then you go one step forward, one step forward. I will just say you, I just kept this picture because, just see this is the right main bronchus, that's the left main bronchus. You see over here, okay, this is the upper lobe, and this is the kind of lingular lobe, and this is the lower lobe. Okay, coming over here, if you see, this is the middle lobe, and this is the upper lobe, and this is the lower lobe. If you see, as we all know that, on the right side, middle lobe will be more anteriorly. Whereas on the left side, the lingular lobe, you see it more laterally. And other important thing you have to know in this whole complicated picture is, you just see this apical one. You see this one B1 and this is B1, okay? So those two apical lobes, if you see the orientation, they go medially. It's arising like this and it just goes like this. Rest of the lobes, generally, or rest of the segments, they are like how we see. So then, how do we need to look, or where do we need to look? How do we need to branch? I mean, track these things. The first thing is you should have a proper CT film, and the slice thickness should be less than 1 mm. That's a basic and mandatory thing. Just see the example. Just see the one on the A is around 10 mm slice thickness cut, whereas B and C are 1 mm slice thickness cut. You just see the difference. So if you see in the center, if you see the bronchi, you can trace it. They are fine. But when you go to the periphery with this 10 mm thickness, you can't trace this bronchi. So whatever CT or whenever you're trying to sit in front of your system, you make sure that the slices should be of around less than 1 mm thickness. And then, how do we need to label them? Or yes, we want to study or we want to track it. So some naming should be there, right? So for this, we just classify these generations. Till 6th or 7th generation, we have some labeling available right now. They're not hard and fast anything, but the person who did that first, they labeled in this way. So for reference, we should have something. So we are just following it right now. Maybe in future, these labeling things or etc., they may change. So we don't know regarding that. So even the classification, if you see, the Japanese classification will be different, the US and UK classification will be different. US and UK people, if you see the general thing which we see in our textbooks, right main bronchus will be generation 1, and then they will go for generation 2 and generation 3. Whereas in Japanese classification, if we see, right, upper lobe will be the generation 1 branching, okay? And in this classification, we just need to remember that we have to label it from superior to inferior, posterior to anterior, and lateral to medial. So these are basic things when we are labeling tracheobronchial tree. Okay. So did anyone ever think why we label as B1 the apical segment? Did it strike to anyone? Generally, when we see in the bronchoscope, we just see the anterior segment, posterior segment, and apical segment. Why apical segment is B1? Why not anterior segment B2? So apical will be B1 and B2 will be posterior segment, and anterior will be B3. The reason for this is this thing. When they have named it, they named it like the superior will be the top one. So B1. And if it after superior, posterior, when we are comparing posterior and anterior one, posterior will be the next preference. So that's why posterior is B2. Anterior is B3. The same thing in the right middle lobe. Lateral and medial. So lateral will be B4 and medial will be B5. This same basic these people have applied even for the further subdivisional branchings. Okay, so after 1, then we have A, B, C, D, E, the next segmental bronchus. Okay, and after that we have Roman letters 1, 2, 3, and 4, and then we have alpha, beta, gamma, and then X, Y, Z, and then some say XX, XY, XZ also. Maybe in future we may get some other terminologies, but generally why we generally tend to look at our 6th generation is with ultra thin scope which is available with us right now, we can negotiate or we can go till 6th or 7th generation bronchi. So how do we need to look at it? First thing, we have to properly study the CT scan. And after CT scan, we have to know where exactly do we need to go. And then we have to have some marking or have this nomenclature, and then we have to go ahead onto the table. So here, just of this complicated thing, just remember only 2 things. Right upper lobe and left upper lobe. For knowing better about this, you should have an idea. Whenever we do a bronchoscopy, how do we see? So we will be standing at the head end, behind the head end, so we will be seeing in this view. Whereas the same picture, when you are observing a CT scan in your system, so how do you look at the CT scan? The film which you see in the CT scan will be from the caudal end. That means how you are looking into me. So let's suppose this is some organ over here. I'm a bronchoscopist, so I'll be looking like this. The same thing will be shown in the CT of like how you are seeing. That means that's a mirror image of what exactly is there. So that's a basic thing you should always remember. So that is the only reason, because when we see the right middle lobe, right lower lobe, left middle lobe or lingular whatever, and left lower lobe, we just need to flip the axis in the CT scan. If we flip, suppose this is the thing which we see, we just need to flip like this. When we flip like this, whatever we see over here, that will be our bronchoscopic view. Okay, that's a basic thing. Next thing, for right upper lobe and right lower lobe, what we should do? For right upper lobe, what we have to do is we have to counterclockwise rotate the CT scan by 90 degrees. That is, when we are seeing an axial section like this, we have to rotate a counterclock by 90 degrees. I'm showing reverse to you because for me it is counterclockwise. Okay, can you take the other way around? For the left upper lobe, what we have to do is we have to rotate it by clockwise by 90 degrees. Why we should rotate it? So here is the answer. You see, this is a picture where we can see as a bronchoscopist, when we are trying to trace the right upper lobe, how do we trace it? As I said to you, I stand behind the bronchoscopist and then I rotate my hand. See here, I'm rotating, for me it is clockwise direction. Okay, and then I'll be flexing the lever, then I will point out the right upper lobe. For you, suppose you are the CT cuts. Okay, for you, how it is, when I'm rotating it, it is clockwise direction. For you, it is counterclockwise direction. That is the reason, if we need to study the axial cuts, we have to rotate in the counterclockwise direction by 90 degrees for right upper lobe. The same thing for left upper lobe. What we do when we are doing bronchoscopy, we will be rotating it 90 degrees. For me, it is counterclockwise direction. And for you, it is clockwise direction. So that is why when we're reading a CT scan, for reading left upper lobe or segments of the left upper lobe, we have to rotate it counterclockwise by 90 degrees. So that's the basic for this. I hope I made it clear. And for rest of the things, as I said, you like for rest of this exact right middle lobe, right lower lobe and left lower lobe, we just need to flip it. Okay? So this is the final one. I hope now it is clear for you. So in this Kurimoto's ways, for right upper lobe, we have to rotate counterclockwise by 90 degrees, whereas for left upper lobe, we have to rotate it clockwise by 90 degrees. For all the rest of the lobes, we just need to have a vertical flip for those things. So again, another confusing thing. So yes, we did it, we understood how to rotate and whatever is the thing. Then, how should I say it to my colleague? Or my colleague or my things, where exactly do we need to go? So we should have some labeling or we should have some naming for them. As I said you, how should we name it? So just I'm going to the basics. So see in the picture one, we have the branching of the bronchi will be either vertical on vertical or horizontal. It will be like this. Vertical on vertical means it will be like this. So just imagine a three-dimensional way. So if suppose the patient is standing like this, if the bronchi is going like this is vertical on vertical. The patient is standing like this, if the bronchi are dividing like this is horizontal by horizontal. Suppose if this bronchi is going like this and some other division is going like this, that is vertical with horizontal. Okay? So whenever we have a horizontal and horizontal division, no matter if it's like this or like this, whenever we see through a bronchoscope, it will be a side-by-side vision for us. So that is why whenever we have horizontal and horizontal division, we always represent a side-by-side, like this. Whenever we are having a vertical and vertical division, suppose it is going like this. One is going up, one is going down. Suppose this bronchi is smaller and this bronchi is larger, or the angulation, whatever it is there, you can just simply put the same thing. If the upper one branching one is smaller and the lower one is larger one, you can put the upper one smaller and lower one is the larger one. Okay? These are the basics of this branching. And just to complicate things further, the one on the left side, yeah. So generally it's a dichotomous branching. Sometimes what happens is it does not branch evenly. We do have many abnormal segments or many abnormal branchings, etc. So even those should be understood and even those should be numbered so that we don't have any difficulty while we are navigating. So with these things, we can name the segmental bronchi 1, 2, 3 and 4, subsegmental A, B, C, again Roman letters 1, 2, 3, and then for subsegmental bronchi alpha, beta, gamma, and then for sixth generation bronchi we can name it as X, Y, Z. So for us, in the case which I have shown you, we at least know that grossly something there is a lesion in the left upper lobe. Okay, so I'll be confining myself to the left upper lobe because I know it's a very complicated topic. Let's make it simple with simple steps. So how does the left upper lobe generally divides? As we all know, apicoposterior segment and anterior segment. Okay, and then it will be lingular segment. Again, it will be superior lingular and inferior lingular. Okay, so this is a general division of the left upper lobe. So as I said, apicoposterior, it goes upwards. So it's in the superior part. So that is 1. 1 plus 2 because it's apicoposterior. And the one in the anterior, it will be 3. So I think everyone can label till that level, 1 plus 2 and 3. Okay. So here we need to, let's go to this. I think, is it clear? Can you see? Okay. Next thing, let's leave apicoposterior. Let's go into anterior segment. Okay. Once we are into anterior segment, then see what all other branches are there. I think rather than this, I'll better show you the video. So this was a mapping which we did it. I'll just show you with the example so you can have a better understanding of this. So this was the CT. I'm just calling it from up, cranial to caudal position in a single go. See, other than this thing, we don't have any other lesion at any place of the lung. Even the mediastinal curve, there was no mediastinal lymphadenopathy or nothing was there. So what I did, it's a left side, so I have rotated it. Okay? And then I just got back over here. And again I'm tracing it. Yeah, just see over here. See this one, this one, this one. Okay? Okay? If you have seen that picture, just imagine this is your same bronchoscopic view. Can you just say me what can this be and what can these two things be? Tell you how we see in a bronchoscope. The one which will be this side will be apicoposterior, and then what is there will be anterior. So with the same thing, as we have flipped it in such a way that whatever we see in the bronchoscope, we are seeing it right now in the CT scan. Okay? So then this will be your apicoposterior, and then this will be the anterior segments. So again we are tracing it. If you see carefully, there is something which is going like this, there is something which is going like this, and there is something which is going like this. So we could see 3 subsegments over here. Okay? Yeah, I think you see, you could see like this, like this, like this, and something which was like this. That the previous branching was there. So if you observe both the 2 subsegments, this one as well as this one, both are leading into this lesion, whatever is there, whether it's a consolidation or whatever is the thing. If you go into both the things, we can reach over there. Okay, now I think you can see clearly. Okay? The other one was going anteriorly. So even if you don't know any labeling, or even if you don't understand, sir, what is alpha, beta, which should be labeled or anything, just have this basic thing in your mind. Now just see that the same thing I will just show you in the proper bronchoscopic way. So this is our left main bronchus. And then here we could see the upper lobe, the lingular lobe, and the lower lobe. Okay, then I just put the radial probe. See here. There was one which was going like this, and now there are two things. Okay, the one which was going up was apicoposterior, which we have seen over here. And then again we are having 2 divisions, right? Let me show it over here. I'll just show it here so that I can control this. Yeah. See here? So we got 2 divisions, right? 1, 2, 3. And the same thing we just see over here. So again we got, this is the left upper. So yes, this is upper lobe, the apical. Again we got 2 divisions over here. Okay? You can see the 2 divisions. And then I'm going into this one. So again I have 2 divisions over here. See. This one, we left this and we went ahead in this. After going here, we again saw some 2 regions in the bronchoscopic view. See, this is one division, this is other division. Okay? That means we need to go into the one over here. See what we did over here. two divisions over there. So we went ahead in this lateral one. Again, we could see two divisions over here, not the upper, we have to go into the lower one. Okay? So I went ahead in the lower one. Here I'm striving to go and I went ahead. Here again I saw two divisions. Okay, let's see what we see in the CT scan again. See this. So we went ahead over here, two divisions, we again went there. Again there are two divisions over here, see. So in any of the division, if I go, I can reach that. So if I go into any of these two divisions, I can reach the target area. So I'm repeating it again and again so that it will be registered in you, in your minds. Yeah. So we are in left main bronchus. This is the left upper lobe. This is the apical segment. This is the anterior segment. It is again, we got two divisions. We have to go in, we need to go into this division. Again here we have two divisions. This will go anteriorly and cranially. This is another division. So we went ahead over here. Again there are two divisions. No matter how we go, we can reach it. But if you see, the larger one was this. This is the target area which we have reached. The same thing I have confirmed it with the radial image. So I kept my scope over there. I just flushed some amount of water. So I wanted to see whether is it the real target area or just a collapsed segment. So even after flushing the water, I couldn't see any pedigree and see the radial one. You see over here. And then from there, we took the biopsy. So is it we didn't have the privilege to have a lung point or anything. Study shows that both lung point and this manual bronchial branching, these are complementary to each other. Nothing is superior to other thing because we have some difficulties or flaws even with this lung point. We see if the proper voxel is not there or if the CT quality is not proper, it will be difficult even for the lung point here. The three bifurcations were missed over here. So it depends on the quality of the CT which you acquire. Though for this case, the cytology, sir, it didn't go with your gut. It came to be neutrophil predominant and it has organizing pneumonia with superative inflammation. For this patient, we just treated with antibiotic. We waited. Even after giving antibiotic, he did not subside. Then we started him on steroid. So as soon as we have started him on steroid, the lesion size got subsided drastically. Probably there is secondary organizing pneumonia, secondary to bacterial infection. So he's right now doing good. Only very small fibrotic part is left, and even his immunosuppression is also stopped after 6 months of treatment. So we even evaluated for ANA, etc., to rule out other things, but they all came out to be negative. Thank you.
An excellent talk, Dr. Subakar. So any questions from the audience?
So I think to avoid suction, we have to use air insufflation. And second one, saline insufflation will artifacts with the radial EBUS. And radial EBUS will have should require a patiency with the team members, more than one treating pulmonologist or dealing pulmonologist. It's unlike linear EBUS.
Yes, sir.
So these are the three things I want to add. Excellent talk for a complex to simple. You made it. Congrats again.
Thank you. Actually, it's not as simple as this. These are only simple part which I have explained it. So I think it will be better for us to go one step at a time. So once we are thorough with this, we can. If we have the proper spatial orientation of where is the anterior part, where is the posterior part, which segment is going from which part to medially or which part to dorsally or anteriorly, then we can master in this thing.
Exactly. Thank you very much, Subakar. This is the very reason I put this session. You you did what I wanted the audience to know, because tracing the CT is not only useful for tracing a nodule, but for any pathology. If you want to trace it where it is, the tracing is very important. I wanted that bronchial branch tracing to be told, not only for a solitary pulmonary nodule, or good that your case there is organizing pneumonia, it's not a cancer, but nodule has become synonymous with cancer nowadays. So the primary aim is that bronchial branch tracing is a technique which exists and which every pulmonologist should be aware of and should at least try to be competent of. They can just do the work on the CT console with the system in front of them, even though they are not going for a relievers. We can do that. Whenever I am free, if there is any lesion like this consolidation or a nodule, I'll try to trace it. I'll just keeping it clockwise, anti-clockwise, this, that, flip, and trying to trace it as much as to the possible extent. Sometimes, as you said, the scans won't be so precise and accurate and of the thickness which we expect. But tracing is one thing which we learn, because the very first thing I told to Bhattu sir when I was planning this session is that not everybody has the privilege of lung point or navigation. Nowadays we are all having different kinds of navigation techniques. Now Fusey has come up with an inbuilt navigation in it, the synapse. But the thing is that ultimately, without bronchial branch tracing knowledge, whatever system you are using, without that system, you are nowhere.
Yes, sir.
So if you are not aware with the basic art of tracing, then without the technology we are nowhere. So that's a very good talk. Thank you.
Thank you, sir.
Why it is a clinical vision?
Yes, sir.
Why you are not known for this?
Percussion CT can biopsy.
So the first choice was CT gate biopsy. They have to stop the procedure because the patient has hemoptysis on the table. So then they were referred to us. It was attempted outside with the CT gate biopsy. On the first, when they went in, as said by the doctor who was referring and the attenders, so the patient had bleeding on table, but the sample even which they have sent it, whatever they got in the first attempt, that was inconclusive. So this is not a case for radiolipid, sir. Yes, I do agree. But for us, it was like biopsy was attempted and then it was a failed one, so we have to go ahead with this thing.
So in Kidwai Memorial Institute of Oncology, one of the surgical oncology thesis was peripherally located lesions, ultrasound guided biopsies were his thesis. Can we do in this present area also, sir?
So ultrasound guided biopsy?
Yeah, peripherally, such a peripherally located.
Yes, sir, we can do ultrasound guided biopsy also. This thing, we can access it with ultrasound, sir. Yes, definitely.
Because it is very cost effective.
Yes, sir.
Currently, one of our PGs is doing the same topic. Comparison study with the US Gen CT grad biopsy for peripherally located tumors. We didn't publish the data yet, but we were working on it.
Yes. Even in the chest hospital, we should do n number of ultrasound guided biopsies only. So we.
Ultrasound room is the most sought after room in PG days.
And also, I was wondering, like, why the biopsy was attempted first instance, because, like, whenever there is some kind of experience, generally we will be using some prognostic tools or indicators like Mayo models or something. Straight away, or else, like, we could have used some LDCT, keep the patient on follow-up. Like, I was just wondering, like, why all of it, so I don't know what that made. The referring physician maybe.
The first thing they were concerned was like cough, which was not there. Even though he was a COPD patient, on and off inhalers, there was issue of weight loss and everything. So I think I just. I think he's not getting it. Slide. Okay, fine. As the history says, sir, the cough was only 2 months duration with expectation initially, and then it was dry in nature. It was a persistent fever from past 2 weeks. Generalized weakness was there. So all these things were there. If it was a sputum, would have been then they might have sent it for a gene expert or whatever. So either there was no gene, it was only dry cough as well with the history of 40 pack years of smoking and with the COPD background, they attempted a CT gate biopsy. So even we thought, sir, we thought, do we really need to go for a this thing? Because especially when the patient comes post procedure with some hemoptysis or anything, yes, the risk even lies more with us also. So even if for me going for cryoballoon biopsy was also a bit risky. So we even thought for twice for this case whether do we really need to go. So after examining all those things, and we went ahead with this. Yes, another thing, PET CT would have been better to rule out infection, but unfortunately we don't have that in our center. So it's the general tendency of the physician, whatever is available with you, you try to do it. And this was cost effective also, rather than sending him for PET CT again, retrospectively this thing.
And I think even the size of the lesion is big enough to proceed with the diagnostic modality.
For the youngsters, doing the bronchoscopy is like learning to swim or ride a cycle or a scooter or any other vehicle like a car. When you start reading about swimming in the textbook, it looks scary and you will never get into the water. So I think we had a rule in Yashoda Hospitals, Hyderabad, when I was running the show, that the young DNB students are supposed to wash the bronchoscope for 10 times, for 10 procedures, then watch 10 bronchoscopies, then assist 10 bronchoscopies, then do 10 bronchoscopies under supervision. So as a result, by the time each DNB passed, each one of them has done something like 200 to 300 bronchoscopies. And the other part is, Dr. Sriram has raised a question of ultrasound guided FNAC. During my early part of my pulmonary practice in the 1980s, I think I have done something like 50 CT guided FNACs for chest, because at that time nobody was ready. So I was ready, so I started doing it, and I gained a lot of experience. The one difference between CT guided and ultrasound guided is, ultrasound guided is real time. You can see where the needle is going, where the lesion is. It's real time. Whereas CT guided, you take a cut, you mark on the skin exactly where the needle should be put, and then again you come out of the CT scan room and then watch whether the marker that you have put is at the right place, and then again go back, put the xylocaine, put the needle, push it inside, again you come back. So it is not real time. It has to be multiple times, you have to go in and out, in and out. So that's the problem with the CT guided FNAC. Whereas if it is abutting the pleura, abutting the chest wall, ultrasound is the best.
Yes, sir.
Thank
and
you
sometimes,
so
sir, even the lateral, whenever for CT guided biopsies, it is placed somewhere over here, the lesion is somewhere here, it will be very difficult while going into gantry, sir. You have to position the patient. There is an advantage with ultrasound where we can just put the probe and we can go ahead.
Correct. Of course, these days the gantry is much wider, and we can always bring the patient out of the gantry, put the needle, push him again back into the gantry, and things like that. There was stories of Siemens CT scan machine where an obese patient got stuck inside the gantry. And the GE company, which is a rival company, they took the picture of the obese man getting stuck and then said, see, our gantries are much bigger.
Thank you, sir.
Thank you, sir.
Thank you very much. And again, I take pleasure to invite Dr. C. Satish Reddy, the consultant intervention pulmonologist, who has done his MBBS and MD2 at KMC and DM from Ananta Institute. He is currently practicing at Yashoda Hospitals, Malakpet. Welcome, Dr. Satish.
Thank you, sir, for the introduction. I think half of my talk covered by Shubhaka, sir.
Yeah, before going into discussion, is Professor Kurimoto, who is a pioneer in this branchial branch tracing. I would like to suggest everyone to go through this book. This is branchial branch tracing. Yes, sir. Available. So this is a basic rule of airway nomenclature. Priority already mentioned. Priority goes from superior to inferior and posterior to anterior and lateral to medial side. That's why right upper lobe divides into apical is RB1, posterior is RB2, anterior is RB3. So this came from this book, this classification. And this is a very basic branchial nomenclature. Main bronchus considered as 0 generation, intermediate as 0 to 1, upper lobe, middle lobe and lower lobe as first generation, segmental bronchus as second generation, and subsegmental third, subsegmental as fourth, and subsegmental as fifth generation. This further division based on fourth and fifth is named small 1, small 2 and alpha beta based on the branch of A and B. And as the basic rule is cranial, dorsal, lateral is they defined as 1 and alpha, and caudal, ventral and medial side is defined as less priority, small 2 and beta. Yeah, right upper lobe will have this 3 segments. This is middle lobe and lower lobe. This right upper lobe will have 3 segments. This RB1 is apical segment, RB2 posterior, RB3 is anterior segment. Again, each segment divides into posterior segment divides into RB2A and RB2B. An apical segment into RB1A and 1B. This enter into RB3A and RB3B. For evaluation of lung nodule, whenever you see a lung nodule in the CT, you should decide whether to target, whether to sample or not. Further, you should see whether any positive bronchus sign positive or not. Once you decide to sample, you should choose a steering device, whatever, whether ultra thin bronchoscope or robotic bronchoscopy. Here we available in India, available only ultra thin bronchoscopies. After deciding the steering device, we should need a proper road map to reach the target, either virtual bronchoscopic navigation or branchial branch tracing. Once you reach the target, you need to verify whether you are in the target or not before sampling with the help of radial EBUS or cone beam CT. This is a virtual bronchoscopic navigation. This is will show how this will this showing this road map to the lesion. Currently we have the luxury of VBN, but nowadays we are also just trying this branchial branch tracing technique. Yeah, branchial branch tracing, this is literally means to translate CT images into bronchoscopy images. For that we need less than 1 mm thickness of CT. So I am confining to only upper lobe to see, to trace the right upper lobe lesion that already Shubhakar sir mentioned. We need to rotate the right upper lobe into a counterclockwise 90 degrees. Then if you see from the, after, you can see in this, this is rotated CT images of 90 degrees counterclockwise. If you see from the upper lobe entrance, that is almost coinciding with the bronchoscopic image. This is the B1 at apex, this is the RB1, this is the, you see this is the RB3, this is the RB3, this is RB2, this is RB2. This came from this book. If you rotate 90 degrees counterclockwise, that is almost coincide with the right upper lobe. Next, we are moving on to case. This is a 44-year-old female, initially presented to ER with new onset seizure. In the ER, they did CT and MRI that showed a ring-enhancing lesion at right temporoparietal and left cerebellum. Patient initially admitted under neurology department. They evaluated, and later they did PET, the CSF and all. They evaluated, that is inconclusive. They did PET CT, whole body PET CT, to rule out any malignancy and tuberculosis. The PET showed a metabolically active soft tissue lesion in the right upper lobe. SUV max is 14, so size is around 2.4 into 2.2. Any subcentimetric mediastinal lymph nodes and thin rim of right effusion, and metabolically active lesion at the right temporoparietal area, and metabolic active lytic lesions in left shaft of humerus. This is a right upper lobe lesion with positive bronchus sign, this pleural tract and spiculated margins. This is a ring enhancing lesion, and this is this SUV max is almost 14. Then is the like how to get the diagnosis, whether actually we discussed that I think most of other specialties, they don't know about our procedure. So neurosurgeon they said he will do the craniotomy and biopsy. Then medical oncologist involved, they planned for CT guided biopsy also. Initially we also thought CT guided, but in between the lung parenchyma is there, so high risk of pneumothorax. So and if she is already this brain lesion is there, all seizures, if you get the pneumothorax again, admission and all, she may need more admission days. So we convinced the primary team, and after MDD we planned for the bronchoscopic approach. So this is unfortunately our PACS has some problem. I don't have the CT video. So this you can compare this when you are tracing. This is a CT image. We rotated 90 degrees counterclockwise. You can see this is the B3. After B3, this is the B1 and this is the B2. You can coincide with the bronchoscopic image. This is the B3. Here the B3. Here the apical segment. Here the apical segment B1. This is another branch is going. This is the B2. This is the B2. You can see here B1, B2. Sorry, B1, B2, B3. Here B1 apical. The B2 is the anterior segment. You can see the B3 segment here. So again, this B2 is dividing into B2A, B2B. Here the B2A, B2B, and B2A again further divided into B2A1, B2A2. I think this is, I hope everyone understands, this is a little confusing. You can compare this CT. This you see, if you correlate with, this is the B3, this is the B2. So you can see here, this B3 is going this side and B2 is this side. If you correlate with the counterclockwise, this is the with CT, this is the B3 and this is the B2, the lesion in the B2 segment. So this is a lesion in the anterior segment, sorry, lesion in the posterior segment. So the B2, again two divisions is there. So B2A and B2B, this is correlating with the lesion is almost correlating with the B2A. Here the B2A and B2B, you can see here two, in the B2, we have two branches. This is the B2A, down is B2B. Here you can see this is the B2A, this is the B2B. This lesion is almost going into the B2A segment. Then we planned radial EBUS under general anesthesia. Lesion was visualized with the, here we used the steering device, target was fixed, we used the steering device, pediatric scope, P190, and this is the RB2, it's the RB2B. This is the RB2A. I think video is little. This is RB2A1 and this is below is RB. You can see this is RB2A1, this is RB2A2, 2, small 2. Here you can see some mucosal abnormality. Here you can see some mucosal abnormality. So once then we have confirmed the lesion with the radial bus. The radial bus shows almost concentric image. The concentric image almost. So later we did biopsy with cryobiopsy from the lesion. Cryobiopsy with 1.1 probe. So whenever we do the procedure, we will call the pathologist inside. Biopsy imprint cytology showed atypical cells. The HP-IHC was suggestive of adenocarcinoma lung. So in this case, technical challenges was convincing a apprehensive lady with young female with new onset seizure for invasive procedure. We have to convince the primary team and medical oncologist and neurosurgeon. So in spite of the positive bronchoscopy, we don't have like obvious lesion or adult FOB. In pediatric scope, we can find some mucosal abnormalities. Whenever you see the lung nodule, you think of all modalities for the diagnosis of nodule. Select one best amongst them to confirm in one setting. So thank you.
Very good talk, Dr. Satish. In this case, one of other challenge was patient attendants asking, are you sure with endobronchial approach, diagnosis is 100%, or we go for a craniotomy? So we opted with a gut feeling as previous talk. Bronchus sign is the clue here. Once you have a bronchus sign, yield will be good and we can get the lesion. We can avoid a scar on the skull. Thank you.
So recently only we started this branchial branch, this thing. We have the VBN actually. So
any questions from the audience?
If the patient's expected life is more than 6 months, even with having brain secondary, having excision, brain tumor excision will give better quality of life and better survival, I believe. So, like the other condition, like all other parameters we have to take into consideration and see if the patient life expectancy is more than 6 months. This excision of the secondary will give better quality of life and better survival rates, I believe. Yeah.
But already femur other meds also there, sir, in this case.
I'm just telling.
Okay, sir.
Not in this case, but
usual.
Point taken, sir. I think the topic is done. So next we'll be going ahead with, thank you. Next we'll be going ahead with the interactive case discussion from the Department of Pulmonology, Yashoda Hospitals, Hyderabad.
Now we will move on to the speaker. Please come Yugandhar Bhattu sir to the stage, and I would like to tell the Karthik sir to give handover to the Yugandhar Bhattu sir. Now, I would like to invite Dr. Avinash Gadesha to give handover to the Dr. Satish Reddy sir. Dr. Subha Kalandena sir, please come. Now I like to invite Pramod sir to give handover to our chairpersons. Yes. Avinash Gadesh sir. Karthik sir. Vijay Kumar sir.
Okay, now I would just like to ask how many pulmonology PGs are here? Oh, good, great. And that's a good thing, you know, pulmonology people staying back. Very happy. And we actually have an interactive session, but we thought probably, you know, staying until 5 in the evening itself is, we should be more than happy for that. And I think in the interactive session, we'll put one full day of interactive session sometime, and then we'll discuss good cases. We are having very good cases to discuss. And we had this plan of, you know, giving a chest radiology book to all the pulmonary PGs who stay until the last. And with gumption again, I went to Paris Medical Book Center and and for these books, I request Dr. Yugandhar Bhattu sir to hand over the books. I would like to call one by name, first the PGs and then the doctors, and you know, yourself, doctor, come. Bhattu sir, come. Yeah, Dr. Asfaq. Yeah. Yeah. That's okay. Dr. Tasneem. Any other pulmonology PGs? Please come. See, this pulmonology book has a worksheet in it. Doctor? Dr. Shri Priya. Satish, please come over and hand over the books. Doctor? Dr. Anantalakshmi. Yeah. Yourself, doctor? Dr. Jashwant. Doctor? Arun Kumar. Oh, I think you are one of the first persons to message me in the first 10 or 15. Yeah, good. Okay, yeah. Doctor?
Srivan.
Yeah. Dr. Manasa? Dr. Suma? Dr. Sairam, sir? Yeah.
We have Indian Lung Cancer Study Group. I am executive member of that group. I request all of the people, please become member of Indian Lung Cancer Study Group. We are doing lot of activities on behalf of Indian Lung Cancer Study Group. I request all the people to become member of this group.
If any information forward to us.
Yeah. I'll send the forms. Thank you.
Thank you, sir.
Yeah, please come by 1 minute. Snigdha. Sumant, Dr. Sumant. Please come. Srinivas. Thank you, sir.
I'm probably one of the oldest persons here. And I'm junior to Dr. Vijay Kumar by 5 years, 5-6 years.
Sir, Ahmad, sir. Ajit, come.
He is our critical care president.
Pulmonologist. Vijendra, sir.
Dr. Vijendra Raju is a 7-year-old pulmonologist doing international pulmonology fellowship at our center. If anybody is interested in chest radiology, they can come. Or else, Dr. Kirti, you're not interested in radiology anymore. You had enough of radiology today. No, I've done.
Excuse